Well, I'm a respiratory physician, but I did notice that when I was younger, I was getting a lot of patients referred who had heart disease, and we noticed they have a very high prevalence of sleep apnea, much higher than the otherwise healthy population. So, for example, patients with heart failure have about a 40 to 50% prevalence of sleep apnea compared to about 5 or 10% in the otherwise healthy population. So that got me excited, making me wonder, maybe the sleep apnea is having an adverse effect. And it turns out it does have adverse effects, and independent studies, prospective epidemiologic studies show that sleep apnea is a risk factor for hypertension, stroke, and heart failure, and to a lesser extent coronary disease. So that got me excited and started me in the field of looking at the physiology of how sleep apnea interacted with heart disease and how treating it might improve outcomes. And that's kept me going for the last 35 years. And so making observations in a field like medicine and following them up gets me excited. And I can tell you, in the 35 years I've been working as in the medical field, my area, I've never had a single dull day, not one. And the other thing that gets me excited is getting young people involved in the research and seeing them grow up and do well. So many of my fellows, I've had 42 of them, are now heads of their departments. They're doing research in the area as well, and this makes me get out of bed in the morning. Well, first of all, you've got to be prepared to do a lot of hard work. This is not a 9-to-5 job. You will not discover major things by working 40 hours a week, number one. Number two, don't pursue things unless you're really committed to it and you get excited about it, because it can be very frustrating if you're not. You have to have a passion for this sort of thing. What I mean by that is in medical research, right? To me, doing medical research and getting paid for it is like sending a kid into a candy shop, because you get paid to do what you love to do, right? And to me, that's a luxury. The vast majority of people don't have jobs like that. So medicine is a fantastic field. Medical research is even more fantastic. So for young people wanting to get interested in this field, get interested in it with a passion, because if you do, it can be the most exciting career you can have. So my name is Dr. Douglas Bradley. I'm a professor of medicine at the University of Toronto. I'm the former director of the Division of Respirology for the University of Toronto. I also run the sleep medicine programs at the University Health Network in Toronto. Well, prior to the trial that I just presented, there was evidence from smaller trials, many of which were done in my laboratory, that treating both obstructive and central sleep apnea improved cardiovascular function by increasing ejection fraction, reducing sympathetic nervous system activity, and also there's evidence that it improved exercise tolerance on the 6-minute walking test. So there was a number of physiological factors that improved that would suggest that it might improve mortality and hospitalizations as well. Study device is called adaptive serval ventilation. Basically, it's like a pacemaker. So if you're stop breathing, if you stop breathing, you have a central apnea, the machine will ventilate you, okay? If you don't stop breathing, it just provides a low background pressure but doesn't ventilate you. If you have obstructive sleep apnea, it increases the pressure, the background pressure, but it doesn't ventilate you, but it just raises the pressure enough to keep the airway open. So it treats both central and obstructive sleep apnea. The device we used is made by Philips Respironics, and it's triggered by what's called peak airflow. So that means that it's aiming, if the peak airflow drops below a certain point, it will start to ventilate you or to treat your obstructive sleep apnea, depending upon which type of apnea you have. It's different than the device used in the SERVE trial. The SERVE trial used a device that was triggered by minute ventilation, and it was a more aggressive device with higher background pressures. And in the SERVE HF trial, which was published in 2015, they found that that ventilator actually caused an increase in mortality, and therefore it's not used for that indication anymore. So that's the device that we use, and it's different from the other one. The study population was men and women, adults, with low ejection fractions, below 45%, with a history of heart failure, who were on stable medication and were stable clinically. So basically that's the population we aimed for, yeah. Key findings were that in 731 patients that we analyzed, The group randomized to the device had a marked reduction in their apnea-hypopnea index, so it completely got rid of their sleep apnea over the entire 5-year course of the trial. And it didn't matter whether they had obstructive or central. It treated both. However, there was no significant difference in the primary endpoint, which was the combination of cardiovascular hospitalizations, death from any cause, atrial fibrillation, new onset atrial fibrillation, and ICD discharges. There was no significant difference between the two groups. And it didn't matter whether they had obstructive or central. It didn't make any difference. On the other hand, it didn't cause any harm, so it's unlike SERVE, in which patients actually had a higher mortality. In our trial, they didn't. If we looked at mortality alone, there was no significant difference, again, between the two groups, either obstructive or central or the whole group. On the other hand, in the central group, we had fewer patients than we had anticipated, because in 2015, when the SERVE trial results were published, regulatory authorities in Germany and France disallowed enrollment of patients with central sleep apnea, despite the fact our Data and Safety Monitoring Committee had seen no safety signal at all. So they overruled our Data and Safety Monitoring Committee. So there's a major ethical problem here. And as a result, instead of getting 430 patients with central apnea, we only got 198. In that group, there was a trend towards a lower mortality. The hazard ratio was 0.78, which means a 22% reduction in mortality rate, but the p-value was 0.34, so it wasn't significant. On the other hand, that difference between the two groups is a difference we predicted when we created the sample size. So the conclusion then would be that there's no indication to treat, oh yes, sorry, the other point was the patients with obstructive apnea had to be non-sleepy, because if they were sleepy, they would have an indication to be treated. So in non-sleepy patients with OSA, there's no indication for them to be treated if they have heart failure, because we don't have any indication that it improves their outcomes. In the central apneics, there's a trend towards improvement, but not significant. So there's no indication, therefore, to treat them either. However, the quality of life data have yet to come out, and if the quality of life data show an improvement, and we've shown that the device is safe, then there may be an indication to treat people who have bad heart failure that's relatively refractory to drug and device therapy. I don't, at the moment, with the fundings we have, I don't think it will have a big impact, except that cardiologists will be more reluctant to send patients for sleep studies, because we don't have any evidence that treating the non-symptomatic patients with obstructive sleep apnea does any good. Similarly with the central apnea, again, depending upon what the quality of life data show, I don't think it's going to have a major impact there either. The major impact is that we do show that there's no harm, but we also show that there's no statistically significant difference in the major outcomes. Well, in the central apneics with the device we used, again, there's a signal there, it's just not significant. The problem is funding these trials, right? So these trials are funded, in this case, by Philips Respironics and by our Canadian Institutes of Health Research, by a peer-reviewed grant. But we don't have the kind of money that pharmaceutical firms have. And so it's very difficult for us to do studies with thousands of patients, because we just don't have the money. If I had the money, I would have extended the trial in the central apneics, because we still have equipoise there. And if we got 400 or 500 patients, we might see a difference. So if somebody wants to do it, I'm near retirement, so it's not going to be me. But there is a signal there, and if somebody wants to follow that up, they should do that. But I suspect they're going to have a hard time getting funding for it.
So I think cardiovascular science, there's a lot more to discover about how we can optimize treatment for patients with cardiovascular issues. I think prevention is the key thing for the future. We want to prevent people having the outcomes in the first place. Now, some of that is lifestyle, but some of that is pharmacological management. And in my own field, I try and prevent the outcomes before they happen by treating people's blood pressure well and treating lipid issues and giving lifestyle advice. So cardiovascular medicine and research is a really exciting field. There's so many different avenues you can explore. A lot of people have said to me since my hotline and presentation at ESC that it's so nice to see a female presenting as the chief investigator of a large randomized trial. And I would totally encourage other young investigators out there, male and female, to do this sort of thing, because you can really make differences to patients' management. And running a clinical trial, as well as being very hard work, is a lot of fun. And it's incredibly satisfying to reach the end of a 10-year project and get an outcome that you can be completely confident in and that will inform practice. So go for it. I'm Professor Isla Mackenzie, and I'm Professor of Cardiovascular Medicine at the University of Dundee in Scotland. So allopurinol is a xanthine oxidase inhibitor, and we normally use it in patients with gout to lower their uric acid levels and to try to prevent acute gout flares. But for many years, the question has been around as to whether it might have additional benefits in cardiovascular disease. So various small studies over the years have suggested it improves certain cardiovascular parameters, but until now there's never been a large outcome study like ALL-HEART. So the ALL-HEART study was a large prospective randomized open-label blinded endpoint or probe trial. It was a multi-centre trial done across the UK, so in Scotland and England, in 424 general practices. We didn't include patients with severe renal impairment. We didn't include patients with class 3 or 4 heart failure. And patients in the study were all aged over 60 with ischemic heart disease. We also excluded anyone with a history of gout and anyone who was already on urate-lowering therapy. So the study randomized patients with ischemic heart disease to receive allopurinol 600 milligrams daily or usual care. And what we found was there was actually no difference in the primary outcome, which was non-fatal MI, non-fatal stroke or cardiovascular death. There was no difference between the allopurinol arm and the usual care arm of the study. We also found no difference in the range of secondary outcomes we had, so MI, stroke, cardiovascular death, all-cause mortality and various other cardiovascular outcomes. None of them showed a difference. So it was a definitively negative trial. So I think that we have answered the question of whether patients with ischemic heart disease should be given allopurinol to try and prevent future cardiovascular outcomes. And I think definitively we've said no. And that's important because there have been individual patients and doctors around who have thought that that might be the case, that maybe they would benefit from the treatment. We haven't specifically looked at hyperuricemia, but that's another area where it's unanswered, whether they have any benefit in asymptomatic hyperuricemia. So I think at the moment, the only benefit that we know of is for patients who have gout.
I'm Jeffrey Weitz, Professor of Medicine and Biochemistry and Biomedical Sciences at McMaster University and Executive Director of the Thrombosis and Atherosclerosis Research Institute. I will be presenting the results of the axiomatic total knee replacement study. This study is a phase 2 dose-ranging study comparing oral milvexian with enoxaparin for postoperative thromboprophylaxis in patients undergoing elective knee arthroplasty. This study was undertaken to test the hypothesis that milvexian reduces the risk of venous thromboembolism after elective knee arthroplasty. Milvexian is a small molecule inhibitor of factor 11A. It is orally available and is rapidly absorbed after oral administration with a time to maximum concentration of about 2 to 4 hours. It has a half-life of about 12 hours. It is metabolized in the liver, and about 20% is excreted through the kidneys. The purpose of this study was to determine whether milvexian has antithrombotic activity in patients undergoing elective knee arthroplasty. This study was a phase 2 prospective parallel group adaptive design trial comparing 7 different dose regimens of milvexian with enoxaparin for postoperative thromboprophylaxis in patients undergoing knee replacement surgery. So patients were randomized to receive milvexian in once or twice daily dosage regimens ranging from 25 milligrams to 200 milligrams, or to receive subcutaneous enoxaparin. The treatments were given for between 10 and 14 days, at which point all patients underwent mandatory venography of their operated leg. And the primary efficacy outcome was any venous thromboembolism, which was defined as asymptomatic deep vein thrombosis that was detected on the mandatory venogram, confirmed symptomatic deep vein thrombosis or non-fatal pulmonary embolism, or death from any cause. The principal safety outcome was any bleeding, the composite of major, clinically relevant, non-major, or minor bleeding. We also looked at clinically relevant bleeding, which was defined as the composite of major or clinically relevant non-major bleeding. A priori, proof of efficacy was defined as showing either that milvexian reduced the rate of postoperative venous thromboembolism to less than 30%. The 30% was chosen as a benchmark because it's a conservative estimate of the rate of venous thromboembolism without thromboprophylaxis in patients undergoing elective knee arthroplasty. And the second criterion was to demonstrate a dose-response relationship in terms of the rate of postoperative venous thromboembolism with twice daily milvexian regimens. And the study met both efficacy criteria. The rate of venous thromboembolism with the combined twice daily milvexian regimens was 12%, which was significantly lower than the 30% benchmark. And there was a significant dose relationship with both twice daily milvexian and once daily milvexian. And the study evaluated milvexian regimens ranging from 25 milligrams to 200 milligrams, given either twice daily or once daily. With daily doses of milvexian of 100 milligrams or more, the rate of venous thromboembolism with milvexian was significantly lower than that with enoxaparin. And most importantly, over a 16-fold range of milvexian doses, from total daily doses ranging from 25 milligrams to 400 milligrams, the rates of any bleeding were 4% with milvexian and 4% with enoxaparin. Rates of clinically relevant bleeding, which was defined as the composite of major or clinically relevant non-major bleeding, were 1% with milvexian and 2% with enoxaparin. There were no major bleeds with milvexian. There was one major bleed with enoxaparin. So over this very wide range of milvexian concentrations, there was no dose response in terms of bleeding, but there was a definite dose response in terms of efficacy with significant reductions in the rate of venous thromboembolism with milvexian compared with enoxaparin. And enoxaparin is the standard of care in many centers and in many countries for postoperative thromboprophylaxis in patients undergoing knee replacement surgery. The take-home message of this study is that milvexian is an effective antithrombotic agent that reduces the risk of postoperative venous thromboembolism after elective knee replacement surgery and is associated with a low risk of bleeding. The next steps with milvexian are to assess its safety, not only in this population, but also its safety as an add-on to single or dual antiplatelet therapy, and to evaluate this, a second phase 2 study evaluating milvexian compared with placebo on top of antiplatelet therapy in patients with non-cardioembolic stroke is underway. The axiomatic secondary stroke prevention study, and will report out sometime next year.
Dear colleagues, ladies and gentlemen, welcome to the view of the Thorax Center for Radcliffe Cardiology. My name is Nicolas van Michem, and together with my friend and colleague Joost Dame, we will review the late-breaking trials for the upcoming ESC 2023 meeting in Barcelona. Without further ado, let's start with the late-breaking trials on coronary revascularization, Joost.
Yeah, so welcome everybody. So there are 3 trials on coronary revascularization that at least stood out to us that we would like to discuss with you. One is the revived BCIS2 trial. So this is a multi-center randomized controlled trial from the UK to evaluate whether PCI plus optimal medical therapy will reduce all-cause death and rehospitalization for heart failure as compared to optimal medical therapy alone at 2 years in patients with ischemic cardiomyopathy. So this prospective trial will enroll 700 patients with stable ischemic cardiomyopathy with a definition of an ejection fraction below 35% and extensive coronary artery disease, and importantly also proven or demonstrable myocardial viability. To me, an interesting trial because most recent European guidelines on heart failure, as you may remember, provide a class 2A recommendation for revascularization in general in these patients in order to improve symptoms. However, a class 2B indication with respect to improving outcome and then even suggest a preference for surgical revascularization. So in that perspective, I think this trial definitely will add to the body of evidence on the value of coronary revascularization in patients with ischemic cardiomyopathy, and has the potential to change the future guidelines.
I think it's a very interesting trial, but I'm a little bit well, not disappointed, but why so much emphasis on myocardial viability? Because we already have the STITCH trial with 10 years results that tells us that in patients with ischemic cardiomyopathy, if you have a poor LV, it doesn't matter whether there is viability, yes or no, in terms of long-term outcome. It does matter if you want to look for improvements in ejection fraction.
Yep.
We know from STITCH that if there is viability, then your ejection fraction will improve, but it will not affect the outcome in terms of mortality. So that said, I think STITCH obviously was a surgical trial. That is why the guidelines also keep referring to CABG in the context of ischemic cardiomyopathy. And I do believe that this is a valuable trial, and I hope that PCI will prove beneficial in this setting. Obviously, it's also of interest to learn what the quality of the PCI is. Will they do coronary physiology? But more importantly, I believe, is there also invasive imaging involved to have optimal results?
Yeah, and the goal to go for complete revascularization. I think that is tremendously important. And with respect to your comment on viability, I totally agree. And that was, I think, also one of the key criticisms to STITCH, that a lot of the viability testing was done with SPECT and might have shown some balanced ischemia or negative findings that perhaps, were not really accurate.
Yeah, well, but in my practice at least, I also try to interpret the echo imaging. Obviously, when there is a very thin ventricle, then you may ask yourself whether it's worthwhile. But if there is only hypokinesia, and you do see some muscle in the territory, in the affected territory, then I think it's a good idea to proceed with revascularization. So hopefully this becomes a positive study in favor of multivessel PCI in ischemic cardiomyopathy.
Yep. So then the second trial that we would like to highlight is, at least to me, one of the perhaps most interesting trials of the upcoming meeting, at least from an interventional perspective. And that is the FRAME AMI trial. So this is a multi-center randomized controlled trial from South Korea to compare clinical outcomes following FFR-guided or angio-guided revascularization of non-infarct-related arteries in patients presenting with acute myocardial infarction. So this randomized trial aims to enroll 1,300 STEMI patients with at least one non-infarct-related artery with at least 50% stenosis, with a primary endpoint of death, repeat MI, or repeat revascularization at 2 years. As mentioned to me, this is one of the perhaps most interesting trials, specifically in light of the recently presented and published FLOWER MI trial that addressed the same question, but was actually completely negative. I still believe in the concept. I do believe that physiological guidance of non-infarct-related arteries could be beneficial. But the likelihood that this trial will be positive, at least to me, is based completely on the aggressiveness on complete revascularization. How aggressive will these operators be in order to treat everything that is above 50% in the angiographic arm? Because what we've learned is that the key benefit of FFR is in detecting those lesions that were visually perhaps not that severe, but were in fact physiologically positive, because those are the lesions that will make the difference in the event rates, and not the lesions with that are FFR positive and will get treated anyway.
So if you do not treat them, right?
If you do not treat them, yes.
So my gut feeling is also that this might become a negative trial for the reasons that you mentioned, and the cutoff for angiographically significant stenosis of 50%, that is maybe a little bit pushing it towards too much, pushing it too far a little bit out. I think I would call a 70% angiographic stenosis more realistic. 50% is really trivial in my opinion. But I agree, the evidence to back up coronary physiology, hyperemic coronary physiology in non-culprit vessels in patients with STEMI is not that solid. So if that is also a negative study, well,
yeah,
we may question.
Yeah, absolutely. And then the final trial within this topic that we would like to cover is the pre-18 FFIR trial. So not really a trial on coronary revascularization, but actually an imaging trial on PET-CT. So this is a prospective observational trial from the UK to assess whether what is the value of the PET tracer 18F sodium fluoride as a marker of coronary plaque vulnerability to detect culprit and non-culprit unstable coronary plaques in patients with the recent MI. So the trial is a prospective trial that will enroll 700 patients that will be enrolled within 3 weeks post-acute MI and angiographically proven multivessel coronary artery disease. This trial has a clinical primary endpoint, which is a composite of cardiac death, non-fatal MI, or unscheduled revasc at 2 years. The marker is not so novel. The marker has been validated and tested already in a Lancet study from, I think, 8 years ago. It's an interesting concept, but I'm not quite sure how these results should be interpreted because of the fact that these scans will be obviously performed post-revascularization. So many of these potential unstable lesions will already have undergone either stenting or CABG. So yeah, I'm curious to learn the exact methods of this trial during the presentation at ESC, but I think something conceptually interesting that is worthwhile to look out for.
Yeah, definitely, I agree.
Good, pharmacotherapy, several trials that we would like to highlight.
Yeah, the first one is ASCENT, and ASCENT, it might sound familiar, it was already published in the New England Journal 4 years ago. Basically, it is a huge trial, more than 15,000 patients with diabetes in the setting of primary prevention were randomized in a 2x2 design, either to aspirin or no aspirin, again, in primary prevention, and then secondly, also to the use of omega-3 fatty acids or no omega-3 fatty acids. In the New England, they already published the data on the omega-3 fatty acids that was negative. Now, I assume we will hear about the effects of aspirin in primary prevention of patients with diabetes. We'll see. I don't have too high expectations. I'm not sure whether this will become a positive study. I think over the years we have seen a clear decay in the importance of aspirin. Maybe this trial will also fit in that series of studies. So let's see what it will bring. An interesting co-primary endpoint is the major bleedings, because you know, we are used to saying to our patients, well, these very low doses of aspirin, it's not nothing, so if it doesn't work, at least it's not harmful. Well, maybe we will see a signal of harm. So I think this trial will add some evidence in favor or not in favor of aspirin in primary prevention in a high-risk patient population.
Yep, I agree. It's an interesting concept that has not been fully addressed specifically in these high-risk patients. So I think it will be interesting.
So I mentioned already the omega-3 fatty acids, and somehow I hope to find a study that somehow will be beneficial, because it is an attractive pathway, I believe, and it is a therapy with hardly any side effects. So if it might be beneficial, I think it would be accepted by the community, but it's so damn difficult to find a positive study. Well, there is Reduce IT that will be presented by the inevitable Deepak Bhatt, because Dr. Bhatt, he is presenting late breakers at every ACC and ESC, so also in 2022, and now he will present Reduce IT. And it is a randomized controlled trial enrolling more than 8,000 patients over a time period of 7 years and more than 400 sites. So it's a huge study. Patients are followed up for at least 6 years, and the primary endpoint is any serious event. And patients are randomized to either normal therapy, including statins for patients with at high risk with mixed dyslipidemia, but then they are randomized to either icosapent-ethyl or placebo. And what is this icosapent-ethyl? This is a purified ethyl ester of one of the omega-3 fatty acids. So this is the next shot at a positive study for the omega-3 fatty acids. I'm rooting for it, so let's see what happens at the ESC.
I have nothing to add to that.
Okay, let's go to the Pacific AMI.
Yeah, so perhaps a bit more common ground concept is the Pacific AMI. So this is a multi-center randomized controlled placebo double-blind dose-finding study, so phase 2 trial actually, to evaluate the safety and efficacy of a novel factor 11A inhibiting agent called asundexian in patients following acute MI. So this is a trial that will enroll 1,592 patients within a 5 days post-MI who will be randomized in a quadruple fashion to either 3 doses of this novel factor 11A inhibitor or placebo on top of dual antiplatelet therapy being aspirin and clopidogrel. The trial has 2 co-primary endpoints. One is an ischemic one, being CV death, MI, or stent thrombosis within 1 year. And the second co-primary is obviously bleeding, being BARC type 2 305 bleeding. I think interesting, the trial makes me remember a little bit of the period when we saw Atlas 15 years ago with rivaroxaban on top of aspirin and clopidogrel, also showing potential benefit in terms of ischemic endpoints, but for sure a higher risk of bleeding in a drug that finally never found its way into routine practice for the treatment of patients post-MI. I don't know whether the same fate will happen to this agent, but yeah, it's again another pathway that is being explored with this novel drug. We'll see.
Yeah, but without knowing the granularity of this study, this is 2022. Why are we talking about DAPT with aspirin and clopidogrel after an AMI? I think that is a little bit old school. I think we are beyond that, at least in patients who do not need oral anticoagulant drugs. So that is a little bit a limitation to me, especially if we want to extrapolate it in the short term to our current practice, because we are now using ticagrelor or prasugrel in combination with aspirin, and then by doing so, we're also looking at schemes to reduce DAPT duration. So instead of adding more anticoagulants or antithrombotic therapies to DAPT, we are thinking about moving towards single antiplatelet therapy. So for me, I'm not so intrigued by the concept at this point, but we'll see what happens.
Yeah, I agree. I have mixed feelings. I think at present we are more looking into how to downgrade antithrombotic therapy. That is a certainty now with COMPARE-STEMI-1 upcoming, etc. There's a lot of trials looking into the value of the monotherapy post-ACS. Most of these most recent trials demonstrated similar ischemic risk rates with a reduction in bleeding. But on the other hand, I mean, there's still a substantial risk of ischemic events in patients post-MI. And there hasn't been any novel agent that has been consistently shown to be safe, but also substantially reduce ischemic events in those high-risk patients. So who knows? I'm not too negative, but yeah, we'll see. Structural heart, 2 trials that we wanted to highlight.
Yeah, one of them is the COAPT continued access study. Well, we are all familiar with the success of the COAPT study that was presented a couple of years ago at TCT following the MITRA-FR study on the value of MitraClip in patients with functional MR in combination with LV dysfunction. COAPT was a positive study, so patients were doing better at 2 years in terms of the combined endpoint of mortality and rehospitalizations. Well, now we're going to see how MitraClip is behaving in the continued access study following COAPT. Well, there are several unknowns for the presentation. What is going to be presented? Is it specifically and only the continued access population, or are the continued access patients on top of the patients in the randomized controlled COAPT trial? But I do believe that we will see a larger patient population, obviously, and so hopefully the study endpoints and the signals that we see in terms of outcome will be more robust because of the higher patient population. So I feel that this is a relevant add-on to COAPT. At the same time, I also want to caution on the over-interpretation of COAPT, because we had stringent inclusion-exclusion criteria. There was a screening committee that screened a lot of patients out of the study.
Yeah.
So the reproducibility and the applicability to everyday practice is a little bit in doubt, in my opinion. But then again, that is maybe also a good argument in favor of a continued access. Hopefully this steering committee is not involved, so that it becomes more reflective of common practice.
I think it will be a tremendously important data that will provide definitely more heterogeneity in the treatment effect than as was shown with COAPT. And that might be very positive, but could also point in a direction with let's say efficacy figures that are perhaps less pronounced than in the randomized arm. So we'll see.
Yeah. Another trial that we wanted to highlight is data derived from the National Echo Database of Australia. A couple of years ago, that same database was used to illustrate the importance of moderate aortic stenosis. So that study back then illustrated that moderate aortic stenosis basically in the long run had the same outcome as or similar mortality rates, almost similar mortality rates in patients with severe aortic stenosis. So that already was a little bit undermining the paradigm of moderate aortic stenosis being harmless. Obviously, we are heavily involved with the concept of treating moderate aortic stenosis in the context of patients with depressed LV function in TAVR Unload, and there is now also the PROGRESS trial, where we are moving on from the ejection fractions and go to the cardiac damage model. Well, now the same echo database of Australia is being used to see whether artificial intelligence can be helpful in identifying the patients with aortic stenosis who are also at risk for events. So you can expect hundreds of thousands of patients, so multiple hundreds of thousands of patients, and then they will implement an artificial intelligence program on that data set. And what is interesting is that this program will specifically not look at LVOT measurements. And obviously we are all familiar with the limitations and the restrictions of echocardiography, and some of these limitations are related to the difficulties related to LVOT dimensions and also LVOT velocities. So once you make a mistake there, then the entire measurement of your valve areas will be jeopardized. So I think if this study can show that by artificial intelligence you don't need LVOT to identify the patients with severe aortic stenosis who will get the events down the stretch, I think that is progress, and I think that also really fits in the time we're living, 2022. Artificial intelligence, it remains a hot topic in digital health and in medicine in general.
Yeah, I agree. I think the size of this program is enormous, and that I think adds to the validation of all these AI algorithms that are typically being tested in 200-300 patients, and then might conceptually point in a direction, but do not have the power to impact any of our practices.
This
in
is
this
next
case,
level.
It's next level. Yeah. But yet, I haven't seen that many AI studies that really came up with findings and clear cutoffs that we're currently using. So I think it's work in progress, and this is probably a very good example on how these data can be used.
But the interesting aspect of this study will be the uncoupling from the LVOT.
Exactly.
Right? And that is quite intriguing.
Yeah.
Okay, maybe we wrap up with some hypertension.
Yep, as usual, we picked one trial on at least one of my favorite topics is hypertension and renal denervation, and that's the PHYSIC trial. So PHYSIC, I will try to explain to you. It's a little bit of an uncommon concept. So with a double-blind, randomized, repeated crossover design, this PHYSIC trial aims to investigate if there's a consistent between patient variation in blood pressure response to common blood pressure lowering agents. So the trial will enroll 300 patients that will have mild hypertension and will be treated with 4 blood pressure lowering drugs, being amlodipine, lisinopril, hydrochlorothiazide, and candesartan in monotherapy, with 2 of the drugs being repeated for each patient. So this trial will look into the predictors of the effect of each of the individual drugs in all these individual patients in terms of blood pressure lowering efficacy. The trial will look into side effects generated by each of these 4 different classes of antihypertensive drugs, and will also provide a biomarker panel for each of these patients in order to be able to, by doing these biomarkers, perhaps identify potential triggers that could help us in the future to select certain types of patients that either do respond or do not respond to each of these 4 classes of antihypertensive drugs, or might be more prone to side effects, which then is the common predictor of having non-compliance, which is at present, as we know, one of the key predictors of poor blood pressure control. So a very interesting concept in a trial with a unconventional design that to me will be of interest, and if positive and if some clear findings will emerge, these data could really help us to better tailor antihypertensive therapy in those patients.
But don't you think that there is a sample size issue here? 300 patients to address all these questions?
Yes, but all these patients will get these 4 agents during a certain period of time. So you will get, I think, a relative representative sample of side effects and of common side effects. Obviously not the side effects that will emerge in 1 out of 1,000 patients. But that already, I think by itself is already interesting.
But then again, to see the differences between the several different drugs in only 300 patients?
I agree, the sample is small, the concept of interest, and you might be right that this trial comes up with several hypotheses that will then be further tested in a larger trial. Could well be.
So, and then the elephant in the room, where is the renal denervation then?
So, that's a good point. No renal denervation, big trial at ESC, but what I can introduce already is that at TCT, the final results of the Radiance 2 trial on ultrasound renal denervation will be presented. So that is something to be covered within one of our upcoming previews. Yeah. But thus far, our preview for ESC 2022.
This is it for the preview of ESC 2022. Jos and myself, we will attend the ESC meeting in Barcelona. So expect from us a wrap-up the week after ESC. Thank you very much for attending.
Thank you for watching. Bye-bye.
Bye.
Hello, I'm Dr. Mirvat Al-Asnaj. I'm an interventional cardiologist at King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. I'm also an editor at the US Cardiology in Review and a member of the Society of Cardiovascular Angiography and Interventions Board of Trustees and the ACC Interventional Leadership Council. I'm here with Dr. Michael Mack, who is a cardiac surgeon and the chair of the cardiovascular service line at Baylor Scott and White Health and the president of the Baylor Scott and White Research Institute in Dallas, Texas. Also with us today is Dr. David Cohen. He is an interventional structural cardiologist at St. Francis Hospital in New York. And he also serves as the Director of Clinical and Outcomes Research at the Cardiovascular Research Foundation. We're here to discuss how guidelines are constructed and elaborated. Gentlemen, thank you for joining me today.
Thanks for having us, Marvat.
There have been lots of discussions on the process that is undertaken to select and elaborate guidelines. I'd like us to address this today. And so to start off, Dr. Mack, how is the evidence base used as the foundation of guidelines that are generated?
Well, I think there's multiple answers to that, Marvat. You know, the first of all is that the guidelines are just that, guidelines. They aren't strict mandates, but they're meant to to provide guidelines to clinical practice and clinical judgment in practice. They are totally evidence-based, and what that means is they're based upon a broad and in-depth review of the evidence in the peer-reviewed published literature to inform clinical practice. For each guideline, for at least for the American guidelines, the ACC AHA guidelines, a joint committee of clinical practice guidelines appoints a panel of experts who are multi-specialty in various aspects of the disease for which the guidelines are being written. Then the peer-reviewed literature is reviewed for all publications relevant to the subject, including a number of relevant keywords to it. A guideline committee is convened based upon experts in the area representing multiple specialties. There are considerations made to multiple aspects of composing that committee, including demographics, diversity, relationship with industry, specialties. Once those are convened, the committee meets, and it's a very in-depth process looking at the previous guidelines, what need to be updated, what new evidence has been generated, and then what that level of evidence is that justifies a change to the guidelines or continuation of the same and previous recommendations.
Thank you. And that really takes me to the next question. Dr. Cohen, how can appropriate representation be guaranteed in such documents, particularly diversity of expertise and affiliations and so on?
Right. Thanks, Mirvat. That's a great question and a good follow-up to Mike's initial comments. Clearly, diversity in a variety of factors is critical these days when you're making something that is as political and potentially contentious and challenging as guidelines. And so I think that needs to be a strong consideration. There are many different ways that can be achieved right now. Most of the guidelines try to do that through the selection process of the members, which usually is directed by the chair and the co-chair of the guideline committees. But I think what's really important is you can imagine that there are many different domains on which one could try to achieve balance and representation. Could be gender, could be minority groups, could be different specialties, could be geographic or even career stage. All of these things are very relevant when one is selecting a guideline committee. Obviously, with unless you're going to have committees of 50 or 100 people, which are unworkable for a variety of other reasons, one may not be able to achieve ideal balance on all of those different factors. So to me, one of the keys is to have some guidance on really some parameters that we want to achieve when establishing these groups, something that comes from the leadership of this, the societies, or even from the membership, what do we value? What is the most important thing to balance? Should it be the specialty that the people are doing? What is the next most important? Because you're never going to have 50-50 on all different parameters. So we have to have some priorities and make sure that we achieve those. And then there can be other parameters that may be secondary, where there still is some interest in achieving diversity, but perhaps it's a little less mission critical. I think right now it's clear that we need to have absolutely need to have different specialties because they have different views of the patients. I think we ideally need to have different genders and racial diversity, and then everything else maybe is a little bit less less mission critical. I think one of the interesting questions which has come up in a lot of recent discussions is, what is the role of the patient? Should there be patients on the guideline committees? And I think that's a really interesting question. I haven't seen it yet, although I'm certain that there probably are some that I just don't know about that have had patient representatives. It's a very interesting topic of how do you integrate patients, who are obviously the goal of guidelines is to care for patients better. But how do we integrate them into the process?
Dr. Mack, you had a follow up on that?
Yeah, a couple comments. First of all, Dave, there was a patient representative involved with the recent 2020 valve guidelines. That was very helpful to have involved in the process. And then secondly, to assure that the diversity of opinion and that the evidence base is appropriate, all the guidelines, once they're written, undergo a peer review process. And there are two lead reviewers, one from ACC and one from AHA, and then multiple sub-reviewers to it. And one of the reasons for the delay or the time that it took to get the recent guidelines out is there were over 1,000 peer review comments to the valve guidelines, each of which had to be answered specifically. So again, there's a lot involved in making sausage. It's not all pretty, but it is onerous. It requires a lot of commitment, especially on the leaders of the guidelines.
Thanks for clarifying that, Mike. It is an enormous undertaking. That's clear.
It is, absolutely. And I think what probably makes it more difficult is we want to keep guidelines current and a reflection of the most recent evidence, so more contemporary living document. And it does take quite some time to elaborate a single guideline document. So how can we do that, Dr. Mack?
So the ACC-AHA Guidelines Committee updated the format, I believe, starting in 2016. They went to something called knowledge chunk format. Previously, when you had guidelines written, the whole guideline had to be updated. It then progressed to what are called focused updates. So for instance, if we take valve guidelines again, the last full guideline was in 2014. There was a focused update in 2017. This time, the 2020 guidelines, it's in this knowledge chunk format to create exactly what you're alluding to, which is a living document. So if there's new, clear evidence that mandates a change in the recommendation, that is constantly monitored and can be updated on an as-needed basis based upon the review and opinion of the guidelines committee. Now, this is, I think, the third guideline that this is being incorporated into, and whether it really works as well and as expeditiously as designed remains to be seen. But I think everybody is dissatisfied with how quickly the guidelines become outdated.
Yeah, absolutely. And, Dr. Cohen, I'll go to you now. Dr. Mack just explained to us the process for the American guidelines. Do you, as somebody who
I am myself an early career research fellow, and I think the key thing that I would advise is if you can find opportunities in your local trials units or even within your universities, if there are larger trials units where you can get some experience with randomized trials, that's probably the best place to start. Because rather than attempting to conduct smaller trials on your own to learn about trials, working with a large trials team will help you to understand how trials are conducted and designed, and understand the methodology better. And I think that is your stepping stone towards getting into the big trials scene, which is where all the action is. I think over the last few years we've seen a lot of interesting new therapies being developed and rolled out, and we've seen very well conducted large-scale randomized trials providing us with excellent information. Looking at the series of studies that were published on the SGLT2 inhibitors, and more recently the PCSK9 program for LDL lowering. So these are all areas in cardiovascular research that have really filled me with hope that we are going to keep discovering and going to keep conducting trials in a way that we can bring lots of good treatments that are beneficial to patients worldwide. And I think that's quite exciting as a cardiovascular researcher. So my name is Michelle Gunasekara, and I am a clinical research fellow attached to the Nuffield Department of Population Health at the University of Oxford. I am a nephrology registrar by training, but I am currently working on cardiovascular trials, and that's me. So many people will be familiar with the original ASCEND study, which looked into the effects of randomization to aspirin versus placebo, and separately to omega-3 fatty acids versus placebo on atherosclerotic cardiovascular disease. So our study is a secondary analysis of that original study, looking into what the effects of these two medications are on heart failure. Because heart failure is a condition that affects individuals with diabetes in particular, and there are over 400 million people worldwide with diabetes, and there are doubts and uncertainties in the current research areas about what the true effects of aspirin and omega-3 fatty acids are on heart failure. So we are hoping that this study will add further information to that mix. The ASCEND study was a double-blind, placebo-controlled randomized trial which had a 2x2 factorial design, and we randomized people to aspirin versus placebo and separately to omega-3 fatty acids versus placebo, and that was a total of over 15,000 participants. We conducted our follow-up using mail-based follow-up methods, using questionnaires every 6 months. And importantly, we also had access to routinely collected data, which we used in outcome ascertainment, which I think is an important methodological piece of work that we did as well. And in terms of selecting the omega-3 fatty acid dose, at the time that ASCEND started, 1 gram was the dose that was in use, and we had evidence for, because I think studies like JELIS and GISI Prevention suggested that there could be a benefit of the 1 gram dose of omega-3 fatty acid, and which is the rationale for using it. And unlike the newer studies which are looking at the effects of triglyceride lowering, which was not a goal in ASCEND. So the primary outcome of our analysis is the effects of randomization to aspirin and separately of randomization to omega-3 fatty acids versus placebo on hospitalizations or death due to heart failure, with our key secondary outcomes being the individual components of the primary outcome. And for the aspirin result, we've shown that randomization to aspirin does not have a significant effect on the primary outcome of death due to heart failure or hospitalizations for heart failure. The rate ratio was 0.98, and our confidence intervals extended down towards a proportional benefit of 17% and up towards a proportional hazard of 17%. And there were no significant effects on the secondary outcomes of hospitalization for heart failure or death due to heart failure. For omega-3 fatty acids, there was again no significant effect of omega-3 fatty acids. The rate ratio for the primary outcome was 0.88, with confidence intervals here extending down towards a proportional 26% reduction and up towards a proportional 5% hazard. So in summary, there was no significant benefit. But for omega-3, we've ruled out any hazard, but there is a possibility of benefit as much as 26%, whereas for aspirin, we can't fully rule out small to moderate harm or benefit. I think now that there is a lot of different studies looking into this question of what the effects are on heart failure, the next step would probably be to undertake a more broad meta-analysis of all the data to try and see what the trend is based on all the different studies and whether it's confirmed in a final pooled result. And for aspirin, we don't really have enough data because we've got this study result that's come out, and then ASPRE, which is a trial of older adults looking into primary prevention, has published their results showing no significant effect. So those are the only two studies that are out there, and hopefully perhaps the ARRIVE trial also does some analysis on heart failure outcomes. We may have enough data to look into the question and answer it more definitively so that we can move on to other areas. I think with aspirin currently the problem is that we don't have enough benefit in the primary prevention setting that can counterbalance the increased risk of bleeding. So I think the key message here is that randomization to aspirin versus placebo did not have any significant effect on hospitalizations or death due to heart failure. But we couldn't rule out the possibility of a small to moderate benefit or harm. And for omega-3 fatty acids, again, we did not find a significant effect of randomization to omega-3. However, we've ruled out the likelihood of harm, but there is still the possibility of modest benefit that we haven't been able to exclude. Thank you.
I'm Harriet Vansball, Associate Professor of Medicine and Cardiologist for McMaster University in Canada, and I'm delighted to invite my friend and collaborator, Dr. Adrian Voors, Professor of Cardiology and Director of the Heart Failure Clinic at the University Medical Center Groningen in the Netherlands. We are here at AHA 21 to discuss his very impactful MPULSE trial. Welcome, Adrian.
Thank you. It's a pleasure to be here.
Oh, it's my honor. It's such a delight to see you, although not in person. We would like to start off inviting you to tell us about the rationale for this trial.
Yes, so MPULSE was designed to not only look at the chronic phase but acute phase. So we have seen EMPEROR-preserved, EMPEROR-reduced, DAPA-HF, all trials in the chronic heart failure world, both in HFrEF and in HFpEF. Then we had SOLOIST, of course, which was a more semi-acute heart failure trial, partly in hospital, partly post-discharge, but only in patients with diabetes. So we wanted to know two things: whether starting empagliflozin in hospital in an acute heart failure hospitalization would be beneficial by itself to give it during 90 days, but also is it safe to start a drug in a vulnerable patient with large volume shift, hemodynamic changes. So those were the main two questions we addressed in MPULSE.
Fantastic. What were your key eligibility criteria?
Yes, so patients needed to be hospitalized for acute heart failure. I think the positive thing about this study is it was an all-comer study. So it included both patients with acute de novo, so the first presentation of heart failure was actually this hospitalization, as well as patients with chronic heart failure who decompensated. It was with patients both with and without diabetes. It was irrespective of whether they had a left ventricular ejection fraction below or above 40 or 50. All patients were eligible for the study. The only thing is that they needed to be stabilized in a way that they didn't have signs of hypotension, no active vasodilators in the last 6 hours, no change in the loop diuretic in the last 6 hours, and no IV inotropic drugs in the last 24 hours. And of course, they needed to have elevated natriuretic peptides.
Was the expectation that empagliflozin might induce hemodynamic instability? One might purport that it might have actually improved some of the hemodynamics in patients with acute decompensated heart failure. What are your thoughts?
Yeah, great suggestion. So on the one, it's exactly what you're saying. On the one hand, there were concerns. I mean, here you are with a drug that does well in a chronic situation. If we think back a long time ago at Consensus 2, when we gave an ACE inhibitor early after hospital admission, it didn't go that well. So on the one hand, there's concerns to give a drug in a vulnerable phase. It's a risk. On the other hand, this drug actually could even provide more diuresis on top of loop diuretics. It could have other hemodynamic or metabolic improvements related to better outcomes. So it was exactly the reason why I'm saying it was both the intent to see whether it was safe on the one hand and efficacious on the other hand. So this was exactly the balance, as you described so well.
What were the baseline characteristics? Tell us about the demographics of your patients.
Yes, so patients were, mean was approximately 70 years. There was 1/3 female. I know, not enough. Should be at least 50-50. We both agree about this, but it was 1/3 females. 1/3 was acute de novo, and 2/3 were decompensated chronic. 46% was diabetic, and 1/3 of the patients had an ejection fraction of above 40%. So it was still, the majority was HFrEF.
And what were your key findings?
So the primary endpoint of the study was a clinical composite of a hierarchical composite of either death, a heart failure event, or improvement in KCCQ total symptom score. And it was scored as a win ratio. And the win ratio is at first sight might be complex, but it's actually very easy. The computer picks out one patient from the placebo group, one from the empagliflozin groups, and starts comparing this patient. And it first looks at whether patients are still alive. If there is a death in one group, then obviously the other group is the winner. If there is a tie, it goes to the next level. And the next level is a heart failure event. And it looks whether or not there had been an occurrence of a heart failure event in one of the groups. And if so, the other group was the winner. And if there was a tie, then in the end, it looked at the KCCQ total symptom score, compared both patients to each other, and looked whether one of the patients had at least 5 points or more improvement in the KCCQ total symptom score compared to the other one. So not compared to baseline, but compared to the other one. And then in the end, you can see that either empagliflozin is the winner, there could be a tie still, or the placebo is the winner. And what we saw from the primary endpoint, that in 53.9% of the cases, empagliflozin was the winner. In 39.7%, it was placebo that was the winner. And in 6%, there was a tie. So if you make a simple calculation, a quotation to that, you can see that the win ratio was 1.36 with a p-value of 0.0054, which means that patients on empagliflozin were 36% more likely to obtain a clinical benefit from empagliflozin.
Right. And then going through each of the component outcomes, I must say that I really loved the thought that went into this analytic plan. And I know there's been a lot of online discussion, but I thought that the hierarchy was so clinically relevant. And you included important endpoints that may not have necessarily been sensitive to the intervention, but were important. And you also set a threshold for the difference in KCCQE, which is much larger. It's the minimally clinically important difference, but much larger than differences seen in prior trials that tested SGLT2 inhibitors in the heart failure population. And of course, the win ratio allowed for inclusion of all of these relevant endpoints in a single primary endpoint. How do you set the alpha for each? What sort of determines that decision? Did you have stakeholders at the table, a variety of voices? How do you make that decision?
Well, that was not an easy one, and there's obviously more options, similar options. The thing is, we first of all, we wanted to have a relevant clinical endpoint. So it needs to be clinically meaningful. And of course, one of the comparators of our study was Pioneer, which was a very nice study, similar size, maybe even slightly larger, but primarily looking at NT-proBNP. And so this is not what we wanted. We wanted the clinical relevant endpoint. And then, of course, we had a big discussion of the components of the endpoint, especially the last one, because should it be a change in NT-proBNP as the closing one? But again, we wanted to have a clinically relevant, meaningful endpoints. And if you look at patients with acute heart failure, what's important for them? First of all, that they stay alive, that they don't get rehospitalized, and that they improve their symptoms. I mean, this is what it's all about. So that's made us think about the components. Now, more the statistical background of this is quite complex, also to calculate the alpha with simulations, and there's lots of simulations. You come up with a win ratio, but we might have chosen other ones, but because of the clinical background and the clinical meaning of the endpoint and the hierarchy that we chose, in combination with, let's be honest, a limited sample size of 530 patients, we came up with this one. But having said this, it's important to realize that because sometimes people saying it's completely driven by the KCCQ. It is not. The win ratio is driven both by an improvement in mortality or improvement in survival, so to say, a reduction in heart failure rehospital admissions, as well as an improvement in KCCQ. So it's driven by the three of them, which makes this, I think, the outcome more powerful than when it's completely driven by KCCQ.
Can you comment quickly on the relative proportion of heart failure events that were due to worsening heart failure versus heart failure hospitalizations?
Great question. So I cannot answer yet. We are working on several secondary papers at the moment. So the primary paper is fortunately accepted in Nature Medicine. So we're working on secondary papers, and one of the papers is an event paper, and we're going to describe in detail about the number of events, what were the breaking down. Upfront, I'm careful to speculate too much on this, because with the 530 patients, you get really limited numbers. But still, we're working on this, and it's upcoming.
I thought that you squeezed as much as you could from the small sample size, and people may not realize the incredible amount of work that goes into planning a trial. And I just wanted to say the methods paper was such a joy to read. And for the sake of the clinician, however, I won't linger too much on the statistics. We'll move on to the protocol that addressed any declines in GFR. So many clinicians are concerned about changes in GFR in patients who are started on RAS inhibitors, on SGLT2 inhibitors, even though evidence demonstrates that these don't correlate with renal endpoints or overall endpoints. But was there any algorithm that you followed for those patients who might have had a large drop in GFR? Were there any thresholds that you used before you held therapy or ceased therapy?
So this was completely investigator or physician driven. So they also reported their acute renal failure. So we have the valid endpoint that is most often used with a 40 to 50% reduction in eGFR, or going down below 15, or dialysis, which was hardly occurring. It was, I think, in 3 patients in the placebo group and only 1 in the empagliflozin group. But we also had the self-reported acute renal failure, which occurred in 7% in the empagliflozin group versus 12% in the placebo group. And I completely agree with you that this is the acute renal function events is completely different from the intrinsic effect of the drug to have an initial slight drop in eGFR of approximately 2 points. I think it's great that you emphasize this discrimination between those. You have the acute renal events. Something is often go wrong. It might be a hemodynamic deterioration or other things that's happening. And there is the intrinsic effect of the drug. Now, the intrinsic effect of the drug is a slight drop in eGFR, which recovers after 30 days or 90 days, and it gets back to normal again. But acute renal failure is occurring less often in patients on SGLT2 inhibitors and in empagliflozin in this situation. So I agree. We should differently look at both aspects of renal function changes.
Right, and a guide to what clinicians should do at the point of care when there are acute changes would be quite useful, because most trials present baseline GFR, but not sort of any algorithmic driven instructions or guides for clinicians, which I think unfortunately results in a lot of inappropriate cessation of therapy. Overall, the safety profile was excellent, with fewer, in fact, adverse events in the intervention group than the comparator group. I don't know if you want to jump in and talk about the genital infections.
Yes, there were 3 cases of genital infections in the empagliflozin group versus 1 in the placebo group. So very low incidence of this event. Still, I mean, in clinical practice and nowadays in the chronic situation, I already use it a lot according to the guidelines. I always tell people, still, I notify them that this might happen. Why? Because if patients get a genital infection, they don't make the link between the drug that they just received. So it's always good to pay attention to this, but it is something that occurs slightly more often in the SGLT2 inhibitor group, but it was very rare in our situation. It's mycotic infections usually. It's easy to treat. I have already a few patients that had it. They wanted to continue with the drug because they felt better, and I said, well, you better stop for a while because you have to treat your infection first. But it's easy to treat.
Yes, and do you stop it for the purpose of the trial? How long did you stop it for?
Well, in my clinical practice, so far I stopped it. I didn't restart it. In the trial, it was also a permanent discontinuation.
I see. Okay. Well, let me congratulate you on an impeccable trial that got such great buzz at AHA 21. It's been a pleasure talking to you today and also collaborating with you through the year. I wish you well. I'm going to look for this primary publication and all the secondary papers that come out, and I can't wait till our paths cross again, Adrian. Thank you so much for joining me this morning.
Thank you, Harriet, for a very nice interview. Thank you.
You can't give what you don't have. And so self-care is the process of filling your tank.
Don't let people bring you down. You just keep working and you lift them up.
It's for the passion that you do the action, and then the results you leave to the destiny of the product.
Ultimately, life is about relationships, and it's important, I think, trying to foster relationships that are fulfilling ones.
I really am the example of an impossible dream, honestly.
Hello, everyone. Welcome to another episode of Parallax.
Hi, everyone. My name is Davide Cao. I'm a research fellow at the Icahn School of Medicine at Mount Sinai, New York, and I'm also an interventional cardiology fellow at Institut Montsouris in Paris. Today I'm going to present the results of the HBR sub-study of the Twilight trial. So Twilight HBR is important for a number of reasons. The most important one, in my opinion, is that HBR patients are extremely prevalent in clinical practice. And this is because we have seen advances in device technologies and operator expertise, which have allowed extending the indication to PCI to increasingly complex patient population. And as a result, about 40% of patients undergoing PCI present with high bleeding risk conditions, which increase their risk of adverse events and bleeding, particularly while on a term of dual antiplatelet therapy, especially with potent P2Y12 inhibitors. And against this background, current guidelines lack specific recommendation on the management of HBR patients, especially because of the low level of evidence that is available. Another important reason why Twilight HBR is very important is that Twilight was developed using to enroll patients at high risk of ischemic and bleeding events according to a broad range of ischemic and bleeding risk criteria, clinical and angiographic, that were developed nearly 6 years ago. Over the last years, the definition of HBR has been revised to include risk score, prediction models, and consensus-based definitions. So we thought it was important to see whether the treatment effects of the main Twilight trial were preserved in a contemporary HBR population as defined by the recent academic research consortium criteria. So in brief, Twilight was a large randomized double-blind placebo-controlled trial who was conducted at 187 sites across 11 countries. Patients were eligible for inclusion in the trial if they had undergone successful PCI with a drug-eluting stents and they fulfilled the pre-specified all patients were discharged on 3 months dual antiplatelet therapy with ticagrelor, and after 3 months, they were randomized 1-to-1 to aspirin or matching placebo on a background therapy with ticagrelor for an additional 12 months. In this pre-specified analysis of the Twilight trial, we evaluated the treatment effects of ticagrelor monotherapy versus ticagrelor plus aspirin according to HBR status. So patients were considered to be at HBR according to the ARC-HBR definition, that is, if they fulfilled one major or two minor criteria at least. A number of criteria of ARC-HBR criteria were available for the study, but of course not all of them. And it's important to note that the Twilight trial excluded patients on oral anticoagulation and with a prior stroke who are two established ARC-HBR criteria. On the other hand, we were able to use most of others ARC-HBR criteria, most importantly, the most prevalent ones, such as anemia, chronic kidney disease, of course, age, use of non-steroidal anti-inflammatory drugs, and so on. For the purpose of this analysis, we used the same study endpoints as the main trial, which is part 2 to 5 as primary bleeding endpoint, and death, MI, or stroke as key secondary ischemic endpoints. But in addition, we also evaluated, we considered outcome of interest for this analysis, those that were recommended recently by the Academic Research Consortium for HBR Trial Design Principles, that is major part 3 to 5 bleeding and cardiovascular death, MI, or ischemic stroke. The key findings were that HBR patients experienced significantly higher rates of not only bleeding, but also ischemic events. And it was also interesting to see that there was a gradient in the risk of ischemic and bleeding events according to the number of ARC-HBR criteria that were fulfilled. In other words, patients with multiple criteria were at much higher risk of other HBR patients with only one major or two minor criteria, and of course at a greater risk compared to non-HBR patients. Ticagrelor monotherapy reduced the risk of the primary endpoint of bar 2 to 5 bleeding without increasing ischemic events, including death, MI, or stroke, consistently among HBR and non-HBR patients. And also, the same treatment effects were observed among very HBR patients who fulfilled multiple HBR criteria. The most relevant finding of this study, however, was the fact that the absolute reduction in major bleeding events, namely bar 3 or 5 bleeding, was significantly larger among HBR patients compared with non-HBR patients, which is particularly important when we evaluate the effectiveness of a treatment strategy, for example, in terms of number needed to treat. So the impact of Twilight HBR on clinical practice is critical. And that is, we just need to consider and take a look at the guidelines. The current European guidelines on non-ST elevation ACS reserve a strategy of ticagrelor monotherapy to patients at low risk. And this recommendation is justified by the lower than expected event rates that were observed in Twilight at 1 year. Against this background, we demonstrated that the treatment effects of ticagrelor monotherapy in reducing bleeding without increasing ischemic events are preserved, that were observed in the main trial, are preserved in the higher risk cohort of HBR patients. And not only this, we also showed that these HBR patients are likely to derive a greater benefit in terms of absolute reduction of major bleeding complications compared to non-HBR patients. Regarding next steps and future research, it is important to remember that Twilight randomized patients to ticagrelor monotherapy versus ticagrelor plus aspirin. So it is very important to evaluate whether the effects of an early aspirin discontinuation strategy on ischemic and bleeding events are true also when using other P2Y12 inhibitors like clopidogrel and especially prasugrel. And it is also important in light of recent evidence, such as the OSTEXAM trial, to evaluate and to compare the effects of P2Y12 inhibitor monotherapy versus aspirin for long-term cardiovascular prevention. We also need more data on patients with STEMI that were excluded in Twilight and in whom physicians are usually more conservative and reluctant to implement bleeding avoidance strategy based on a short DAPT regimen. Finally, it must be remembered that Twilight HBR was a sub-study of a trial, and therefore, by definition, it was underpowered to detect significant differences, especially with respect to ischemic events. And therefore, prospective studies using the ARC-HBR criteria are warranted, especially based on the observed results of the Twilight HBR sub-study.
I'm Billy Caceres. I'm an assistant professor at the Columbia University School of Nursing and core faculty of our Center for Sexual and Gender Minority Health Research. Today, I will be discussing with Dr. Carl Streed, providing an introduction to cardiovascular health concerns among LGBTQ+ populations. And LGBTQ+ stands for lesbian, gay, bisexual, transgender, queer, and questioning individuals. So it's a very large group, and we're trying today to sort of provide just an introduction of the different cardiovascular health concerns that affect this specific population. So first, I just want to thank Dr. Streed for being here today, and then I'm going to ask you to introduce yourself.
Great. Thanks for having me. I'm Carl Streed, pronouns he, him, and his. I'm a primary care doctor at Boston Medical Center and assistant professor of medicine at Boston University School of Medicine, as well as the research lead in our Center for Transgender Medicine and Surgery. So thank you for having me. Why don't we kind of dive into our first question? So Dr. Caceres, tell us, what are some of the documented cardiovascular health disparities in LGBTQ plus adults?
So there's more and more that we're learning about the health disparities that exist in this population related to cardiovascular health. You and I both know that. One of the biggest issues that we have very well documented evidence is around tobacco use and other forms of tobacco like e-cigarette and even smokeless tobacco use among mostly all LGBTQ individuals really across the lifespan, so from youth to old age. We also see higher levels of alcohol use, so heavy drinking and binge drinking among certain groups in this community. Some of the risk factors that are sort of emerging are related to more physical health conditions like obesity and hyperglycemia or diabetes among lesbian and bisexual women, that when we actually look at some objective data, we actually measure people's glucose or hemoglobin A1C, we actually see some clear differences, even when we're controlling for body mass index or other measures of adiposity among lesbian and bisexual women. And again, this is comparing lesbian and bisexual women to heterosexual women, which is usually the comparison group across these studies. And then we also have some evidence of obesity among bisexual men when we compare them to heterosexual men. And bisexual men are also about 2 times more likely to have been diagnosed with hypertension than heterosexual men, and to also meet criteria for hypertension when compared to heterosexual men. So those are some of just like a brief overview of some of the disparities that have been documented, but really the disparities that have the most robust evidence are really some of the ones that I just discussed. So I didn't specifically talk about disparities around transgender adults because I wanted Dr. Streed to discuss this. So Dr. Streed, what are some of the documented cardiovascular health disparities among transgender and gender non-binary adults?
So I feel like you hit a lot of the high points in terms of risk factors, particularly as it relates to tobacco, since it is such a significant and modifiable risk factor for cardiovascular morbidity and mortality. But in terms of like hard outcomes, when we're talking about heart attack and stroke, the data is at best suggestive. We are still looking for better data sources to really describe the long-term cardiovascular health of transgender and gender diverse individuals. What data we do have available from such surveillance systems in the US as the Behavioral Risk Factors Surveillance System, which is one of the largest and oldest surveillance systems of its kind in the US, we do see a suggestion that through multivariable analyses of this cross-sectional data that men who are transgender men have about a 2 to 4-fold increase in the prevalence of heart attack compared to cisgender men and cisgender women. We've also seen an increase among transgender women, about 2-fold of the prevalence of myocardial infarction as well, compared specifically to cisgender women. But there was no difference when they were compared to cisgender men. And I want to highlight that you have to make these comparisons both on sex assigned at birth as well as gender identity. The big issue here, of course, though, in this data is it's all self-reports. We don't have anything objective in terms of of actual reports of myocardial infarction. Generally, people are good about saying whether they've had a heart attack, but the big issue with these kind of surveillance systems is we don't actually know mortality. We don't know who did not survive a heart attack and so forth. So again, the data is suggestive, and we're really looking for better data sources at this point.
Yeah.
So kind of moving into some larger factors that really affect health, and we're really getting a better framework for this. Dr. Caceres, tell us a little bit more about what factors are believed to contribute to cardiovascular health disparities among LGBTQ plus adults.
So that's sort of a big question because there's a lot of different factors. And again, I'm just going to provide a brief overview of some of the main sort of social determinants specifically that are hypothesized or have been shown to influence cardiovascular health in this population. So I think the first thing is to take sort of a large, big picture view of things. One of the biggest factors that is posited in the literature and also by people who are LGBTQ health experts to influence their health overall, but potentially their cardiovascular health, is around anti-LGBTQ policies, so anti-discrimination policies that really aren't widely adopted across, certainly in the United States where we are. There's many states that do not have these policies to protect LGBTQ people from discrimination. But if we look at worldwide, there's still about 70 countries where it's illegal to be a member of the LGBTQ community. And still, I think about a dozen countries where it's actually being LGBTQ is punishable by death. So we see that even at the policy level, there are certain issues that exist that could clearly impact the health and well-being of LGBTQ people. Now, whether or not that increases risk for cardiovascular disease is still pretty unknown, but we do have robust evidence around, particularly in Europe, looking at different countries with different policies that are protective or not protective, and seeing that it does have an influence on the mental health of people who are LGBTQ+. I think, so now if we go down further to the interpersonal level, we do know that LGBTQ people experience higher rates of discrimination in interpersonal relationships or interpersonal interactions. And there is some consistent evidence that discrimination at the interpersonal level is a risk factor for higher levels of smoking and substance use among LGBTQ people, which are both risk factors for cardiovascular disease and other chronic conditions. And then if we think at the individual level, many LGBTQ people themselves have experienced discrimination, but they also might be friends with people who have experienced discrimination. So there is sort of this idea that there is increased expectation of being rejected or increased expectation or fear of discrimination among LGBTQ people. They may actually cause some LGBTQ individuals to avoid opportunities or situations in which they feel that they'll be discriminated against. And I think that's important to think about, that it's not necessarily what people experience, but also sort of what they're aware of that they might experience because of their identity. And that's sort of a really important issue. But again, we really don't have very good evidence showing that things like anticipated rejection or discrimination is associated with cardiovascular risk in this group. But there is some new, I know that there are some studies that are sort of trying to investigate this that will be coming out in the next few years. So I think we'll have more of an idea of what expectations or anticipated discrimination, how that might influence health. I think the other things to think about are related to barriers to access and utilization to healthcare. So at least in the United States, we know that certain LGBTQ individuals are more likely to live in poverty. That includes lesbian women, bisexual men and women, and transgender and gender diverse individuals. So those higher rates of poverty are also seem to be correlated with lower use of healthcare. So we know that many LGBTQ individuals are much more likely to avoid seeking care, not only because they're afraid that it might cost too much, but also they might be afraid of being discriminated against by providers that are not as aware of LGBTQ issues or may have biases against LGBTQ populations. So I think the idea is that most of what we think influences cardiovascular health among LGBTQ people really has to do with social determinants. And I think that this is in line with what we know about other disparities for other groups, like racial and ethnic disparities, as well as sex disparities for cardiovascular health, that these social factors really do play a role. I think one of the things that I didn't cover, but it comes up a lot, is sort of the role of gender-affirming hormones on the cardiovascular health of transgender and gender diverse individuals. And this comes up a lot among clinicians having fears about the influence that gender affirming hormones might have on the cardiovascular health of these individuals. So I wanted, Dr. Streed, for you to talk a little bit about gender affirming hormones and sort of their role in cardiovascular health in that population.
Thanks, and thanks for that really great introduction to minority stress theory and how it plays a role broadly in cardiovascular health. I know we've really outlined that in some other papers as well. In terms of gender-affirming hormone therapy, this is always a sticking point for a lot of folks because people are fearful of causing harm or causing any kind of risk. What I want to kind of give is a 30,000-foot view, a very broad overview of what we do know. So again, evidence could be better is, I think, the best is the takeaway message I will always say right now as it relates to cardiovascular health for trans folks. I want more data, I want better data, and I want community-informed data. But as it relates to gender-affirming hormone therapy, let's break it down into main categories of testosterone for the most part for masculinizing, and then estrogens, progestins for feminizing and the like. What we see for trans men who are receiving testosterone affects a lot of the factors that we associate with poor cardiovascular health. So it does can increase prevalence of dyslipidemia, really increasing people's LDL, lowering their HDL, but it also increases insulin resistance, which has been tied to early onset of diabetes, and it has been associated with a slight increase in systolic and diastolic blood pressure among trans men receiving testosterone. That said, the data has not tied these changes in risk factors to actual downstream morbidity or mortality as it relates to cardiovascular outcomes such as heart attack, stroke, and death. Among trans women who are receiving typically estrogen and maybe an anti-androgen and possibly progestins, we've seen, again, a little bit more mixed data here in terms of actually improved lipid profiles, a slightly improved blood pressure, but we are still seeing issues as it relates to potential blood pressure effects as well. It varies a lot based on formulation. It does vary a bit in terms of whether you're using a progestin or not. So it's worth digging into the data that we can provide to really understand what might be the risk for your particular patient. At the end of the day, though, I really want to highlight that when people are actually able to access gender-affirming care, their self-reported levels of stress decrease. Blood pressure actually overall will decrease slightly for folks. And then also risk factors, behavioral risk factors change. So access to gender-affirming care has actually been linked to higher rates of cessation of smoking or essentially improved connection with healthcare, which allows us to actually engage in more preventive healthcare services. I explain this more as a primary care doctor. If we can improve trust with our patients on our end, since healthcare really does have a lot to reckon with, that allows us to have more contact, more trusting relationships with our patients, and then to actually address preventive healthcare, which I think is a large component of cardiovascular health. In terms of like how we can be better prepared to be more inclusive, more broadly for LGBTQ individuals to address their cardiovascular needs, I think we really need to set this as a priority. I think we need to really describe this as a priority population very broadly that has very distinct features. This is not LGBTQ plus as a homogenous group. We need to really think about the individual group members, individual community members, and what needs to be done to meet their needs. As a clinician, it's important for me to know what interventions are specially tailored to somebody based on their identity and their community factors. So if we're talking about a smoking cessation program, it's not going to be best if I just throw them in with everybody else talking about standard stressors as it relates to their everyday cisgender heterosexual life. That might be particularly off-putting. It might actually scare people away, might actually stress them out to smoke more. So I think we need to think about interventions that are more tailored based on people's identity and community support. Also, we really need to think about how are we collecting this data, how are clinicians and other health research experts really identifying LGBTQ plus folks within clinical and public health data so we can better define the disparities and then measure interventions to improve their health. And I do want to highlight pretty much the higher level that Dr. Kasseri's really talked about is that we need to implement non-discrimination policies not only in the clinic and across our institutions, but at local jurisdictions and at national levels as well, because these effects are going to be what's going to derive a lot of long-term health in these communities. So I really want to turn it back to Dr. Kasseri to kind of ask, what are some more other important cardiovascular risk factors to screen for in LGBTQ plus adults?
Well, I think you provided such a great overview of sort of the clinical imperatives in terms of caring for this population. I think the biggest thing, and I think Dr. Street could agree with this, is that we're still sort of at a stage where we're still describing these disparities and sort of what causes the disparities, that we still haven't moved beyond that to really think about, well, what are some really high evidence-based interventions to improve the cardiovascular health of this population. So what I'm about to discuss is just sort of what I think Dr. Street and I and others sort of think might be the things that we should focus on. But I think that any sort of clinician thinking about reducing cardiovascular risk among LGBTQ people really needs to take a preventive approach. I think that that's the sort of like, from what we know right now, what makes the most sense. We're really thinking about a multi-component approach that focuses on lifestyle modification. So if we think about some of the factors that we've talked about today, we know that LGBTQ people experience more stress for a number of different reasons, both stress from being an LGBTQ plus person, but also from higher rates of poverty or stress in the family. That's been documented. So thinking about stress management or stress reduction is important. We know smoking cessation is an important intervention for LGBTQ individuals, not just for cardiovascular health, but tobacco use being a leading cause of preventable death among all adults for a number of different conditions. We also can think of one of the emerging disparities is sleep. And few studies now have shown that lesbian and bisexual women in particular, and some studies have shown transgender individuals as well, are much less likely to meet recommended hours of sleep, which is 7 or more hours of sleep per night. So thinking about interventions that focus on sleep hygiene is also important, I think, because we know sleep plays such an important role for a number of different cardiovascular conditions, hypertension, diabetes, obesity. And then I think also, and this is one of the things that Dr. Street just mentioned, is thinking about what are interventions that are tailored for different communities, and that LGBTQ plus individuals aren't just one big group, and that some interventions that may work for a gay or bisexual man may not work for a lesbian woman. So the other intervention, and I know that we talk about this a lot in primary care, is weight management, but that can become a touchy subject for certain individuals within the LGBTQ plus community. And there is evidence from different qualitative and even quantitative studies that has shown that for lesbian and bisexual women, a focus on reducing weight isn't really the right approach, but really about maintaining a healthy weight or maintaining a healthy diet is really a much better approach in thinking about working with alongside patients that identify as lesbian or bisexual women. So I think it's important to think about what interventions are appropriate for people at the stage that they're at, and also from the population that they belong or identify with. I think along with that, what are some clinical considerations specifically for transgender and gender diverse people that you would recommend for clinicians, Dr. Street?
So I definitely want to encourage people to get comfortable providing gender affirming care. Honestly, if you do well by transgender and gender diverse folks, you're going to do better by everyone, since gender is an issue that many people have to navigate society with. So I want to highlight that as it relates to gender affirming care, particularly, I want you to really be mindful of a variety of guidelines. Naturally, there's the World Professional Association for Transgender Health, which provides their standards of care, which is being updated with Standards of Care 8, that will provide additional guidance for providing gender affirming care for particularly gender diverse individuals, but also being mindful of your local hospitals, endocrine group in terms of their guidance for how to provide care. In the US, we have a fairly standard practice of close monitoring of hormone therapy in the first year and then spacing it out over time as we achieve the desired hormone levels, as well as try to maximize the safety profile of receiving exogenous hormones. But again, to what Dr. Summaries mentioned, it's really about modifying, addressing modifiable risk factors such as smoking cessation. And again, really framing when we talk about healthy eating and healthy weight, it's really about physical activity, ensuring people are living their best life, that they're thriving, and that we identify what barriers are getting in the way of them thriving. So it's one thing for me to say you should have a healthy diet of fruits and vegetables, and people are like, there's no market with fresh fruits or vegetables for miles around, and I don't have a car, and things like that. So we have to be really mindful of the barriers that are affecting people's access to a better life, as we define it medically. So again, I appreciate Dr. Summaries' reframing of, we're not talking about obesity, overweight, and weight management. We're talking about healthy activity, improved cardiovascular health overall, and really trying to make sure people can engage in the life they want. And that also means being mindful of community support systems. There's been a larger recognition of the dangers and the harms of isolation and essentially being alone, and how that literally is killing people over time. So I want clinicians to really take it upon themselves to identify what are the community supports around them and how they can connect their patients to those specific community mechanisms to ensure that their patients are thriving, not just getting by between visits. Other things I think we need to talk about are some policy interventions. So Dr. Summaries, what are some examples of policies that are needed to ensure that clinicians have adequate training in LGBTQ+ health?
And I think this is something that we've talked a lot about in the US, and I'm sure in other countries as well. But one of the things that's really come out over the last decade or so is how little content on LGBTQ+ issues there is across different health professions. So medicine and nursing, which is where I'm in, public health, physician assistant programs as well, that there really needs to be required LGBTQ content that's integrated across the curricula. And I think one of the big concerns, and I hear this from students themselves that are identified as LGBTQ plus that are, I don't know, going to nursing school or medical school is that they generally will have like one lecture on LGBTQ issues where all the health issues are lumped together in one session rather than integrating across their curricula. So I think that's really important to think about. If there is a lecture on cardiovascular disease, that then the professor or whoever is giving the lecture really discuss how those cardiovascular issues might be different among LGBTQ people or among trans and gender diverse people. And I think that's an important step. And now more and more, we have more resources for even people who are not LGBTQ experts to be able to pass on that knowledge to students. But also we have plenty of LGBTQ health experts that could come in and do a lecture on cardiovascular disease or on endocrine function among LGBTQ plus individuals. I think the other thing, and we've talked about this personally, is thinking about the requirements for renewing licenses among healthcare professionals. And there's different continuing education credits that people need to complete to actually renew their licenses, and thinking about incorporating LGBTQ health content and really even just content around social justice and health equity into those relicensure requirements might be another step to really target or reach people who've been out of school for a few years, but still need to have this content in order to provide gender affirming or LGBTQ affirming care to this population. And it's really small steps, but I think that they might go a long way to just opening people's eyes about some of the issues that this population experiences. And then I think from a policy perspective, and we've talked a little bit about this already today, thinking about how can we enact anti-discrimination policies that protect LGBTQ people from discrimination. I think that's particularly important, and both Dr. Street and I mentioned that. And then I briefly mentioned before the income inequalities that we see among LGBTQ people. So it's not just about passing laws and policies that are specific to LGBTQ individuals, but I believe that if we pass laws that decrease income inequality, that will have an important positive effect on increasing LGBTQ people's access to healthcare, access to healthy fruits and vegetables, access to potentially living in neighborhoods where they can engage in physical activity without fear of being victimized or having like a hate crime committed against them, which is also a big issue that we didn't really talk about today, but it's also a big concern, sort of violence against LGBTQ people, particularly trans and gender diverse individuals, at least here in the United States, and I know globally it's a big concern. So I think those are sort of the main sort of like clinical and larger like societal policy level issues that probably need to be addressed, although we could probably talk about this for hours on end. I think one of the big things that people who might not be as familiar with LGBTQ health might want to know is about educational resources to help them better understand the population and how to reduce cardiovascular disease risk in this group. So Dr. Sheed, can you talk a little bit about some of the resources that you're aware of?
Yeah, so there's a number. I want to acknowledge our broader global audience and recognize that there is the World Medical Association, which actually has a number of supportive policies as it relates to better understanding LGBTQ health. Naturally, the American Medical Association is a member of the WMA and has an advisory committee that actually provides additional guidance to their board as it relates to LGBTQ plus health. Disclosure, I'm a current member, past chair of that committee, and we really try to develop and push for additional educational materials and naturally host a lot of what we describe as continuing medical education courses. I mentioned earlier, there is the World Professional Association for Transgender Health, which also has essentially every other year conferences that really highlight the latest science, but also provide a great introductory course as it relates to providing gender affirming care, and does have a particular focus on cardiovascular health. They also have what they describe their Global Education Initiative, the GEI, which also provides certification in gender affirming care. There is GLAMA, Healthcare Professionals Advancing LGBTQ Equality, previously known as the Gay and Lesbian Medical Association, but is more than gay, lesbian, or medical at this point, and is one of the oldest medical associations focused on LGBTQ health, and particularly with a focus on LGBTQ healthcare professionals. And then, of course, here in Boston, Massachusetts, in the US, we have Family Health, which is a national and international leader in defining a lot of what we know about LGBTQ health, really pushing a lot of different policies, including better data collection, better training for clinicians for how to do that, but also really pushing for additional policy changes, local and abroad. But I also want to make sure that people don't miss out on looking to their own localities, thinking about their own institutes that focus on research and public health, because a lot of this is homegrown. Naturally, we can provide you guidance on where to look for a little higher level information. That's kind of what we're providing here. But I really want to remind folks that generally you probably have experts in your backyard, and I don't want you to neglect them. So things that I also want to make sure people always think about, of course, is the United Nations, the World Health Organization, which does provide pretty much annual reports on the health of eligible.
Hello, I'm Mirvat Al-Asnaj. I'm an interventional cardiologist at King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. I'm also an editor at the US Cardiology in Review and a member of the Society of Cardiovascular Angiography and Interventions Board of Trustees and the ACC Interventional Leadership Council. I'm here with Dr. Roshan Colleran, who is an interventional cardiologist at Mater Private Hospital and Cardiovascular Research Institute in Dublin, Ireland. Dr. Khalid Al-Shaibi, who is an interventional cardiologist and the director of the Cardiac Center at King Fahd Armed Forces Hospital, Jeddah, Saudi Arabia. Dr. Marco Valgamigli, who is a professor of cardiology at the Cardio Centro Ticino Institute, Lugano, Switzerland. And we're here to discuss revascularization in high bleeding risk individuals. So to start off, I'll go to Dr. Colleran. How do we define high bleeding risk?
Thank you, Dr. Al-Asnaj. So the Academic Research Consortium for High Bleeding Risk recently proposed the first definition of high bleeding risk for patients undergoing PCI. So this definition consists of clinical criteria, which are known risk factors for bleeding, and they were classified into major or minor criteria, depending on the associated bleeding risk at 1 year. So a major criterion is any criterion which is associated with a 1 year BARC 3 or 5 bleeding risk of 4% or more, or an intracranial hemorrhage rate of 1% or more. And a minor criterion is defined as any criterion which is associated with increased bleeding risk, but less than this cutoff of 4% at 1 year. So high bleeding risk is defined as the presence of either one or more major criteria or two or more minor criteria. And these criteria included clinical characteristics such as age, anticoagulation, chronic kidney disease, anemia, thrombocytopenia, and so on. The good news is we don't need to memorize this whole list because there is an app, the ARC-HBR app, which is a handy user-friendly tool which can be used at the bedside, and patient data can be inputted to determine how many major or minor criteria they meet and whether they meet criteria for high bleeding risk.
So Dr. Al-Shaibi, why is there so much variability in antiplatelet regimens in clinical practice currently?
Well, I guess one of the reasons is the initial studies that looked at shortening dual antiplatelet therapy duration, such as the initial DAP trial and PRECISE DAP trials, excluded patients who were considered at high bleeding risk. And hence there was little to guide DAP treatment in such patients at that time. Subsequently, trials that have looked specifically at duration of DAPT in high bleeding risk patients, such as the LEADERS-3 and the senior trial, have been performed, yet the definition of high bleeding risk was not uniform across such trials. And importantly, certain high bleeding risk patients were excluded, actually. And this was something that Dr. Colleran just alluded to with the new ARC-HBR criteria that have been that were introduced last year. I think it was published in Eurointervention in 2020. Furthermore, over the past several years, an attempt has been made to estimate the bleeding risk of patients, and several bleeding scores have been developed, including the DAP score, the DAP PRECISE score, the PARIS score, the BLEMAX score, to name but a few. Yet again, the only common variable in these risk scores is age, and even then, the cutoff for age within the different scores varies, and its weight also varies. So really, all the bleeding scores omit certain important variables known to be associated with high bleeding risk, such as thrombocytopenia, bleeding diathesis, liver disease, prior bleeding episodes, planned elective surgery. And these differences in omissions between the bleeding scores make these scores at best moderate in their accuracy in assessing the risk of an individual patient for bleeding. And as Dr. Collins has pointed out, the Academic Research Consortium has recently published the ARC-HBR definition, which he pointed out. And this was actually validated recently in a study published by Yasushi Yuki et al. In Neurointervention, in which they actually determined that in those that met the ARC-HBR criteria, the incidence of major bleeding within 1 year of follow-up was in fact 6.5%, compared to 1.2% in those who did not meet such criteria. So it has been validated, but again, its sensitivity and specificity was not much better than the already published bleeding risk score. So really still somewhat at losses who really is high bleeding. We know these scores and the ARC-HBR definition are very good at predicting who won't bleed. So if you score low, you probably are not going to bleed. But if you do score high on these scores, the sensitivity and specificity is not where we would want it to be. And then obviously there's the other side of the coin that is the ischemic risk, and that's a very important consideration also when you talk about dual antiplatelet therapy and duration. It's always a balance between bleeding risk and ischemic risk.
So, Professor Valgamigli, in your experience, what is the body of evidence that is guiding practice and guiding the elaboration of guidelines?
So with respect to HBR, since we are discussing this patient subset, I would like to focus on first device and then pharmacology, if you allow. For device, we have today quite clear understanding that even in HBR patient, drug-eluting stent iteration should be preferred over bare metal stent. We have had a total of 4 studies, 3 focusing also or exclusively on HBR patient, 1 focusing on elderly patient, comparing a DES active iteration versus bare metal stent in patient receiving relatively short DAPT duration, including also 1 month. And all these 4 studies actually are telling us the same story. DES outperform bare metal stent. So with respect to device selection, the evidence is quite clear. DES should be preferred across the board in patient with or without HBR features. With respect to the APT duration, then the evidence is actually much more limited, because today we don't have a RCT focusing on HBR patient and comparing a very short or a relatively standard DAPT duration. However, we have some single-arm registries which did good use of historical control registry data, which do seem to suggest that we can go short as 1 month compared to longer DAPT duration without, in fact, losing anything with respect to the bleeding endpoints, ischemic endpoints, sorry, and in fact gaining on bleeding endpoints. However, again, this is evidence coming from non-randomized studies. Now, aside this, we do have some DAPT duration studies which did not focus specifically on HBR patient, who actually seems to tell the same story. If you go short, and short is relatively 6 or 3 months as compared to 1 year duration, you gain in bleeding endpoints and you don't seem to lose in ischemic events. Now, finally, with respect to type of DAPT, that is also something which is not entirely clear 100%. Triton TIMI38 established the superiority of prasugrel over clopidogrel. However, HBR patients were formally excluded by the protocol. In Plato, ticagrelor was compared to clopidogrel. HBR patients were not formally excluded in the protocol, yet they were not properly defined according to the definition that actually Roizen was explaining to us. So we do not really know how many HBR patients were there. And the only thing we can use as a proxy is the age pre-specified analysis, which is telling us that the treatment effect of ticagrelor versus clopidogrel seems to be consistent across all ages, including elderly patients, meaning above or equal than 75. However, if I have to say that there are recent data coming from Sweden, the Swede Heart Registry, which is a very large study, observational study, telling us that in very elderly patients, above 80 years of age, there may be some disadvantage of ticagrelor versus clopidogrel. So to make the story short, I would say that with respect to the type of the APT, both clopidogrel and ticagrelor may be considered, but perhaps if the bleeding risk is very high, then clopidogrel has to be preferred.
Thank you. And from here, I'll go back to Dr. Colleran. I think there's been a lot of discussion about intracoronary imaging to help us determine the duration of therapy. And many tend to reference trials such as, the SMART Choice or STOP DAPT. And these were Asian trials where the use of intracoronary imaging was very high, and over 90%. Not sure they're applicable to high bleeding risk patients. Nevertheless, that's the discussion ongoing right now in the interventional community. So what are your thoughts on that?
Yeah, so that's a great question. I mean, no trial, to the best of my knowledge, has specifically addressed this question of whether intracoronary imaging guided DAPT durations or antiplatelet therapy regimens versus angiography guided are associated with similar outcomes. There was one randomized trial, the IVUS XPL trial, which did touch on this. So this trial assessed IVUS guided versus angiography guided stent implantation with the Science Prime stent in long lesions. And it did show that TLF was lower in the IVUS guided group at 1 year. It also looked at DAPT duration 6 versus 12 months and showed similar outcomes with 6 versus 12 months at 1 year. However, it didn't, this trial had a 2x2 factorial design, but it didn't specifically look at whether IVUS guided DAPT duration versus angiography guided DAPT duration was, didn't look at outcomes with this, didn't directly compare that. So I think, we know that in terms of stent thrombosis, the ways to prevent this are firstly a good antithrombotic therapy regimen, good antiplatelet therapy regimen, I should say, and then optimization of stent technique. And in high bleeding risk patients, obviously, we want to avoid prolonged antiplatelet therapy regimens and want to avoid very potent regimens. So really the way to reduce the risk of stent thrombosis then in these patients would be to optimize stent technique. And the best way to do this is through a liberal use of intracoronary imaging. We know that the most common reason for stent failure is a mechanical cause. So if we can identify mechanical causes post-stent implantation, like edge dissection, underexpansion, malapposition, intracoronary thrombus, that we can optimize stenting by post-dilatation or by implanting an additional stent. In addition, baseline information gained by intracoronary imaging that might not be seen with angiography include stent sizing, so both diameter and lesion length to make sure that the lesion is adequately covered, and also information gained on plaque characteristics. So is this a ruptured plaque? Is it a TICFA? And all of this information might help to guide DAPT duration. If we know that we have optimally implanted the stent, we might be more confident in high bleeding risk patients to reduce the DAPT duration, for example, 6 months in patients with ACS and 3 months in patients with stable disease.
Thank you. And, continuing with, us as operators looking into the decision regarding high bleeding risk patients and the optimal antiplatelet regimen, Dr. Olsheibi, would the complexity of the PCI, for example, whether it's a bifurcation or a left main stem PCI, impact your prescribed regimen for your patients?
Well, again, it's always the issue of balancing risk of bleeding versus ischemic risk. And we know complex PCI, when you're talking about bifurcation procedures, especially two-stent procedures, long diffuse disease with long stents, especially smaller diameter stents, which are very prevalent in our part of the world, CTO revascularization, again, which usually involves quite lengthy stenting, or very high-risk patients where you've embarked on a chip procedure, for instance. Obviously, your concern as an operator for ischemic outcomes is quite high, and you tend to want to extend dual antiplatelet therapy in these patients. And we know these patients are at higher risk for ischemia. So definitely yes. I think the complexity of the intervention certainly will flavor the type of antiplatelet agent I use, ticagrelor versus clopidogrel, and the duration in which I will recommend it. Keeping in mind there is increased bleeding risk, but there is no data really that I'm aware of that really looks at the lesion complexity and tries to marry this with dual antiplatelet therapy regimens or duration. So it definitely, most certainly is a concern because we know these complex patient subsets with complex interventional procedures do have a higher ischemic risk than your straightforward angioplasty. So yes, it definitely is something that I do consider.
And Professor Valgamiglia, I'll move to you right now. What are your thoughts on de-escalation versus, discontinuation of aspirin?
Thank you, Mirvet. That's a difficult question. I can say that both treatment strategies are most likely very effective in reducing bleeding risks. Apparently, none of these two treatment strategy is associated to a concomitant trade-off with respect to ischemic events. However, these two treatment approaches have never been compared side by side. So I cannot answer which one is the best fit for the HBR patients. If anything, because these treatment strategies have also been tested in patients who were not properly selected for being necessarily HBR. A problem of judging the evidence with respect to de-escalation is that if you look at each of these studies was actually quite different one from the other. In some cases, the escalation was unguided. So you switch from one potent P2Y12 inhibitor towards a less potent P2Y12 inhibitor. To name it is, of course, clopidogrel. In some cases, this was guided either with genotype or phenotype. And I have to say, we have seen in Western countries mainly guided the escalation, and in Asian countries mainly unguided the escalation. So how the evidence apply in the various ethnicities in which the specific strategy has not been tested is completely unknown. With respect to dropping aspirin, also we have had a total of 6 studies, 5 of which focusing in post-PCI patient testing this approach. Importantly, aspirin was dropped in a time frame of from 1 to 3 months, so that was a heterogeneous time frame. And all the studies were, if taken individually, I would say underpowered to answer a very critical point. Are you risking anything with respect to ischemic events? Or are you simply trading bleeding benefit with ischemic risk? We also have seen some direct and indirect aggregate data meta-analysis, pulling these studies together. The limitation of this meta-analysis is that they always included the DAPT phase, which was common in both treatment arms, and therefore have in a way biased the results towards the null. I'm very proud to announce that we have now succeeded in publishing, actually that will be published soon in the British Medical Journal, an IPD meta-analysis of all these studies, where we deliberately excluded the common DAPT phase. We only look into DAPT versus P2Y12 inhibitor monotherapy treatment phase. And out of 24,000 patients, we do see a bleeding benefit, which is consistent across the board in the range of 40 to 50% lower risk of major bleeding. We don't see any excess of a composite ischemic endpoint, which is all-cause death and MI stroke. Importantly, we see a significant reduction for cardiovascular death. And very interestingly, there was a very strong signal with respect to sex interaction, suggesting that female patients are deriving a massive ischemic benefit, not only bleeding benefit, in dropping aspirin. Importantly, this signal was coming consistently across all the 6 included studies. In none, the gender analysis was significant, but all of them uniformly contributed to that signal. So I think that will be something very interesting to be further explored in the future.
So what's in the pipeline, you think, in this arena, Professor Van?
Well, I think there are many studies in the pipeline. The one which I think specifically apply to the discussion we are having today is the master DAPT study, which we, and I say we proudly because of course you were taking the lead of that study together with many others, including myself. We investigated whether 1 month of DAPT is enough in HBR patients who have not been selected with respect to the complexity of the PCI that they received. We were previously discussing CHIP patients. Well, CHIP patients are actually part of the population. We have a lot of rotablation. We have a lot of bifurcation stenting. We are speaking about over 5,000 HBR patients who have been uniformly treated with ultimaster stent implantation. And after 1 month of DAPT, if well tolerated, they were randomly allocated to stop one of the two antiplatelet therapy or continue DAPT for at least 2 additional months. So I would like to emphasize that the control group is a contemporary control group. We were not artificially extending DAPT duration up to 1 year, specifically because we wanted to have real HBR patient on board. Now, I have to stop here because the result of the study have still to be disclosed, but hopefully that will happen at the European Society of Cardiology this year.
Well, congratulations to the PIs on that paper. So before I close, I'll quickly go Dr. Colleran and then Dr. Shaby. What is your current practice in high bleeding risk patients? Really quickly before we close off.
Yeah, so I guess in high bleeding risk patients, it certainly depends on presentation. So whether they've presented with an ACS or chronic coronary syndrome. So in patients with ACS who are not on oral anticoagulant therapy, I'm treating them with 6 months generally of dual antiplatelet therapy. And then stable patients, I'm treating between 1 and 3 months, depending really on that risk. You know, I suppose we've high bleeding risk patients, and then we've very high bleeding risk patients, and patients who have accumulation of a lot of the factors that we mentioned in the definition. And then in patients with oral anticoagulation therapy, I guess we're more conservative again, reducing antiplatelet therapy often to 1 month, and continuing aspirin and OAC will be my practice, dropping the clopidogrel.
Dr. Shaby, anything different in your practice?
Pretty much the same, depending on the presentation, ACS versus non-ACS, 3 months versus 6 months, and then dropping one of the antiplatelet agents.
Thank you all for joining us today. Hope we gave you a little insight on the high bleeding risk entity, and looking forward to the publication of the new trials. Take care and see you in another episode with the US Review.
Okay. Thank you.
I'm Harriet Vansball, Associate Professor of Medicine, Cardiologist, and Scientist at McMaster University, and I'm honored to have with me today Dr. Cindy Grimes, Chief Scientific Officer of the Northside Hospital Cardiovascular Institute and the President of the Society of Angiography and Interventions. Welcome, Dr. Grimes.
Thank you so much for inviting me.
We are going to talk about some of the gender-related inequities in cardiology, interventional cardiology, and clinical trial leadership today. I have to admit, you are a huge source of inspiration to men and women in cardiology, including myself. But as a pioneer who has broken barriers, you are particularly inspirational to women. In a 2017 interview with Dr. Oman, you said, "You learn how to be tough when you talked about managing the competing demands of pregnancies and your clinical work as an interventional cardiologist, and of course, your research leadership as a clinical trialist. Tell us how you navigated some of these barriers and what some of the facilitators were for your success.
Gosh, there were so many barriers. It's hard to even start. Obviously, when you're going through training, there are barriers to even get a cardiology fellowship and to become an interventionalist. It's interesting. I thought patients would be a barrier, but the patients seemed to be fine. They had no problem being with a female physician, and actually studies have shown they prefer female physicians. But it was more the surrounding people that were the issue. And I was fortunate in that I was at the University of Michigan doing my cardiology training, and I was surrounded by lots of other people who were doing high quality research. I went into my fellowship thinking that I wanted to be an echocardiographer, and I came out being an interventional cardiologist. And in large part, that was because I was there during the reperfusion era when it was first taking off. We were doing a lot of thrombolytic trials where we required angiograms to determine coronary patency. And so I really got into the cath lab work and doing angioplasty, and that was really the focus of my investigation for the next couple of decades.
Right. So the barriers were more in the culture and some of the faculty members around you. How did you overcome some of these barriers?
Well, I think at the time, we didn't have this Me Too movement, and, we just, if people did inappropriate or said inappropriate things, we just kind of brushed them off because that's the way it was. And so I didn't let it bother me, to be honest. And I never really pulled the woman card and complained about things. But, times have changed now. But I found there weren't many women around to be your mentors. So I had mostly male mentors, and they were very helpful. I think if you're just inquisitive and hardworking and you don't waste their time and you actually start writing abstracts and papers, then they like you a lot. And that was really helpful to have those male mentors.
Right. We have an upcoming co-publication together in JAC on a roadmap to increase gender equality in clinical trial leadership. Tell us about how we might go about closing the gender gaps that you have alluded to in clinical trial leadership. There are particular challenges in research leadership that may be even more profound than in clinical cardiology. Tell us about those and how we might overcome them.
Well, it is very difficult to become a cardiovascular trial leader, as you are well aware. And I was lucky in that I was at the beginning of percutaneous interventions for STEMI. And I really made a name for myself because nobody else was doing that. So I think niche research has actually been very, very helpful. With regard to trying to get grants, I think that there's probably not a lot of discrimination in that area per se. It really would be nice actually if they could block out your name, because there might be these subconscious biases. But with regard to, I see a big difference though when it comes to industry sponsored funding, at least in interventional cardiology. In large part, it's related to, again, the good old boy network and the amount of volume that you do in the cath lab. So even though it's supposed to be separated, that's not how it works. So if you're chosen to be an investigative site, it's because you do a high volume of procedures and you use that particular vendor's equipment. And the same holds true for who they select to be principal investigators for many of their trials. Now, the FDA has actually stated that they want more ethnic and women and diversity in the trial participation with regard to both patients as well as site PIs at least. And there's a strong thought that if you are a woman, you're going to be more likely to enroll female patients because you can understand them better and talk to them better. And so we are working very closely with the FDA on trying to increase the participation of women investigators. But is it a mandate? Absolutely not. We have to work with industry.
Right. My team has a couple of papers, one in the European Journal of Heart Failure that showed the association, the independent association between women clinical trialists and recruitment of women participants. And another one showing the same association with recruitment of ethnically diverse populations. So some benefits, at least in terms of associations of a diverse research leadership force. We certainly see diversity in the frontline aspects of research recruitment, but it doesn't necessarily translate to research leadership yet. And as you point out, there are some particular challenges in industry sponsored trials where the path to clinical trial leadership is not clear and where the calls for research leadership are not open. So certainly some barriers to navigate in that area. What are your priorities as the president of your association?
Well, as you already mentioned, there is a lot of problem with a lack of mentorship and exposure of women. There aren't as many women at the podium. There aren't as many women who are chairing sessions. There aren't as many women who are, first author on publications. And so throughout SCI, for actually over a decade now, we've had this SCI WIN. It stands for Women in Innovations. And it's a committee that we formed specifically to mentor and foster the professional development of women and to enhance research by women or research about women. And that has been very, very successful. We've managed to put lots of women at the podium. We've had specific conferences just so they can enhance their speaking skills and get exposure to the rest of the world, basically. We also implemented this thing just this year. It's a specific mentorship program. And if you're a female, regardless of where you are in training, you could be a medical student, you could be a resident, or you can even be a practicing cardiologist. You may not have anybody who's your same sex or anybody who has ever helped you throughout your career. And you're able to connect with some people in our WIN committee to, bounce ideas or actually have a more formal mentoring process. When I became president, I specifically decided that we were going to try to increase the diversity. And so as part of that, we changed our scientific sessions program. So now we require that at least a minimum of 15% of all lectures are given by women or underserved minorities. And in the past, there had been none of that. We also developed this Diversity, Equity, and Inclusion Committee, and we also commissioned 2 publications, which hopefully will be published this month. One was on revascularization in women, and that was just a really great a manuscript that was written by Alexander Lansky. And the other one was racial and ethnic disparities. And we covered, what we did is we got all 4 of our clinical councils. We covered coronary disease, peripheral vascular disease, structural heart disease, as well as congenital heart disease. And we compiled the available literature. And interestingly enough, there, as you might suspect, there does appear to be lots of disparities, as well as some genetic differences that might account for some of this. But we compiled this into a publication and came up with marching orders as to how we hope to improve this in the future. So that has been a big focus of my year as president.
Right. For many women investigators, navigating research networks can be a challenge. Many research networks are closed, and output often relies on the investigator as a first or last author when you're not part of a wider network. What is your advice to young investigators, particularly women investigators, persons of color, who may be left out of informal networks, both at their research institute and on a wider scale by virtue of perhaps a focus on the competing demands of early parenthood or navigating tough environments in their locales? What can you offer them to increase their ability to network, navigate exclusions, and integrate themselves into a wider productive network?
Well, I think you should start at your own institution. I see lots of publications coming out from databases such as linked databases with Medicare, you know, the administrative billing databases, the national inpatient sample. And so even if you don't have a network, if you have access to that, you can write a paper and then actually even inquire some of the leaders to help you with that paper, because I get those requests not infrequently. With regard to trying to develop more of a network, if you're a clinical physician, I would recommend having participating in clinical research. In the past, prior to the pandemic, there would be at least one investigator meeting per year, and you can get a chance to talk to people. Even if you don't attend that meeting, there's lots of Zoom conferences where you can interact. And if you're a good recruiter or you come up with some interesting ideas for sub-studies, often that's the way to, you know, basically get into the club. And I think with regard to the difficulties with childbearing, that's I mean, we could spend days talking about that, you know, because I've consulted or talked to many of my trainees about this. There is no good time to have a child, period. And, you know, if you think about it, you just should do it. It's going to be difficult no matter what stage of your career. And even if you were just a stay-at-home mom, it's still difficult. It's the most difficult job I did, much more challenging than being a physician. But it's incredibly rewarding. And you just have to get the right support system in place. You know, I hired a lot of babysitters and daytime nannies, and then you have your spouse and family to help if possible. But you can certainly do it. And the one travesty that I see are women who think that they have to choose their career versus a social life. And I think all of us need a partner, and you may or may not want to have children, but you need something other than your career, because your career does not love you.
Right. And my little daughter, when she was 7, she's now 13, I have 2 kids, reminded me about the paradox of how much we invest in our careers, and that the more we invest in our careers, the less time we sometimes have to do those simple things that bring us joy, like time spent with family, for example. So certainly it's a juggling act, one that is facilitated with supports at home and perhaps in the wider community. I've learned to rely on carpools a lot. But perhaps for many women, not the biggest challenge in their career. I've certainly found that it's very feasible to juggle parenting with a research and clinical career, and that some of the barriers that are more substantive are those in our work environment. So onward and forward we go, trying to navigate those barriers for ourselves, and then also create some changes in the system for those that come behind us so that the journey gets incrementally easier. I would like to thank you so much for spending your time with us this morning. It was my absolute honor to meet you. This was just a big excuse to get to meet Dr. Grimes for me. But we're honored, and we know that our viewers will benefit from your experience and your advice. Thank you so much, Dr. Grimes.
Thank you so much for asking me.
Greetings. It's a real delight for me to be in the presence of such magnificent faculty. My name is Anastasia Mahaladou. I'm one of the section editors of US Cardiology Reviews, and it's a pleasure to be hosting this session, and I hope you'll be as excited as I am about it. We've named it How It Started, How It Is Going. Women Pioneers in Procedural Cardiology. When angioplasty and interventional cardiology started, there weren't many women. However, we're fortunate to have one of the talented archivists and one of the people who was involved with it from the beginning, Mr. Bert Cohen, who, as many of you will know, is the editor-in-chief of angioplasty.org. and has been involved from the very beginning, actually filming the initial interventions. He's produced many of the live demonstrations that we've used through social media, and he's working with the pioneers in the field and continues to document the history of angioplasty. We're very grateful for that, and I'm delighted that he's here with us. Welcome, Bert, to this session. And maybe you can start off by telling us a little bit of how it started, please.
Sure. Thank you, Anastasia. It's interesting, the very beginnings of interventional cardiology or interventional procedures were in the 70s when Andreas Grunzig went to a course in Nuremberg run by Eberhard Zeitler and saw the Dotter method and met Charles Dotter, which was a series of catheters of increasing diameter that kind of just pushed through blockages in the leg. And he had this idea, maybe there was a better way, and came up with the idea of balloon. And he worked with his assistant at the time, and this was in the 70s before he was doing any cardiology procedures in peripherals, and that was Maria Schlumpf. And she was critical in terms of actually building the balloon. They used to, he found the right kind of plastic, a PVC, and they built these balloons on the kitchen table in Andreas's apartment, where, interestingly enough, Andreas's wife, Michaela, was a therapist, and she would be interviewing patients in one room and treating them, and in the kitchen they'd be making balloons, and mostly Maria made the balloons on the kitchen table. Maria's husband, Walter, also was involved in this, as was Michaela, and the four of them really kind of traded ideas and really were the people who began making the first successful balloons. Bernie Meyer referred to them as the Gang of Four. And so that went on, and then made the first balloons, and Andreas did the first procedure in 1977, but Maria was very critical throughout the 70s, and then really helped organize these initial courses where slowly, first 20 and then 80 and then 100 and then 200 physicians would come to Zurich and see what this was all about. So that was quite interesting beginning on the kitchen table. Andreas knew that they couldn't continue just making the balloons on the kitchen table, so he went to a small company in Zurich, Schneider Medtech, and said, could you make this kind of balloon perhaps commercially? And they said, yes, we will try to do that. And a critical person in this company, who then became president very shortly afterwards, was Helene Canepa. And she talks about how they made a total of like 5 catheters a week, and they used to sell them out of a little window in the building down in the basement kind of garage for cash when the doctors would come to Zurich. And Schneider became the supplier of the first interventional balloons. And so it was interesting. Here you have the first company to really make the balloons on a scale that became important, and also train doctors how to use them, was run by a woman, Helene Canepa. Jumping over the pond here to the United States, you had a company outside of Boston, USCI, which was a division at that time of C.R. Bard, and the vice president of marketing, who was really the prime mover in terms of training, education, and distributing the first catheters in the United States and then worldwide, was Claudia Russell, who I worked with very closely. And this was, they licensed the Grunzig balloon, and they worked with him, with Schneider, and really became the #1 company making interventional equipment. Now we're talking about, the late 70s, early 80s, and these companies were all very, very small. It was not like today. There was not a lot of money. In fact, most of the companies were in financial difficulty because there just wasn't a large audience of interventional cardiologists that existed in the world. But that changed, obviously. Going to the West Coast, there was another company that started by John Simpson, who came up with a different balloon idea and also came up with the idea of putting a balloon over the wire. Up till now, all the balloons were fixed wire balloons, and they had very limited ability to get into distal vessels. His company was ACS, Advanced Cardiovascular Systems. It was a division of Eli Lilly, and it wasn't doing very well. And so Eli Lilly decided to spin it off into its own company, I think maybe to help their bottom line because the company wasn't doing very well. And the CEO of this company, which then became known as Guidant, was Ginger Graham. And she really turned the company around. She has a whole TED talk that she does, which discusses how she did this. And Guidant became, one of the leading manufacturers, along with USCI. They were really head-to-head competitors. And so you had the three major companies that were making interventional equipment, balloons, and wires, and they were all basically run by women in the beginning. And this all changed, of course, because they all got acquired by larger companies. Schneider got acquired by Boston Scientific. Guidant got acquired by, got split up between Boston Scientific and Abbott. And I think Abbott came out on the good end because they got all the balloons and stents from them. And USCI got acquired by AVE, which then got acquired by Medtronic. So, and the women in charge, were gone. They were not running these companies anymore. They've all gone on and they're working in the medical field and other fields and, have been running things. But very interestingly, in the beginning, all three companies were basically run by women. So that's the history.
Thank you. That's wonderful to hear. I'm going to bring in the other two stellar faculty. Professor Roxana Moran is the Mount Sinai and our Chair of Cardiovascular Research and Outcomes, and Professor of Medicine, Cardiology, and Population Health Sciences and Policy at Icahn School of Medicine at Mount Sinai, New York. Most of you will know Dr. Moran is the co-founder of Women as One, and which is the organization which has provided such unique and wonderful professional opportunities for women physicians. And a delight for me to say that she's the lead commissioner of the Lancet Women and Cardiovascular Disease Commission. And it gives me great pleasure, and I'm so excited both have agreed to join us, Dr. Shrila Banerjee. Dr. Shrila Banerjee is an interventional cardiologist based at Surrey and Sussex NHS Trust, just outside of London. She has a particular interest in coronary artery disease, prevention and intervention in women, and also in aviation cardiology, which I didn't know until now, which is wonderful. She is the consultant advisor to the Civil Aviation Authority. Dr. Banerjee has a huge interest in education and diversity and is an elected member of the British Cardiovascular Intervention Society and co-chair of the Focus Group for Women in Interventional Cardiology. Welcome, both of you. Thank you for making the time. Do you want to comment at all or ask Bert any questions? Because I'm fascinated. I really didn't know about these women pioneers, but I sort of had a hunch that there must be a woman involved, to be honest.
Well, no, I think, Bert, you brought out the history so beautifully. And to note that while we've seen a lot of incredible men, there have always been fantastic, strong women behind the scenes, usually. I love that you mentioned Ginger Graham. I remember her very vividly, her strong presence on the audience, her conviction in bringing forth percutaneous vascular therapies, not just in the heart, but throughout the body for, vascular as well as cardiovascular disease. And her incredible work and conviction was why all of these other companies also, came into the game. And I think there was a lot of early pioneers that maybe have not been recognized. But it's just so nice to hear the history of PCI. And Bert, you've done such a beautiful job. I don't want to say that I remember these things because then that ages me. And you see, I have no gray hair and I'm really young. And so I don't want to be saying that I remember when we didn't have stents. I remember when we used the stacked perfusion balloon, when we had a dissection after a balloon angioplasty. And I remember giving patients Coumadin and, having them bleeding out. And it was just an incredible sight. But all of that is what I think sets angioplasty apart because of the conviction and the incredible dedication of men and women in the field to bring forth a Andreas Grunzig's dream to perform these procedures in a totally awake patient and to get them out as soon as possible and give them the quality of life back that they deserve. So I love hearing these stories. Thank you for always keeping us reminded of where we were and where we're going.
Thank you. Yeah.
Srila, do you want to add anything or ask anything?
Not much, really. I've just been blown away by Bert's summary. It's amazing to think how people have innovated so much. And I'm much more of a doer. I'm not much one of those big thinkers that's going to come up with a new scheme or a new device. And I love to hear about how people have come up with these ideas. And I'm so grateful to these men and women that have trailblazed the way for people like myself and Professor Moran and Anastasia yourself as well, just all of us in cardiology who have benefited from their innovation. Thank you.
That's great. Do you want to add anything, Bert?
It was a very different time in the beginning, but there were and the thing is, at any time, but especially in the beginning, you'd walk into a cath lab where these things were starting to be done, and there was, and we can talk about this. There really were no women who were interventional.
Yeah. So why do you think that culture started? Sort of like the macho culture. Because it was innovative, because it was out of the box, because the guy who did it then got everyone to listen to them, because of the fact that, you would have these live cases that Dr. Grunzig started where, in the audience, there was one woman and all of the men were there. It was sort of like the macho culture that started in the inception of PCI, and women were in the background. And if we spoke up, we were sort of like, okay, pitch it down. And then, of course, our ideas would then be proliferated through a more male-dominated voice. And then, of course, companies also supported men more than they did women. Why was it like that? Why? I mean, I'm sorry to put, you're the only male on this panel, but why? Why? Yeah. #why?
#why? That's a great question, and I don't have an answer for that. I was going to say, if you walked into a cath lab at this time, and the doctors,
but the nurses were there to.
You walk into a cath lab and there was one man
performing the procedures, and they were all feeling good.
Yeah, well, all the techs, and I'd walk in the cath labs all over the country, all over the world. The techs and the nurse, there was one man and all women in these cath labs. I mean, pretty much there'd be an occasional man who was a tech or a nurse, but pretty much all women. And as you're in the cath lab, and where are all the ideas where, oh, watch out for this, or maybe you should do this. There's a lot of that going on. And that was a lot of women were involved in this. And I personally did a lot of the original training and product introduction, but mostly it was educational training. Pretty much everyone I ever worked with was a woman in these companies who was involved in education and involved in training. Why? I don't know. I think it's a reflection of the broader culture, perhaps. Was just mirrored in the medical field.
I mean, it was 40 years ago, right? When angioplasty first came about. So
it wasn't that long ago, was it?
Yeah, it was. It's 4 decades. And I guess back then there was a lot of, the Me Too movement wasn't really there. But But I mean, I think that culture, because it started that way, it continues to stain us, honestly, in a way that women are running away from this subspecialty, while actually I believe they would be amazing in this subspecialty because we know how to multitask. We're great with fine motor movements. We have great insight, good judgment, and care a lot about the patient on the table rather than the toys in our hands. And I think we have those qualities that are really makes for fantastic interventional vascular therapeutic, regimens for, someone who delivers that care. But yet that culture it just hasn't left us. And we are trying to see the tides changing, and we're speaking up, and we have all these climb programs, all kinds of programs that we're working on in our Women as One. But maybe we can hear from Shrilla, who's younger and more contemporary, and she's watching the change and more women becoming interested. But, that's not the answer, because they become interested, they come in, they train. But then when you go out 10 years after their training, very few of them are actually practicing interventional cardiology, because when they go into the real world, they're back in that male-dominated culture of being pushed out and overlooked and not promoted and paid less with a lot of hours, so they don't stay. So Shrilla, how are we going to change this?
I think that's a great question, Roxana. And Bert, as Bert said, it was a cultural thing. In the 70s, all the superheroes were male. The only superhero I saw as a female was Wonder Woman. And if you look, it's changing. We are seeing more and more female high-profile role models in the media and also in cardiology. So we are noticing there's been a culture shift, although it perhaps could be speeded up a little bit. And then, as you said, there's a leaky pipeline. For some years, we've known that 50% of medical graduates are female, but why aren't 50% of cardiologists female? And so we know that we lose talented women through the process of training and then becoming attendings or consultants. But it is changing, and we can see that the process will improve, but we need to address particular issues. We need to attract more women to interventional cardiology. We need to support our trainees and female consultants, because we have different issues. We have issues like pregnancy, we have issues like imposter syndrome, which can affect women and men, but predominantly women. We need to make sure that women are seen to be represented and clearly visible in interventional cardiology. And we also need to make sure that there is a zero tolerance for discrimination and harassment that some women do experience within training.
What changes we heard how it was, and we've discussed what needs to be changed. What changes do you actually think need to be implemented to bring that change about? Roxana?
I mean, to me, it's about changing the culture altogether. And I think I see a positive wave. I really do, in training programs in academic centers. What I don't see is what's really going on in the real world if women are continuing to face harassment and not, pay gaps, lack of promotion, and being told that they have to cover external clinics, and then therefore don't get the what we call in the United States RVU-based model that gives them procedures that have a higher unit of revenue producing for the hospital, where then they would be recognized. So there's a lot of things like this that goes on in the medical systems here now. Every procedure we do has some kind of a unit of revenue that has been assigned to it. And if those procedures that have the highest value are being performed mostly by men, it's almost going to be impossible for women to crack that glass ceiling. Because in some ways, and I hate to monetize this, but unfortunately, it's kind of gone in that direction. you then get promoted based on what you're bringing to the table. And if you're always constantly covering the weekends and taking care of chest pains and atrial fibrillation and referring procedures to the guys in the lab, then you're never going to be the one who shows that you brought value to the table. And so therefore they could say, well, we're paying value-based and we're equal, but actually you're not equal because you're not given a chance for women to do the work that produces the revenue that you're looking for as your promotion. I mean, to me, the RVU model is a four-letter word, honestly. I hate it. I think it's changed the platform of medicine and care for humans. But if that's the way we're going, that culture is a very, very difficult one for women to get into, because we're just not going to be, most women who go through all of this are not doing it for the value of the bank, what they're making in their bank, but rather for what they're bringing and how, because it's so damn hard. It's a lot easier to make money elsewhere faster and quicker. It's so hard for a woman to figure out everything else that.
I spend about half my time taking care of patients and the other half of my time running clinical trials, often very big international clinical trials. So first, it is fabulous to be back face-to-face here at ESC, COVID pandemic under control, because so much of this is about relationships. And so it's great to collaborate and network with my colleagues from around the world. What I think is most promising with regard to clinical trials is the opportunities that technology brings to make trials simpler and faster and more patient-centric, and take more of the trial to the patient rather than the patient having to come to the hospital or the trial site. And with more clinical trials, better, faster clinical trials, we get better quality evidence and can take better care of patients. So that's what I think is most exciting. One thing that we all have in common is we're getting older. It's really critically important that the next generation of researchers learn from the current generation of researchers, and the best way to learn is by doing. And so I would encourage young investigators who are interested in clinical research to network. Go meet your peers who are interested in clinical research, go meet the older clinical trialists and figure out how to get involved. And there's lots and lots of opportunity. And I think the cardiology clinical trials environment is very supportive of bringing up junior investigators into important roles in clinical trials. So it's an important thing that I'm passionate about, and part of my career. And I think it's really about networking and making relationships. I'm John Alexander. I'm a cardiologist and professor of medicine from Duke University in North Carolina in the United States. Factor XI inhibitors are a new class of drugs that inhibit one factor, Factor XI, in the coagulation pathway. And they're really new, and there are about 4 or 5 of them that are in development. Asundexian, which is being developed by Bayer, is one of them, and that's what we studied in Pacific AMI. And the hope is that they will have some advantages over existing antithrombotic drugs, like aspirin, like the P2Y12 inhibitors, clopidogrel, ticagrelor, and prasugrel, and like other anticoagulants, like vitamin K antagonists or warfarin and rivaroxaban, that have limitations, that have benefits, but also have limitations in patients after an acute myocardial infarction. So we like to lump all anticoagulants together, but they're really different. So Factor XI is in the contact activation pathway, and asundexian inhibits it. Rivaroxaban, apixaban, and edoxaban inhibit factor 10. Factor 10 is necessary for the initial generation of thrombin, and we think that thrombin is key for hemostasis, to stop blood, to cause a blood clot, to stop bleeding. But thrombin has a feedback loop and generates this huge explosion in thrombin generation and activity. And that is through the pathway, the contact activation pathway that includes factor 11. And so inhibiting factor 11, we think, will inhibit this burst of thrombin activity and hopefully prevent recurrent heart attacks and recurrent strokes, but still allow a little bit of thrombin to be generated to stop bleeding. So Pacific AMI was a phase 2 clinical trial. We studied patients with a recent acute myocardial infarction. People could be enrolled within 5 days after their acute MI. They had already undergone PCI, or the initial stabilization after their acute MI. And all patients were treated with aspirin and one of the 3 available P2Y12 inhibitors, clopidogrel, prasugrel, or ticagrelor. And then patients were randomized to one of 3 doses of asundexian, 10, 20, or 50 milligrams a day, or placebo. And then they were treated for up to a year, and we followed patients for that year plus an additional 2 weeks. Our main outcomes were factor 11 levels, bleeding, and recurrent ischemic events. We saw a nice dose response in the level of inhibition of factor 11. So the 10 milligram dose inhibited about 70% of factor 11, the 20 milligram dose about 80%, and the 50 milligram dose more than 90% of baseline factor 11 activity. So that's good. We got the drug work to inhibit factor 11. There was really no increase in bleeding with factor 11 inhibition, including at 50 milligrams. So that's consistent with a hypothesis and is really why these drugs are being developed. So no increase in bleeding. Unfortunately, we didn't see a reduction in ischemic events either, but you have to be careful. This is a phase 2 trial. There were only about 20 to 25 events per arm, and the confidence intervals are still really wide. So this sets the stage for the next trial, the phase 3 trial. Bayer, the sponsor, has a large phase 3 trial program planned that'll include trials in atrial fibrillation and stroke. We're still in discussions with the sponsor, with Bayer, about a phase 3 trial in acute MI. There's not one planned right now, but we're still trying to figure out the perfect design. This is going to be, the next 10 years, you're going to see a ton of results around factor 11 inhibitors, just like we have for the last 10 years around factor 10 inhibitors. And it's quite likely that they will revolutionize the way we take care of patients. So stay tuned.
You can't give what you don't have. And so self-care is the process of filling your tank.
Don't let people bring you down. You just keep working and you lift them up.
It's for the passion that you do the action, and then the results you leave to the destiny of the product.
Ultimately, life is about relationships, and it's important, I think, trying to foster relationships that are fulfilling ones.
I really am the example of an impossible dream, honestly.
Hello, everyone. Welcome to another episode of Parallax.
Well, I think it's a great time to be a scientist, especially in the field of cardiovascular disease. Myself in particular, I'm a stroke neurologist who's interested in stroke prevention, as well as the interface between reducing ischemic vascular events and people who are prone to bleeding. And particularly now with the emergence of factor 11 inhibitors that may be able to reduce thrombosis without increasing the risk of bleeding, as well as some anti-inflammatory medications such as colchicine that could also do the same. I think is really exciting new paradigm of medications that will be able to further reduce ischemic events without translating to a higher risk of bleeding. And this will be particularly important in older patients who have intrinsic small vessel disease of the brain that lead to hemorrhage, or those who have already had bleeding in the brain. And with advances in technology and pharmacotherapy and mechanical treatments, I think right now we're really at a kind of exponential increase in potential therapeutics that could help our patients. Definitely being a clinical investigator, a clinical scientist is challenging in terms of trying to balance work-life priorities and demands. However, it is very, very worth it. And some advice is find a strong altruistic mentor. I would never be in the position that I am now presenting these results if it wasn't for very strong and kind and altruistic mentorship that I've had in my institution, such as people like Robert Hart, Mike Sharma, Stuart Connolly, as well as other very impactful people throughout my training. And if you happen to fail, try and try and try again. For instance, for grant writing, getting rejected is basically the rule initially, and you have to keep trying until you get your first grant. And then try to adapt to the strengths of your environment, right? You're going to be shifting from one institution to another when you go from training to clinical practice, and sometimes the strengths there may not be what you're used to, but if you adapt to them, I think that's your greatest chance of success. Hi, my name is Ashwin Shwamanesh. I'm an associate professor of medicine in the Division of Neurology at McMaster University and a stroke neurologist and scientist at the Population Health Research Institute in Hamilton, Canada. There's a large unmet need that's being addressed with the Pacific Stroke Trial. We are targeting patients with non-cardioembolic ischemic stroke. This subgroup of ischemic stroke patients accounts for 75% of patients who suffer an ischemic stroke. And in 2019, there was about 12 million individuals with stroke worldwide, or incident stroke worldwide. At present, despite guideline-recommended treatment, there is a substantial risk of stroke recurrence in patients with non-cardioembolic ischemic stroke that is above 6% per year. So our aim and the importance of this study is to be able to address this unmet large residual risk of stroke recurrence. And we're also using a novel medication that may be able to further reduce this ischemic stroke risk without increasing bleeding, which is, of course, kind of the offsetting potential harm when you use blood-thinning medications in these patients. So the Pacific Stroke Trial was a prospective, randomized, double-blind, placebo-controlled, phase 2 dose-ranging study. Patients with non-cardioembolic ischemic stroke who presented within 48 hours of symptom onset were randomized 1:1 to 1:1 to 3 doses of asundexian, which is a small molecule direct factor 11A inhibitor. And those doses were 10 milligrams, 20 milligrams, and 50 milligrams daily. And they were compared against placebo. Our primary efficacy outcome was the composite of recurrent symptomatic ischemic stroke and covert brain infarction on MRI. As a result, all patients also had to have had an MRI either prior to randomization or up to 72 hours post-randomization, and at end study or 6 months. The eligibility criteria additionally mandated that patients be at least planned to be treated with antiplatelet therapy throughout the duration of trial participation. So this was using asundexian on top of background clinical care antiplatelet therapy. It's a very important question because that's what's really exciting about factor 11A inhibitors, and in particular asundexian, is that through direct inhibition of factor 11, there's a potential, and very exciting potential, to be able to reduce pathologic thrombus formation without increasing the risk of bleeding. And the reason for that is that factor 11 plays a very direct role in amplification of thrombus or thrombus propagation that we think leads to pathological thrombus formation. On the other hand, it has a much lesser or subsidiary role in hemostasis. So there is a very strong rationale why these medications may reduce thrombosis without resulting in an increase in bleeding. And there's a lot of epidemiologic data in patients who have factor 11 deficiency and so forth that support this. In addition, for a population of stroke, it is important because we know that patients with ischemic stroke have higher levels of circulating factor 11, and also those who have inherent factor 11 deficiency have lower risk of stroke compared to the general population. So it makes it a very attractive candidate for optimizing stroke prevention. So our primary analysis did not demonstrate a dose-dependent effect on the composite outcome of recurrent symptomatic ischemic strokes and covert brain infarcts and MRI. However, this was driven by a lack of effect on covert brain infarcts, which accounted for about 75% of our composite primary outcome. When we look at the more clinically relevant outcome of symptomatic ischemic stroke, there was a suggestion of a 20% relative risk reduction with asundexian 50 milligrams relative to placebo, and this did not reach statistical significance, but there was a strong numerical trend there. And then when we looked at the post hoc exploratory outcome of the composite of ischemic stroke and TIA, we did notice a dose-dependent effect in reducing this composite outcome with asundexian, leading to roughly a 35% risk reduction in this outcome with asundexian 50 milligrams daily versus placebo. And we were also very interested in looking at subgroups of patients that had indication of atherosclerotic disease. And this was based on another trial called the COMPASS trial, where patients who were receiving rivaroxaban with or without aspirin, the combination of low-dose rivaroxaban and aspirin, and who had systemic atherosclerotic disease, these patients had improved ischemic stroke reduction with combination therapy or dual pathway inhibition when combining a small dose of an anticoagulant with an antiplatelet agent. So for this reason, we were very eager to see our effects in patients that had indication of systemic atherosclerotic disease. And we looked at this in two ways. One, we looked at patients who came into the study and their qualifying stroke met criteria to suggest it was due to large artery atherosclerotic disease. And in these patients, there was a larger effect size of a 45% relative risk reduction in the composite outcome of ischemic stroke and TIA with asundexian 50 milligrams daily versus placebo. And in those that had any indication of atherosclerotic disease, so they had atherosclerotic disease on vascular imaging of their aortic arch, carotid disease, or intracranial vessels, in those patients there was actually a very robust 60% relative risk reduction in the composite outcome of ischemic stroke and TIA with the 50 milligram dose versus placebo. And this was all combined with no suggested increase in bleeding. So we did not find a statistically significant increase in our primary safety outcome, which was the composite of major bleeding or clinically relevant non-major bleeding as defined by the International Society of Thrombosis or Hemostasis. I think, well, the take-home message is, one, of course, this was a phase 2 study, and the results are too preliminary to be implemented in clinical practice at this time. However, very, very exciting results demonstrating potential strong efficacy with asundexian relative to placebo, particularly the 50 milligrams daily dose, for addressing this unmet need of high rate of recurrent stroke in this population, particularly in those with atherosclerotic disease, and importantly, without increasing bleeding. So I think these are very promising and exciting results for a subsequent phase 3 trial to confirm these findings before they're applied to clinical practice. So we're really, of course, excited to see if we can confirm these findings in a phase 3 trial, and we're working towards the development of such a trial.
You know, I think I've been excited about cardiovascular science since I was in medical school. It is a rapidly developing field, and the developments have just continued to increase. One of the nicest things I have to say about 2022 is meeting people again in person. Research is a collaborative effort. You bounce ideas off each other, and I can't tell you how nice it's been now to sit with colleagues, some of whom you haven't seen in person in over 2 years, and talk over ideas. There are really exciting developments happening right now in the field of prevention, Lp(a), and what we've been working on with factor 11 inhibition. I think we're in the dawn of entirely new classes of agents to help prevent disease. I think that the best advice I can give was something I received when I was young, and that is research should be fun. So do things you enjoy, do them with people that you like working with, and you'll end up being more successful than you realize. You're going to spend a lot of time and effort doing research, and you don't want it to be drudgery, you don't want it to be painful. Focus will come as soon as you find things that you enjoy. I'm Mike Sharma. I'm a stroke neurologist at McMaster University and the Population Health Research Institute in Hamilton, Canada. So patients who've had a recent ischemic stroke or high-risk TIA have an absolute risk of a stroke within the first 90 days between 6 and 10%, so really quite high. We've made some advances with antiplatelet agents using aspirin in combination with clopidogrel, and most lately aspirin with ticagrelor. These things, however, have come at a cost of increased bleeding. So the standard of care at the moment for minor ischemic stroke, high-risk TIA is dual antiplatelet therapy. The reason we chose to add this factor 11A inhibitor on top of dual antiplatelet therapy is that we wanted the comparator to be the best standard of care available to us. It also gave us the opportunity to test the safety of this agent in combination with antiplatelet agents. And certainly at phase 2, when we don't have evidence of efficacy, we did not want to leave patients in the trial without the standard of care. So as a result, patients in axiomatic SSP received one of 5 doses of milvexian on top of aspirin and clopidogrel for the first 21 days, and then aspirin from day 22 to day 90. So we looked at patients who had high-risk TIA, defined as having an ABCD2 score of 6 or 7 or motor symptoms, or mild to moderate stroke, NIH stroke scale of 7 or less, and we randomized them within 48 hours of symptom onset, so very rapidly after the occurrence of the index event. The strokes were non-lacunar and non-cardioembolic, so we avoided patients who had an indication for anticoagulation and also small vessel disease, which appears from previous studies to respond less well to antithrombotic therapy. All patients, whether they came in with TIA or stroke, had to have visible atherosclerosis in a feeding vessel. So it could be in the aortic arch, in the carotids, in the vertebral arteries, depending on the area of the brain that was affected. They were randomized to one of 5 doses of milvexian or matching placebo, and the doses had a 16-fold range from 25 milligrams once a day to 200 milligrams twice a day. Everyone was on dual antiplatelet therapy, aspirin and clopidogrel for the first 21 days, and then on aspirin 100 milligrams a day by itself from day 22 to day 90. Our composite efficacy endpoint was a combination of symptomatic ischemic stroke and covert infarcts. So these are infarcts we detect on MRI, looking at the 90-day MRI compared to a baseline MRI, so we know they've occurred during the period of this study. In the primary outcome, which combined covert infarcts with symptomatic ischemic stroke, we saw numeric reductions in this outcome for the 50 milligram twice a day and 100 milligram twice a day doses, but overall we did not see a dose response curve. However, when we looked at each component separately, what you note is that the covert infarcts don't respond at all. However, Symptomatic ischemic stroke did respond. Every dose of milvexian, apart from the highest dose, had a lower rate of stroke than placebo, and there was a 30% reduction compared to placebo for doses between 25 milligrams twice a day and 100 milligrams twice a day. This all occurred with really outstanding safety. There were no fatal bleeds. There was no increase in intracranial hemorrhage or hemorrhagic transformation of the ischemic stroke. Most of the bleeds that we saw were GI bleeds, and the rate in our trial ranged from 0.6% to 1.5%. Again, there wasn't a dose response for bleeding, however, numerically increased in the 50 milligram BID dose and higher doses. So, the real prime function of a dose-finding trial such as axiomatic SSP is to find a dose that we can take forward. Here we have 3 doses with efficacy that was actually higher than we predicted at the outset, and outstanding safety when combined with antiplatelet trials. So the next step is an adequately powered phase 3 trial, and I think likely to study a similar population to the one we studied in phase 2. So that should start as quickly as possible. So, I think that if we get to the stage where things work as we expect, there'll be a huge impact on patients. Stroke is a devastating condition, and we have about 12.2 million strokes each year in the world, and it results in significant disability. So looking at these patients who are at highest risk of death or disability due to stroke and reducing the chance of that occurring, I think is of great benefit. What's limited us in the past is the bleeding hazard. And what we see early on is benefit without a significant increase in bleeding. I do want to say that that we have to be careful in our claims. It's not the case that we expect no bleeding. We will see some bleeding with all antithrombotics, but we hope that the trade-off is as we predict, and the serious bleeding just doesn't occur. So this has a potential to really revolutionize stroke prevention. For clinicians, I think that having a very effective tool in the toolbox is important. If things work as they did at phase 2, I think we're going to have to be more conscious as clinicians of the underlying stroke subtype, and particularly look early for atherosclerosis underlying the stroke.
Hi, my name is Manesh Patel. I'm the Chief of Cardiology and co-direct the Heart Center at Duke University, and I'm an investigator at the Duke Clinical Research Institute. We have patients with atrial fibrillation, and we've had advances in the anticoagulation of our patients. We've gone from warfarin to DOACs, or direct-acting oral anticoagulants, such as apixaban or rivaroxaban. But we still have patients with unacceptable bleeding, and a lot of patients who don't get therapy. So the background to this study is, are there new therapies that we could use in patients like that? And asundexian is a new small molecule that inhibits factor 11, and it was studied in Pacific AF. Pacific AF is a phase 2 study, and it's looking at understanding the dosing of asundexian, a small molecule that inhibits factor 11 and is minimally renally cleared. We used 20 milligrams and 50 milligrams once daily of asundexian and compared it to apixaban with standard dosing in 750 patients with atrial fibrillation. We followed them for about 3 months to see what the rates of bleeding were. The reason we're looking at bleeding is to understand the dosing relationship with asundexian and apixaban for bleeding as we get ready to do a large phase 3 outcome study. It's important to recognize a lot of ways can be evaluated to see how patients bleed. And this was done during the COVID time. The patients were patients with atrial fibrillation and a CHADS-2 VAS score of about 4. Many of them had some renal dysfunction, many comorbidities, heart failure, diabetes. There were 48 total bleeding events, and even though ISTH major and non-major clinically relevant bleeding was the primary safety evaluation, and what we found is both doses of asundexian had less bleeding than apixaban, about 50% less. Small numbers, but at least encouraging to show us that seems to be a safety profile for the therapy. Currently, I don't think these findings can affect clinical practice because the therapy is still being evaluated. Pacific AF is one of 3 studies. There's an AMI study and a stroke study, and through that we'll learn about the dosing of the drug as we get ready for large phase 3 studies together. So these phase 2 studies will help us. What's important, though, is that we want to engage patients. So we are doing something called Pearl AF. People can go to afibopportunities.com and later this spring participate and tell us what matters for them if they have atrial fibrillation. Are they interested in being in the study? We hope that these types of trials and agents will tell us in the future how to get to a better place for our patients with atrial fibrillation. Yeah, the critical next step is to actually design phase 3 or outcome studies that engage more people, more women, more underrepresented patients, more patients from around the world that previously have not been in trials, and hopefully develop ways in which these therapies work across those broad populations to increase the adoption of new therapies. I think we all know that many patients with atrial fibrillation have a risk of stroke and systemic embolism. Currently, clinically, we don't treat them because of a bleeding risk. The take-home message of this is Factor XI assay has shown us that asundexian inhibits 90% of Factor XI activity, and at that rate, we have looks like 40 to 50% of the bleeding of apixaban, so encouraging for the phase 3 data.
My name is Mandeep Mehra. I'm a professor of medicine at Harvard Medical School and the distinguished William Harvey Chair in Advanced Cardiovascular Medicine at the Brigham and Women's Hospital in Boston, Massachusetts. Momentum 3 is the largest trial looking at comparative effectiveness of 2 left ventricular assist devices, the HeartMate 3, which is a novel, fully magnetically levitated pump, and the HeartMate 2, an axial flow pump, an older generation pump. These are pumps designed for use in patients with advanced heart failure, those who are escaping the effects of benefit from pharmacological therapy, most of whom are bound or nearly bound to IV inotropic support or maintain a functional status at home that is naturally bedbound to some extent. This trial was originally started in 2015, and the 2-year follow-up of this trial, which was considered to be its complete follow-up, was concluded in 2018 with the final report provided in 2019. As a condition of approval of the HeartMate 3 pump, the US FDA mandated a 5-year follow-up of this particular trial. And the current analysis is really outlining the outcomes at 5 years for this trial. The device itself, the HeartMate 3, is a fully magnetically levitated left ventricular assist device. This is a device that is almost frictionless. It has very wide blood flow paths and is also designed with an intrinsic pulsatility algorithm that prevents stasis within the pump. The engineering of this device was designed to really overcome one of the most vexing dilemmas that we had with left ventricular assist device therapy, which was the notion of hemocompatibility related adverse events. And these included gastrointestinal bleeding, strokes, as well as de novo pump thrombosis, which required reoperation of the pump. This study is a one-to-one randomized study to the fully magnetically levitated, more hemocompatible pump, the HeartMate 3 and the HeartMate 2 axial flow pump. This study included over 1,000 patients who were initially followed to the completion at 2 years, and then the current analysis mandated continued follow-up to 5 years. Of note, at the 2-year reporting, this particular study showed that the HeartMate 3 pump, the fully magnetically levitated pump, was superior to the axial flow pump on indices of hemocompatibility-related adverse events, including near elimination of pump rethrombosis requiring reoperation, a halving of stroke rates, and a third reduction in gastrointestinal bleeding. What was not shown, however, at the 2-year mark was a difference in survival between the two pumps, and that really left a question in the field as to whether these changes that we've seen in terms of morbidity translated into long-term outcomes. At 5 years, we found that the HeartMate 3 fully magnetically levitated pump, in fact, achieves a significant survival benefit. The 5-year survival now is approximately 60% with the HeartMate 3 pump, as compared to 40% with the HeartMate 2 axial flow pump. This actually translates into a median survival benefit with the HeartMate 3 pump that exceeds 5 years of life prolongation, something we have just absolutely not seen with this technology in this very, very sick population of patients. The first point I'd like to make is that not only did we show and confirm a survival benefit at 5 years plus, but we also confirmed the initial superiority on hemocompatibility-related adverse events. And in fact, much of the attribution of reduction in mortality was a result of reduction in hemocompatibility-related cause-specific deaths in this particular trial. That is not to mean that there aren't challenges with the pump technology moving forward. For example, we did not show a difference in heart failure or infection-related deaths in this particular trial, indicating that we do have more opportunity in the field as we move forward. There are complications that can occur with late degeneration of these device components, particularly one of the peripheral components, the outflow graft, can in fact have some constriction or narrowing over time, which results in low flow states, but can be very easily mitigated if diagnosed and surgically or percutaneously interventionally treated. So this is something that clinicians have to stay vigilant for with this particular pump, but this hasn't really resulted in a major negative in terms of its long-term survival. What we're really pleased to note is that for the first time in a population of patients with a median survival that is less than a year, these are IV inotropic therapy bound patients with advanced heart failure who are no longer responding to pharmacological therapy as they should, that we can in fact prolong the lifespan by over 5 years, and that is something not seen in this field before this observation. Yes, we believe very strongly that patients who are transitioning from chronic heart failure, who are very stable on guideline-directed medical therapy, who now are escaping the effects of these guideline-mandated medical therapies or are unable to tolerate this. For example, these are typically patients who are having repetitive hospitalizations. These are patients unable to titrate guideline-directed medical therapy to goal, or we are having to reduce this therapy down in these patients. Are likely candidates for this. Patients who require more and more diuretic therapy in a staircase manner to, in fact, keep them stable are all candidates for this particular therapy. These are classically patients who are nearing the need for IV inotropic therapy use or require IV inotropic therapy use during hospitalizations, but also bed-bound patients, patients who are in fact suffering from a very, very poor quality of life with advanced heart failure are all particularly good candidates for this particular treatment option.
I think that the most exciting part of cardiovascular research at the moment is the application of big data, and I'm a very big fan of acquiring big data resources to truly let us understand the statistical distribution of outcomes and parameters that we measure as they relate to mortality. And this is game-changing because we've had small data sets extrapolated to large populations, and what we need is large data sets that we can extrapolate to the general population. Leadership is a deprivation of self. It's an understanding that we need a multidisciplinary, multi-speciality collection of individuals to synergize together to create things more as a group than we can on our own. And leadership really feeds into bringing those groups of people together and allowing people to flourish. And I think that's incredibly important, to empower people to feel safe in their environments, to work together to make mistakes, but to collaborate collectively to the betterment of the outcome for the patients that we serve. My name is Professor Jeff Strange from the University of Sydney, Australia. I'm the Chief Investigator of the largest echo study in the world, the National Echo Database of Australia. So we have been working on producing an artificial intelligence decision support software for the detection of aortic stenosis. Aortic stenosis is underdiagnosed globally. At best, we're transferring less than 70% of patients onto receiving their aortic valve repair or replacement, and we need to work better with our echocardiographic colleagues to identify the right patients at the right time to go to the heart valve team. Yes, so we've developed an artificial intelligence decision support software that uses a modified mixture density network, neural network, which is a fed-forward network that takes the Gaussian distribution of outputs of all the echo variables, all of the structural changes in the heart, and it uses all of that information to predict those patients that will have a poor outcome with aortic stenosis. So the study design is a clinical cohort study of real-world echocardiographic data fed into a neural network that derives the multi-dimensional relationships between ventricular response, atrial response, and the pulmonary circulatory response to a stenotic or stiff valve. And the way that the artificial intelligence works is it takes that multi-dimensional relationships and gives a probability output that the patients will have a risk stratification, either severe, moderate, or low risk, for a mortality event within 1 to 5 years. Yeah, so we're excited to present our artificial intelligence decision support software at the hotline session at ESC on Sunday the 28th. We're presenting data on 1 million echocardiograms on more than 630,000 individuals, where we've trained an artificial intelligence algorithm to risk stratify patients with severe, moderate, or low risk aortic stenosis phenotype. Aortic stenosis, as I said, is very underdiagnosed. We estimate that less than 10% of patients are making their way through to the heart valve team for a decision on what valve strategy to put into patients. So what we need to do is reframe the way that we're communicating the results from echocardiography, and in doing so add an artificial intelligence algorithm to identify the right patients to go through to the heart care team at the right time. I think the time has come for a change in echo reporting. we need a call to action for our cardiology colleagues to know when to act, who to act on. We've currently got a dichotomy of guidelines that leaves people either not treated or sent for treatment, and it's a spectrum of disease, and the use of this multidimensional artificial intelligence module actually allows clinicians to understand the sequelae of what's happening in the ventricle, its response, the atrial response, and the pulmonary circulatory response to that stiff valve. And having this algorithmic decision support software is going to aid in that call to action for those people interpreting echo reports.
I am Michael Fradley, and I am from the University of Pennsylvania in Philadelphia, Pennsylvania. So various different cancer treatments can be associated with the development of abnormal heart rhythms, but the ones that we think of majority of the time causing this are the BTK inhibitors, medications like ibrutinib or acalabrutinib. However, we are also seeing this with some of the traditional cytotoxic chemotherapies, as well as other treatments such as immunotherapies. So that's a really interesting question. So there are the traditional risk factors that we know predispose individuals to developing abnormal heart rhythms, particularly atrial fibrillation. And those would be situations like known cardiovascular disease, things like ischemic heart disease or cardiomyopathy or heart failure, hypertension, diabetes. However, we are also still trying to learn some of the specific unique risk factors for the cancer patient population that may increase the risk. So while we can certainly say that the traditional risk factors also apply to cancer patients, there are likely to be specifically unique risk factors that we're still learning about. It's quite common, and honestly probably more common than we recognize. So in some series, we're seeing that upwards of 15 to 20% of individuals may have an abnormal heart rhythm in the setting of their cancer treatment. So I think both is probably a good idea. So again, I think that screening ahead of time, at least getting a sense of a patient's baseline risk factors, some of those traditional risk factors that I spoke about would be helpful. Now, in terms of initiation of preventative strategies, there's probably not yet a role to be doing that, but at least we can start to identify people that we think may be at increased risk, and that might allow us to better determine who we should monitor for arrhythmias during treatment. The best way to approach monitoring these patients is still up for debate. Does this involve simply evaluating when a patient is symptomatic, or does this take on a more proactive approach where we start utilizing ECGs or perhaps wearable devices that we now have at our disposal to better identify individuals who develop these problems? Well, I think the first step is that in order to best manage this condition, we have to have a better understanding of what the true burden of the disease is. And I think that we don't fully understand or grasp how many people are having this problem, because traditionally we have relied upon patient-reported symptoms or abnormalities in vital signs. However, we know arrhythmias are a problem that can come and go, and a patient may not always be symptomatic, or they may not always have an abnormal vital sign when they're being evaluated by a healthcare provider. And for that reason, we need to do a better job in terms of really identifying what the true incidence and prevalence of these problems are. And I think that's where we can really start to focus on some of the novel technologies that we have at our fingertips, utilizing wearable devices, and really sort of engaging patients to be active participants in the monitoring of their heart rhythm.
Hi, I'm Dr. Lauren Baldessari, and I am Associate Professor of Cardiology and Radiology and Biomedical Imaging at Yale School of Medicine. One of the greatest benefits of cardiac MRI in patients is that it gives not only structure and function information that one can get from some other imaging studies such as echocardiography, ultrasound, but it also gives additional information about what we would call tissue characterization. And that is looking a little bit closer at the muscle tissue of the heart, where we can look at things like fibrosis or scar. We can look at inflammation. And this is very important in many cardiology patients, but specifically in cardio-oncology patients, especially when they are undergoing therapies that may have some effect on the heart, either during therapy or after receiving therapy. And we can take a closer look to see if there has potentially been any effects on the muscle of the heart. I think every cardio-oncology service, of course, it would be ideal to always have cardiac MR at your fingertips for patients. But, at the minimum, for certain patients where it is indicated, to at least have a referral center that patients can be sent to. But in general, yes, like cardiac MRI is an important component of a cardio-oncology practice and the imaging practice of cardio-oncology. So not every cardio-oncology patient needs a CMR. There's certain indications where one might want to use or consider cardiac MR. One of those indications is even just to simply look at structure and function. When, for example, other imaging modalities that we would normally go to first for that question, such as echocardiography, ultrasound of the heart, sometimes there's certain situations where images might not be diagnostic with those imaging modalities. And cardiac MRI is considered, the gold standard for cardiac, function and volume. So when we really need to get a very clear answer about that for a patient, which could have implications for their cancer treatment plan, then we can reach for cardiac MRI to give us answers about the structure and the function of the heart in a very accurate way. And then additionally, on top of that, as I had mentioned previously, there are some situations where we want to look beyond that. We want to look at the muscle of the heart to see if there is, potentially inflammation that can happen from certain cancer therapies or some scar or fibrosis that could happen as well. It's about, picking and choosing the right imaging tests for the right patient at the right time. So certainly not all patients need it, but there are frequently circumstances where it is appropriate to order cardiac MRI in our cardio-oncology patients. So in general, cardiac MRI is, a bit more expensive than, for example, ultrasound echocardiography. And so, that's one of the reasons why we don't reach for it as the very first test. However, it is an affordable test. It is, it can be used. We can do it with contrast. We can do it without contrast. There are abbreviated protocols that can be done to answer very specific questions in a short period of time that, use less, financial and time resources. So, I think, again, it's using the test when it's appropriate, at the right time for the right patient, not just applying it to all patients. Well, I think the best way to convince oncologists is to show them, the utility in their patients. We work very closely with oncologists. They often send them to us when there's a cardiac question or concern. And when we do order a cardiac MRI, and it does help change, our diagnosis and management, we communicate that very closely and clearly with the oncologist to help develop a plan, next steps for that patient's cancer care. And I think when they see that, they see the utility of how it really clearly answered a question and helped to move forward with a good plan for that patient and their cancer care, then it's pretty easy for them to see the benefit. And sometimes even oncologists in certain circumstances will order a cardiac MRI on their own. They know, after working with us and others, to help take care of many patients, that sometimes they even know when they can order one. They don't even always have to refer to us to do that.
My name is Dr. Ann Blaze. I'm a medical oncologist and associate professor at the University of Minnesota in Minneapolis, Minnesota, where I'm also the director of cancer survivorship services and translational research for the Masonic Cancer Center. So when I see patients with breast cancer, there are a number of things that can cause cardiac issues or heart complications after their therapies or during their treatment. Some we think of as chemotherapies, such as anthracyclines or trastuzumab, otherwise known as Herceptin. The anthracyclines for our breast cancer patients, these are your medications like AC or EC. These are the anthracyclines that can disrupt microtubules in the cardiac myocytes of the heart itself and cause heart failure-like symptoms. Trastuzumab or Herceptin can cause cardiac dysfunction in a different mechanism and is oftentimes reversible when we stop that medication. Other types of therapies, some of the medications that are used can cause hypertension or hypercholesterolemia. When patients receive breast cancer treatments such as radiation, there's a slight increased risk of cardiac ischemic disease or higher rates of cardiovascular disease in individuals who have left-sided breast radiation compared to right-sided breast radiation. And then some of our newer medications like immunotherapy that are now being used in triple-negative breast cancer have rare complications where they can affect actually the inflammation in and around the heart. This is a rare complication, but something that can happen with those treatments. Yeah, typically I tell patients, you want to know the treatments that you've received. So you want to know the names of the chemotherapy drugs, whether or not you received radiation, how much you had, as well as the anti-estrogen therapy that you might be receiving. There are traditional cardiac risk factors, such as things like hypertension, hypercholesterolemia, diabetes. These can all augment or increase the toxicity or the potential for somebody to have heart complications after their breast cancer treatment. So typically when I see patients, I'll talk to them about those risk factors up front. Are we working with a primary care provider to optimize those risk factors, such as is your blood pressure under good control? Has your cholesterol or blood sugars been checked recently? But we also talk about those things during the course of treatment and in the survivorship period. When blood pressures are elevated in our breast cancer survivors, they actually can augment or increase the risk for later complications after their treatment. It depends when I think about heart risk in individuals who've gone through breast cancer treatment, it's important to know how much of particular drugs they've received, as well as the types of treatment. So really having a treatment summary can impact sort of what that risk is. For example, a patient who received anthracycline, such as doxorubicin, their risk of cardiac dysfunction may be on the order of 3 to 4%. This is dose related, so it all depends on how much somebody received. If you received, for example, 4 cycles of AC as part of your breast cancer treatment, you received a total of 240 milligrams per meter squared of doxorubicin, giving you an ultimate risk of heart complications of approximately 1 to 2%. This risk increases significantly if somebody had larger amounts of the medication and can go up into the order of 10 to 12% and sometimes even higher. As oncologists, when we prescribe these medications, we take very good histories about whether or not somebody might have received that. For example, if someone had a prior lymphoma and they might have received chemotherapy and now has breast cancer, this might increase that risk of cardiovascular complications. So as oncologists, we oftentimes will ask, can I give a different treatment and get the same outcome? For other medications like trastuzumab or Herceptin, the risk of cardiac issues is a few percent. I think what's not always recognized, though, is the fact that many of our breast cancer patients are getting older, and as they age, they are also at higher risk for things like high blood pressure, high cholesterol. There was a recent publication in JACC Cardio-Oncology looking at our older breast cancer patients, and as women get farther out, 7 to 8 years after their breast cancer diagnosis, actually their cardiovascular risk surpasses that of a breast cancer recurrence. So thinking about ways to reduce that risk is really important. So when I think about somebody and their heart risk and they're sitting in front of me with a new breast cancer diagnosis, it's important actually to think about heart risk throughout the course of their treatment. So at the time somebody originally presents with breast cancer and I'm making a prescription on how to treat their breast cancer, we should be thinking about those risk factors at the very get-go. Asking ourselves, do they have other risk factors? Are they an older individual? Do they have some of the risk factors that I mentioned, such as high blood pressure, high cholesterol? Am I prescribing one of these medications, such as an anthracycline? Will they need radiation, such as left-sided breast radiation, which can slightly increase the risk of heart complications? And do they have prior heart disease or prior history of heart failure? If they have any of those risk factors and part of their treatment requires me to use some of these medications that can affect heart function, I would recommend that they see a cardio-oncologist and have a baseline assessment. That baseline assessment can include looking at blood biomarkers such as a pro-BNP or a troponin. It may also include using a heart ultrasound or an echocardiogram to really look at the way that the heart pumps. As people go through their cancer treatment then and are actually on treatment, we typically will follow their cardiac function, particularly if they're receiving medications like anthracyclines or trastuzumab-based therapies. For trastuzumab-based therapies, these are typically heart ultrasounds are recommended every 3 months during the course of their treatment. This can sometimes be modified for patients that are in the metastatic setting and are receiving these types of treatments for many years, particularly if they've had no complications. And then for individuals in the survivorship period where they may be done with their treatment and their cancer has been cured, we also talk about cardiovascular risk and risk reduction. As I mentioned, there are several cohort studies actually emphasizing the fact that our older breast cancer patients are at higher risk for cardiovascular disease than the general population. And as a result, it's important we work with primary care doctors to optimize their risk factors, such as blood pressure, cholesterol, helping to make sure that they're avoiding tobacco use. And all my patients in clinic will hear me say, keep moving. So I think it's really important that individuals are exercising regularly. That may be moderate intensity walking, 30 minutes most days of the week, 5 to 6 days a week. We know that that helps to prevent recurrence and can help prevent cardiovascular complications. This is a good question. So I'm going to break your question down into kind of 2 pieces. How do we best manage this? Well, if you have breast cancer and you have some other risk factors for cardiac complications, I would first say, are there things I can do to help prevent this? We can't make our breast cancer go away without treating it, but we can be proactive about how to reduce risk factors for potential complications. This might include meeting with a cardiologist or primary care doctor to ask, what about using blood biomarkers or preventative medications like ACE inhibitors or beta blockers to help prevent any of these cardiac issues? If it's a patient who's in the metastatic setting and they're living with their breast cancer, It's important to work with cardiology and oncology about how to optimize breast cancer outcomes while keeping the heart well. What do I mean by that? So for individuals, for example, on trastuzumab, this can vastly improve breast cancer outcomes, helping these patients live for many, many years. If they have their heart monitored regularly and there is a decline in the way that their heart pumps, there are medications such as ACE inhibitors or beta blockers that can help stabilize the cardiac function. These medications can be continued through their treatment, and oftentimes it's close collaboration between cardiology and oncology in helping patients stay on their breast cancer treatment while keeping their heart healthy. And in the survivorship period, as I mentioned, I always tell patients, keep moving, avoid tobacco use, and keep an eye on your blood pressure and cholesterol and blood sugars. All of these things can contribute to heart disease and can accelerate the risk of cardiac issues in breast cancer patients.
Hi, everyone. My name is Avirup Guha. I'm the Director of Cardio-Oncology at the Georgia Cancer Center. I'm also the Assistant Professor of Cardiology in the Division of Cardiology, the Department of Medicine at the Medical College of Georgia at Augusta University. So big data is relevant in cardio-oncology for several reasons. I have 4 today to present. As you know, cardio-oncology is an overlap between cardiology and oncology. And one thing which we have issues with in cardio-oncology is our guidelines don't have any solid evidence. Most of our evidence comes as a level of evidence C, which is expert opinion. We also noticed that a lot of the cardiovascular trials exclude cancer patients and cancer trials exclude cardiovascular patients. As real-world evidence of taking care of these patients are missing. The trials in the field of cardio-oncology also lack precision, and most of the trials have been negative or equivocal so far because they're not mega trials like cardiology or oncology. And if we don't ask precision-based questions, then the trial tends to be equivocal. And then finally, I think big data is an easy way to collaborate between cardiology and oncology, thus sort of generating interest and collaboration, thus furthering the field of cardio-oncology. There are multiple questions which have been answered, and it's sort of hard to discuss each question which has been answered. What I do have is sort of 3 major papers which I'd like to point out, which are published in high-impact journals to bring to attention the fact that big data is definitely a good source of gathering data in the field of cardio-oncology, especially to elevate the levels of evidence. The first one was one where I performed this research with my colleague at Ohio State, where we looked at atrial fibrillation in patients with new-onset breast cancer. And we saw that there's been increase in breast cancer incidence when we follow these patients for a year. We also see that the breast cancer stage and grade is a risk factor for atrial fibrillation. And then finally, the new onset atrial fibrillation increases cardiovascular and all-cause mortality, but not breast cancer mortality in these patients, which was a novel and interesting finding in this big data research done using the SEER Medicare registry from the United States. And then the other data set which I would like to point out is the UK Biobank data set, which was merged with multiple other UK-based registries, where a paper published in Lancet 2019 showed follow-up in cancer survivors up to 12 years. And it was a very interesting analysis where we could see the natural history of some of the conditions, such as arrhythmias, heart failure, venous thromboembolism in various cancers over a long period of time, the natural history of which was sporadic and from single center or multi-center studies. Here we had millions of hundreds of thousands of patients, and that solidifies some of the notion we had, and it changed our notion about certain other natural histories. The third one, which I would like to bring attention to, is a paper published in European Heart Journal by colleagues in France and the United States, where they looked at the World Health Organization big data resource pharmacovigilance study using the Vigibase, where they looked at the incidence of torsades or ventricular arrhythmias due to prolonged QT, which are induced by anti-cancer medications. The most interesting part of the study is we see a shift in medicines causing this arrhythmia from traditional anti-cancer therapies to more targeted therapies, the most common one being tyrosine kinase inhibitors. And the incidence of these arrhythmias have gone up significantly in the last decade, specifically after 2014, where we have seen a lot more use of targeted therapies, and that's when cardio-oncology also has gotten into more vogue, thus sort of showing how big data is able to create a use case for having cardio-oncology as a specialty. That leaves every question unanswered so far because of the fact that we're just starting up in the field of cardio-oncology from all kinds of research standpoint. In fact, the American Heart Association just funded the Strategically Focused Research Network grant, which we were glad to be part of, where we are doing some population science big data studies to answer questions regarding disparities in cardio-oncology. But if I have to draw attention to one manuscript which sort of captures everything which needs to be done in the field of cardio-oncology, would be a paper published in JACC Cardio-Oncology with the first author, Dr. Daniel Lenihan, who's the past president of International Cardio-Oncology Society. This was the proceedings from the Sao Paulo meeting, which was held in 2018, 2019. And several things were pointed out as sort of what we need to do in the field of cardio-oncology to advance the field. And I think big data can be used to detect cardiovascular events in immunotherapy, like we are starting to find how immunotherapy is increasing the risk of atherosclerosis, understanding more about tyrosine kinase inhibitor related toxicity, as we have a lot more number of patients using big registries such as IBM MarketScan. Then to find robust predictors of cardiotoxicity, and this points back to looking at molecular big data, where we get a lot of data from one patient rather than a lot of patients with less number of fields to find biomarkers. And then we need to clarify the role of cardioprotection and also cardiovascular intervention after cardiotoxicity using directed clinical trials, which we get evidence from using retrospective big data resources. I would like to first bring to attention of how we will be able to answer the big data questions and then dovetail into how trainees can help there. So there are sort of multiple national and international registries which are being made where we could use the help of trainees to elevate the level of evidence, as we talk from level of evidence C to level of evidence B. And also the trainees could focus their attention towards getting trained in population science while doing the cardio-oncology fellowships, wherein they could use resources even outside the institution which might not be offered there, such as a massive online learning, such as edX, Coursera, etc., to learn statistical analysis to help with some of this research. As I always say, all teams of population science research, including cardio-oncology, needs dedicated statistical support, and they could play that role. The advantage of being a clinical cardio-oncology fellow would be that they could play the role of a cardiologist or an oncologist and also be the statistical support, thus making the research move faster. Additionally, they need to trainees need to focus on, when they're reading papers in which is data science heavy, to focus on the method section, because that's where the meat of the manuscript lies. If the methods are not good, then if the discussion or the results look good, then I would definitely take the results with a pinch of salt. Then as trainees become attendings and they hold leadership positions, they need to focus their institutional efforts towards investment of the electronic medical records being more of a source of data, so that rich data from the institution with a large number of patients who have already been taken care of can be made into big data sources. Additionally, institutions need to pay attention towards getting access to large data sources such as SEER, Medicare, Medicaid registries, and national registries are always there in countries which have a national insurance system, such as the United Kingdom or the Danish registry, which can be used for cardio-oncology research. Specific to trainees, I think it's important to reach out. There's data science research happening across the globe. many of us are doing data science research and population science research. Don't be afraid of hearing a no, because that's how you would find the right mentor. And also the fact that data science research can be done from anywhere using a lot of free resources which we have available online. You can actually get this research started from wherever you are, unlike other types of research. So that's sort of my final take home for the trainees.
I'd like to welcome everyone today to this webinar we have on how to set up a cardio-oncology program. We are very lucky to have a very famous speaker with us today. Dr. Daniel Lenihan is the president of the International Cardio-Oncology Society, and he's also director of the cardio-oncology program at Washington University, St. Louis. And it's my great pleasure to have him here with us. Just before we start the talk, I'd just like to say that this is going to be very interactive. So please do post your questions in the chat box at the bottom of your screen. If you can't see the chat box at the bottom of the webinar screen, please refresh your page, and please do put your questions to Dr. Lenihan, which we will address at the end of the talk. With that, I'd like to hand over to Dr. Lenihan. Thank you.
Thank you so much, Dr. Ghosh. I really appreciate the invitation. And this is always one of my favorite topics because, you know, really this is what we're trying to do internationally, is to encourage people to participate in the active development of cardio-oncology throughout the world. So we really do learn a lot from each other. And I think that's, if there's one main theme from this presentation, I think it would be that. These are my disclosures. So let's start out with the beginning. You know, what is cardio-oncology? So one definition that is out there is that it is a clinically based discipline focused on the cardiovascular health of cancer patients and cancer survivors. And so then one would next want to ask, who is a cardio-oncologist? Well, a cardio-oncologist is a healthcare provider who is focused on the prevention, early detection, management, and recovery of cardiovascular function, potentially resulting from cancer therapy. So these are some basic definitions, just so that we know who and what we're talking about. Now, initially, you know, we have observed for many years that cardio-oncology was a developing discipline. And we initially proposed it as a new multidisciplinary specialty several years ago in this particular publication. So when we focus our efforts today on, you know, what we really want to know is, what does it take to create a cardio-oncology program? So let's look at that in a little bit more detail. So this was a recent publication in Journal of Cardiovascular Translational Research. And this is basically the central figure from that publication. But if you can certainly appreciate that the principle that we're trying to emphasize is that in each area of medical disciplines, they have their own language. So certainly in cardiology, we have our own language, talking about DOACs and PCI and DAPT and various and sundry other terms that you guys are highly aware of. Well, the same thing happens in hematology and oncology. They have their terms. And they sound pretty unfamiliar to us if we don't really understand them. So that includes CTCAE, which stands for Common Terminology Criteria of Adverse Events. And then they talk about TKIs, or tyrosine kinase inhibitors, alkylating agent, checkpoint inhibitors, immunotherapy. These are all terms that are commonplace in hematology and oncology. So we really need to understand their terms, and they need to understand our terms. And the basic tenet is that communication is an essential piece, and then collaboration to identify what the needs are for the patient. Included in that is, what does it take to monitor for toxicities, and then documentation of those problems, as well as reporting from a clinical research standpoint, because for the most part, we're all trying to learn from each other, and reporting is an essential piece. If you do all of those things together, it will result in excellent care. And the whole reason why cardio-oncology was born or was created was because we wanted to maximize cancer treatment, minimize cardiovascular toxicity, with the overall goal to improve overall outcomes. So one of the tables from this particular paper is highlighted here. This was table 1, and it talked about clinical practice principles that are essential to develop a vibrant cardio-oncology program. I didn't highlight every one of them, although each one is very important, as was detailed in this table. I did highlight several of them just to give you some feel for what they're saying. So the first one is, be intentional for establishing a strong clinical connection. This is absolutely paramount. You cannot develop a strong relationship if you never go to the location where oncology and hematology providers are, if you're a cardiologist. And also, if you don't reach out and speak to them directly in person or via some communication tool. But the bottom line is that you will never develop a cardio-oncology program if you are not intentional. Then an essential item that was identified as one of the key priorities in the overall presentation is that you need to identify key administrators and clinicians in each area so that they realize the purpose and benefit of cardio-oncology service. And you definitely want to emphasize that optimal cardiovascular care has a major positive impact on those patients being treated for cancer. And truly, that is the nature of multidisciplinary care. One other sort of unique feature is, within your location, you need to ascertain what the best methods for communications may be. Some places have some sort of internal communication system that may be the most effective. Others may depend on text messaging via cell phones or some other instant messaging through email. There could be a number of different ways. But the bottom line is that you need to establish those pathways for communication, and they need to be very trustworthy. The other thing is you do need to participate in multidisciplinary meetings. The only way we learn from each other is by doing that, and especially openly discussing difficult cases in a collaborative forum is really necessary so that we can learn the expert clinicians, we can learn what their thought process is, and they can, share their experiences with us. So I think that this is this is truly an essential component, and cardio-oncology cannot progress without this type of interaction. So this table is a little long, but it's worth looking at in some detail, partly because as we were creating this table in this publication, we were really thinking about, what patient population would benefit from cardio-oncology. So this is clearly a necessary item. If you're trying to be convincing with your colleagues that, a certain patient really should be seen by you if you're the cardio-oncologist, is you need to be compelling, and you need to say, yeah, these are established reasons that patients with cancer being treated with these therapies are at higher risk than the average population, for sure, for cardiovascular toxicities. So we divided this up in terms of the first column is high baseline cardiovascular risk profile before some planned cancer treatment. And, these all make sense. These are all things that people are aware of, cardiovascular risk factors. But the other is that if they've had prior anthracycline, maybe in a previous episode of cancer, or if they've had prior chest radiation, or if they have had some previous cancer and they developed cardiovascular toxicity, then these are all very high-risk features. So it's critically important to get an accurate cardiovascular risk assessment, but also to include cancer-specific toxicities that may exist in the person's past. The next major group are those in which the planned treatment is particularly risky. So on one level, you may think everything, this day and age has significant risks, and that may be true, but truthfully, some things are more risky than others. And so finding the treatment paradigm for cancer that is associated with known cardiovascular risks is a critical element to make sure that you have an understanding of what those things are. So, obviously anthracyclines are like the oldest cardiotoxic type therapy. And so people are aware of those pretty much, that they need to follow cardiac function, et cetera. And then radiation, for the most part, people know that those things have risks, but I'm not sure that they fully know all of the possible cardiovascular manifestations of radiation to different parts of your body. So we recently had a publication in JACC Cardio-Oncology highlighting what those cardiovascular ramifications are specific to radiation therapy in all the different parts of your body. But other situations are, for example, relapsed multiple myeloma in which they're receiving proteasome inhibitors, especially in combination with other therapy. Those patients are at high risk for the development of cardiovascular toxicities. And then, of course, one of the most popular therapies in this day and age are immune checkpoint inhibitors. And these are being used in virtually every cancer at every different stage. And they're, last time I checked, which was maybe a year or so ago, there were more than 400 clinical trials happening right now in which checkpoint inhibitors are part of the therapy. So these are huge treatments, and they have known cardiovascular toxicities, and some of them are very serious. So these would be all the patients that I would say we should be proactive and try to assess them at baseline and then follow them during the course of treatment. In the third column, there are patients who are actively receiving treatment, and you need to monitor for the development of toxicity. So an oncologist or hematologist may not be that familiar with what things are necessary to monitor this patient. And cardio-oncology can add to the picture to help organize that or help deliver on the surveillance piece of these therapies. What cardiovascular toxicity can we anticipate? And then the last column is very important because, especially we've learned a lot from the childhood cancer survivors, and many years after their treatment, they have known cardiovascular toxicities. That is certainly a very important group, but also people with adult cancer that get treatment and survive it because cancer therapy is so effective. There's a large population of survivors in the world, but definitely in the United States, this number continues to rise substantially. So there are a lot of people that were treated for cancer with known therapy associated with cardiovascular toxicities. And being cognizant of those things is crucial. And so the long-term outcome from cancer therapy continues to improve. So this population is going to increase, and they will have a substantial need for cardiovascular disease surveillance. This figure really is intended to just highlight what the components are. Now you can look on the outside of this bullseye and the outer ring, and it's just the tools or the things that can be helpful in fashioning a good collaborative response with your other colleagues. So those include case discussions, cardiac safety boards, drug information sheets that you may either give to the patients or providers, and then of course, order sets. These are all tools to help enhance your collaborative practice. The next circle in just talks about, what things are really, necessary to be able to meaningfully improve practice. So these include urgent cardiology availability, integration into the patient process, proximity to hematology oncology. So you can't be separated by long distances, because you will not be able to develop a strong collaborative practice. And then we have to have structured reporting and documentation so that we can share our observations with others. Then as you get closer to the bullseye, which the bullseye would be a cardio-oncology program, as you get closer to it, what is more elemental is that you have leadership, you have a patient navigator, you have administrative help that supports you either in scheduling issues or collaboration issues, but also in funding issues. And then I think an essential element of all programs has to be ongoing clinical research, because many of our observations many of our treatment decisions are based on careful observations of our colleagues. And then of course, education is also critical throughout this whole process. So how do you establish value? There are a number of ways that you can do it. This is just a table highlighting some of the Institute of Medicine quality domains that exist out there. I'm not really going to go through this in too much detail, partly because, it's a real challenge to know what tool can establish value in your situation. But I think understanding what drives administrators wherever you work, and then also making sure that the basic point is that you've improved clinical practice, then that in and of itself is the most valuable thing that you've done. So I think that if you focus on, improving patient care, then whatever metric you use to demonstrate that is interesting and maybe unique to you. But the bottom line is that if you're improving care, then you have intrinsic value. And that is what we are confident that anybody who, meaningfully develops communication and collaboration and improves practice will add substantial value to that situation. There was a nice paper a couple of years ago in the European Heart Journal, which is highlighted here. And the European Society for the Heart Failure Association developed a very nice paper sort of summarizing many of the things that I'm highlighting here. But some of the obstacles that they put later on in their article really do summarize to a great extent what types of struggles we may have. Now, each individual place is going to have different struggles, but I do think that these are some of the high points to consider. So I think that, consensus between cardiologists and oncologists may be a challenge, but that's the reason to have those case discussions that I mentioned before. There is one of the identified barriers is a lack of professional training and with multidisciplinary teams. I'm going to highlight some efforts that we're making in the International Cardio-Oncology Society to try to minimize this as a barrier. Certainly, I think that this is something that will be required going forward. We need to continue to think about how do we enhance professional training and implement services in the broadest possible way. And then in a situation where there are no cardio-oncology services, there's, consistently there's going to be a lot of impetus for nothing to change. So that's a problem. So usually you have to develop enthusiasm and interest and commitment to improve practice. And that at the outset, it may be difficult, but usually if you stick with it and display persistence and, thoughtfulness, then I haven't really, at multiple institutions that I've been in the last decade, I really haven't felt that this was that substantial of a barrier. And once you actually started to improve practice, it was highly facilitated. So one other key element is that you need to be aware of the current literature, because right now, many of our practice decisions are based on what others have observed. So that's why I think it's essential that any program is committed to ongoing clinical research, but at the same time, you have to be aware of what others are saying. So with that in mind, I just want to highlight some of the recent major articles that are out there. This one was a consensus recommendation from the European Society of Medical Oncology. It was published in February of 2020. This is really the first truly comprehensive document looking at management of cardiac disease in all types of patients with cancer. Over the past year, there have been a number of also very important publications. 2 are already published and 1 is accepted but has not been published yet. First is strategies for COVID, for addressing COVID in cardio-oncology, was published in August of 2020 in the CA Journal for Clinicians. I already mentioned briefly that we had a radiation therapy and cardiovascular disease publication in JACC Cardio-Oncology just a few weeks ago. And then what I think is going to be a very important publication when it actually happens is a paper entitled Definitions of Cardiovascular Toxicity. This was an international effort really trying to synchronize the various definitions of common evidence of cardiovascular toxicity. So this is a very thorough and concise, thorough but concise description of the definitions. And I would encourage you to read that when it comes out. One other item that I would just like to bring forth is that, you know, the International Cardio-Oncology Society has been having annual meetings for over a decade. And the last in-person meeting was held in Brazil, and this was a proceedings from that last in-person meeting. Of note, we did have a virtual meeting about 2 weeks ago, and many of you may have been aware of it, but we really tried to cover contemporary issues in an innovative manner. Nonetheless, looking at this publication, we identified 10 priorities. Obviously, there's more than 10 priorities, but these were the top 10, or these were the ones that we thought were most important at the time. And as you can see on this figure, which was the central figure from that paper, that building the community was one of our top 10 priorities. And that's in essence what this webinar is about. How can we build our community? How can we enhance cardio-oncology throughout the world? And, you know, webinars like this one, we think are critically important for people to not only be oriented or educated about what the issues may be, but also be motivated to join in our group. Recently, we had a paper in JACC, which is the front page is highlighted here, where we tried to outline what the education and training for cardio-oncology should look like. As you can imagine, there are a lot of opinions, and there may be a lot of perspectives that differ. So understanding how to combine all of these great thoughts into a concise document was quite challenging. But the highlights of this document and others that I already showed you is that cardiovascular comorbidities and toxicities are increasingly important aspects of cancer therapy and outcomes. We don't have time today to go through all of those details, but suffice it to say, there are significant cardiovascular toxicities in every area that every cancer and every cancer therapeutic has been identified. So this is an absolute fact. The second bullet, enabling optimal cancer therapy at the lowest cardiovascular risk, is a key goal of cardio-oncology. So this is not to say that, you know, all cancer therapy causes cardiovascular problems and we don't want patients to be treated with it. That would be exactly the opposite. We want the patient to get the best cancer therapy they can get with the lowest cardiovascular complications possible. That's the basic goal. And cardio-oncology, like other some specialties, does require expert knowledge, specific skills, and dedicated training. So these are all facts. This is one of the central figures from that paper, and it highlights that on the cardiology track, you need to get exposure to the cancer therapies. So you need to understand what chemotherapy is and targeted therapies and immunotherapies. Whereas if you are on the hematology oncology track, you really need to understand more about cardiovascular issues. So you need to understand basic principles about cardio-oncology, typical pathophysiology of major conditions, cardiovascular diagnostic tools, and other cardiovascular drugs you would need to become more familiar with. And so these are elements, depending on what path you're in for your training, to where you can become a cardio-oncologist. And then these are particular elements that are highlighted on the left. And then there are different levels for which ultimately, if you want to be a cardio-oncologist at the highest level that you can, we would consider that level 3 training, and that would be equivalent to a cardio-oncology fellowship. And then green boxes on the right highlight how you get there. So the first level of training is mainly didactics. And then as you move into the second level of training, it's clinical experience in addition to didactics. And as you approach level 3 training, you need to have certification, ultimately to say that, yes, I have learned this knowledge and I know how to incorporate it. And then the last box there for accreditation is more for either practices or at an institutional level, that they would need to become accredited, that they are doing proper training, but also they're providing excellence in patient care. So these are all identified principles to enhanced cardio-oncology training. And this table just highlights more detail. I won't go through all of that, but it's pretty granular in terms of what would be required for level 1 versus level 2 versus level 3. So I would encourage you to look at this article really for a perspective of where we think training would need to go. And then honestly, there has to be some sort of clinical provision for those providers who cannot do a fellowship. So if you had previously done your cardiology training and then you went out and practiced, and because of your own collaborative efforts, now you have developed a strong relationship with, say you were a cardiologist and you developed a strong relationship with your hematology oncology colleagues, and then you are participating in our international efforts, and you are also committed to reporting on your clinical experience, then those are all the things that a fellow would do, or those are all the things that an institution would train a fellow to be oriented to. So, but these things there has to be a provision for those people who do those things in practice and over time have developed a significant experience. So we think that one way to do that is to have a board certification exam, which we started about a year ago. And here is one example of one of our first graduates that passed the knowledge certification exam for cardio-oncology. And we think that this is an important milestone in people's medical training, to say not only do they can they answer the questions, but they have shown a commitment to cardio-oncology for at least 3 years to be eligible. And then Recently, we created a ICOS board review manual, which is shown here, and that's available on the website. These are example questions and validated answers that were really intended to serve as a study guide. Additionally, I would say all the feedback that I've gotten about this, and also preparing it for myself, that I really learned a lot, and understanding, what evidence may back up a clinical decision is critically important. And we try to highlight these types of things in this manual. And then one last item that I would like to at least talk about is the Center of Excellence designation. So when a practice or an institution decides that they want to, provide evidence that they're doing excellent care, then this is the type of thing that they strive for, a center of excellence. There are other medical conditions in which these types of designations are done. And so we're just trying to bring a parallel process to cardio-oncology. So I won't highlight all of the components, but they're shown there on the slide. But for the most part, it's just providing evidence that the practice or institution is providing expertise that is unique and has demonstrated to improve quality in their practice situation. I would encourage you, if you are a practice or practice representative or an institution, and you would like to consider the Center of Excellence designation, you can get a blueprint for your institution of how to do this on the website, and it's pretty easy to find. So in summary, how do you set up a cardio-oncology program? So first and foremost, there are many things that are necessary, but without a doubt, the motivation to improve the cardiovascular care of patients with cancer is at the core. You need to develop close collaborations and communication with your colleagues. You should organize and participate in difficult case discussions. I will say that ICOS has a weekly webinar on Thursdays. Depending on where you are in the world, it's either in the morning or in the afternoon, but we consistently present difficult cases and have expert reviews and up-to-date literature discussions. So this is one way that we think is absolutely necessary to understand best case scenario, and also understand from worldwide experts how to work through a challenge. Absolutely, any program needs to participate in research locally and globally. We really learn from each other, and this is an essential element. You should consider how can you help train the next generation, because everybody gets older, and there are a lot of energetic, thoughtful young trainees that would love to have some direction from a cardio-oncologist. I would encourage you to get certified. I think it's, especially if you were finished with your fellowship before cardio-oncology really became an entity, then this is the way to show that you have had a commitment to clinical practice and that you have an important knowledge base to be a cardio-oncologist. And then lastly, your practice can become a center of excellence, and we're very interested in trying to help places that are truly committed in terms of showing evidence that they're a center of excellence. So I think that's my last slide, and thank you very much. Happy to answer any questions. And Dr. Ghosh, I don't know what you think about all that. I mean, you set up a program yourself, so I don't know if you would have similar observations in terms of what the challenges are.
Yeah, thanks so much, Dr. Linehan. Yeah, I agree. It's a challenging process, but of course does benefit our patients at the end of the day to allow them to continue their cancer treatment, complete their cancer treatment, and also manage them in the late effects setting. And I think I would probably just echo, of course, everything you've said, but you really do need local champions, one within cardiology and one within oncology, to kind of come together to set these services up. So we're just going to move on now to the question and answer section of the webinar. And we've had a lot of interesting questions come in, and I would be putting them now to Dr. Linehan, but I would please urge you also, while I'm asking the questions, to keep sending your questions through in the chat box below the webinar screen. Please refresh your webinar screen if you can't see the chat box. So let me start with the first question, Dr. Linehan. So this person asks, are there any stakeholders that should be engaged other than cardiologists and oncologists?
Yeah, that's a crucial question. And the answer is absolutely yes. The problem is that I don't know if that's exactly the same person at each location. But I can say from my own experience that you have to have practice administrators supporting you, either on purely administrative things like how do you get referrals into your practice. That's a relatively simple thing, but then also personnel. I had a clinic nurse, a nurse practitioner, we had some fellows. So we had a lot of people that are committed to this. And you're going to need the support of administrators in order to allow those personnel to interact. So sometimes, even just having an administrative team approve 1 to 2 years worth of salary for a nurse practitioner, for example, would allow you to really build your practice. And then after 1 to 2 years, maybe there could be some other cooperative arrangement that, you could be self-funding at that point. But, you may need some upfront support. Usually you do. And I think it's one aspect that I've not currently been able to achieve is to get a PharmD, committed to our team. And as you know, from how complex all these medicines are and what the drug-drug interactions, having a PharmD input is such a benefit. And I have not been able to arrange that, but I have colleagues that have, and of course they thank their lucky stars every day. So I don't know in your situation if you have PharmD input, because I think that's a really key element.
Yeah, so we do have some specialized cancer pharmacists who are interested in helping us with these patients. So that's definitely quite beneficial. And I think I know from the ICOS there is a group of interested pharmacists, and we also have some similar people in the British Cardio-Oncology Society as well. And I think just spreading the word amongst the interested pharmacists is very useful in that regard. And I suppose another group of people, Dr. Nellian, maybe the cardiac physiologists, those who are performing the echocardiograms. We do have interested cardio-oncology echocardiographers as well.
Yeah, absolutely. I think these, the imaging characteristics have become so complicated. I mean, I don't know how sophisticated you are in terms of reading echoes and all of that. If you are up to date on all of the latest software, I mean, I'd like to say that I am, but I think I would be lying if I did. And, I think I have had some personal interest in MRI, so I feel like I know some of those details pretty well, but I would still say that, the details of somebody who's been purely MRI trained, far exceed what I know. So I think that each of these areas have true experts, and they're not necessarily going to want to take care directly of, the cardio-oncology patient. So it's going to be up to you to navigate their expertise and improvement in your patient's care. So in that way, you're sort of like a go-between. But yeah, I think that facilitating those arrangements it's absolutely necessary so that you truly have, the best imaging characteristics you can get.
So I suppose also you would need to collaborate also with an interested local interventional cardiologist for the 5 FU cases and an interested EP cardiologist for the abrutinib arrhythmias and all of these things.
Yeah, I think it's much more complex than that. I think it's broader. As you are probably aware, and I don't know how much amyloidosis you see, but because I know London has a massive national amyloidosis center, but interacting with EP about specific cardio-oncology patients, whether to put a device in or whether to do a procedure, there's a lot of subtleties there. So you have to discuss with them, how to best navigate that. So I think in the case of cardio-oncology.
Sure. Just the questions you would like to ask.
Sure, sounds good.
Okay, please.
The pointer doesn't work. They haven't been using the pointer.
Oh, but I think that
I think
they
can't.
say that.
No, yeah, just describe the.
Well, just do we have a pointer that works on the screen, like for the audience to see? On the slides.
When you press that,
because this will just.
Yeah, there's something that comes up.
Do you want to see that?
But we'll see this.
We are streaming back to the studio.
No, but if we kind of use this pointer.
I use this pointer, the audience.
It's just light, isn't it?
Yeah, so we don't have a kind of pointer that we can use on the slide deck. Yeah, we'll just sure, no problem.
Okay. So you're going to presumably do a welcome and then hand over to
so I'll kind of
Razor.
do the kind of intro and then just basically introduce the two of you and then just kind of hand over. Hi, man. Yeah, ready to go? Hello everyone, welcome to this Radcliffe session from the ESC, and I'm live here at the ESC with our two chairs of the new cardio-oncology guidelines. It's been a momentous last few days in cardio-oncology, the first international comprehensive guidelines in cardio-oncology, and who better to take us through them than Dr. Alex Lyon from London and Dr. Teresa Lopez Fernandez from Madrid. Thank you so much for being here and taking us through the guidelines.
Thank you, and thank you for inviting us to present the new ESC guidelines on cardio-oncology. As you know, these are the first ESC guidelines on cardio-oncology, and for sure I'm sure that you are aware that this is a multidisciplinary teamwork, and we always, when we present the guidelines, we want first to thank all the task force members for the incredible work they did, as well as the reviewers and the ESC team that support us during the last 2 years. So this is the general overview of our guidelines. We include 272 new recommendations that are formed regarding the most permissible but also the most efficient cancer treatment. And we cover all these different topics in the guidelines. So guidelines provide new definitions and also strategies for personalize the prevention and the monitoring of different cancer therapies, as well as how to manage the potential problems that this patient could develop during and after the cancer treatment. And we also focus on how to organize the long-term surveillance of this patient and also on special population. So these figures summarize two of the key messages of the guideline. The first one is that the risk of suffering cancer therapy-related cardiovascular toxicities is a dynamic variable that changes through the pathway of care. And that's why we need to organize personalized monitoring during and after treatment. But the first step is to really focus on how to adjudicate events in cardio-oncology, and that's why we introduce as a first chapter in our guidelines the new international definition of cancer therapy-related cardiovascular toxicities that include also this new descriptive term of cancer therapy-related cardiac dysfunction. We try to describe with CTRCD the broad spectrum of heart failure symptoms that may occur in some patients. So symptomatic CTRCD means symptomatic heart failure, and we have different degrees of severity, and according to this severity we make appropriate treatment decisions. And we also have different degrees of asymptomatic CTRCD, that means asymptomatic left ventricular dysfunction, based on different cutoff of ejection fraction and ELS, and also on the increase in cardiac troponin. The first step when a patient has a new diagnosis of cancer is to try to stratify his or her baseline cardiovascular toxicity risk. And we need to use tools that manage all these cardiovascular risk factors and also previous cancer history and previous cancer treatment. And in the guidelines, we support the use of this Heart Failure Association and International Cardio-Oncology risk tool. These tools have been published a few years ago by these two societies and try to summarize for different drug classes what are the risk factors that are more important we need to consider. And when we feel these different performance that are now available at the ESC APP, you can establish a different level of risk of your patient according to the treatment he or she is going to receive. So after this baseline assessment, that of course include a clinical assessment, also an ECG for all the patients who are going to receive cardiotoxic cancer therapies, and other tests like echo or biomarkers according to the level of risk. So once you finish your baseline risk assessment, every patient fits in one of these three categories: low risk, medium, moderate, medium risk, or the high and very high risk. And that's the only way the oncology team can make appropriate treatment decisions. We can also educate patients to promote healthy lifestyle, and we need to educate patients on their own cardiovascular toxicity risk, because we need them involved during the treatment. And of course, we recommend different degrees of referral for patients. So we manage different protocols for monitoring of the treatment, and this is an example. This is anthracycline chemotherapy surveillance protocol, and as you can see, on the left the different risk categories, and according to these risk categories, we establish precise recommendation on ECG, troponin, echo, or in other classes of drug, other type of complementary tests. And now I'm going to hand over to Dr. Lyon, who is going to talk about the management.
Thank you, Teresa.
So I think it's important to emphasize that this is a guideline for the cardiovascular diseases in cancer patients. And so in the management of cardiovascular disease, we focus on where treatment decisions are different to patients without cancer, which are of course covered in other ESC guidelines. And the different factors you should consider for a patient with cancer, of course, is their cancer-related symptom burden and their cardiovascular symptoms, what their cancer stage and prognosis is, the treatments that they've been receiving, and potential future treatments, including non-cardiotoxic alternatives, the cancer drug, cardiac drug interactions, and we have an extensive list of those in the data supplement, and of course patient preferences. And we cover a whole range of the different cancer therapy related cardiovascular toxicities as summarized in this slide. Just to give one example, which is the management of trastuzumab targeted therapy and its related dysfunction, and this is relevant to all the HER2 targeted therapies. So once a patient has had the problem diagnosed, you'll see in the upper third of the algorithm, are they symptomatic or asymptomatic, and what is their severity as per the definitions that Teresa has just shown you. In the middle third of the algorithm are the decisions on oncology therapy. So severe cases, trastuzumab is interrupted, whereas we'd like to highlight in asymptomatic moderate CTRCD, where the ejection fraction has fallen to below 50%, but in the range 40 to 49, if the patient's asymptomatic, it's a class 2A indication to continue trastuzumab with close cardiac monitoring. And then in the lower third of the algorithm is the cardiovascular management plan. So patients with moderate or severe CTRCD, whether it's symptomatic or asymptomatic, should have heart failure therapy. That's a class 1 indication. And for mild asymptomatic CTRCD, which we see more and more with surveillance, if the GLS has fallen or biomarkers have risen, it's a 2A indication to start an ACE inhibitor or a beta blocker. And here are examples of the algorithms for anthracyclines, for Takotsubo syndrome, checkpoint inhibitor-related myocarditis. We also cover the very difficult topic of the choices of therapeutic anticoagulation for atrial fibrillation and venous thromboembolism, different cutoffs for arterial hypertension when it's caused by a cancer drug, and also QT monitoring and how to manage the patient on a cancer treatment who develops QT prolongation. A really important new area is a focus on an end of cancer therapy cardiovascular risk assessment. We've heard about it at the beginning. We now have introduced the concept of doing it in the first 12 months when the patient has completed treatment, because this will enable you to guide what their long-term strategy is. And here is a table of the risk factors for identifying people at high risk for future development. Now, another important topic is long-term surveillance, and we know that some patients develop their cardiovascular problems years after initial treatment. And again, we can divide the groups into low, medium and high risk, and this will guide us on the frequency of surveillance, for example with transthoracic echocardiography. And on the right you'll see we have risk factor groups both for the adult survivors of childhood and adolescent cancers, and below the risk factors for adult cancer survivors and who is high risk and needs this closer monitoring. And in the final clinical section, we also focus on some special populations seen in cardio-oncology services. That's patients with primary cardiac tumours, the valvular complications of carcinoid syndrome, cardiac AL amyloidosis in patients with multiple myeloma, and the group of pregnant women who develop a cancer during pregnancy that needs anthracycline chemotherapy. We also have these algorithms for identifying and how to manage patients who've got a cardiac implantable electronic device such as a pacemaker or defibrillator where they need radiotherapy that could interfere with the device.
So again, we just want to thank all the co-authors who've helped to build this guideline and worked tirelessly over the last 2 years, and we really hope it helps you in the management of these complex patients.
Great, thanks so much Alex and Teresa for that fantastic overview of the guidelines. So generated a lot of interest, there's been a lot of buzz here at the conference and also kind of online, so we've got a number of questions coming through. So first of all, we have a question from Irma Bisglia. One of the questions I have relates to the placement of biomarkers in class 1 in high-risk patients undergoing anthracycline treatment and the serial blood test required in each cycle as 1B. This can create a number of extra blood tests for patients. Do you have any comments regarding this? So maybe, Teresa, if I could start with you for this one.
Yeah, well, not sure that this leads to extra blood tests, because before each cycle of anthracycline, the oncologist did a blood test. So we just need to click the button of troponin or NT-proBNP. And we think, and reviewing all the literature, that biomarkers are quite cheap and quite easy to help the monitoring. Is it true that they are sometimes too sensitive, and we need to interpret the values in the clinical context of the patient? That's why it's very, very important to have baseline values, because if not, we cannot identify what really means increase in cardiac biomarkers. But especially for anthracyclines, and especially for patients who are going to start trastuzumab therapy and receive previously anthracyclines, there are a huge number of articles that refer that these biomarkers can detect mild asymptomatic CTRCD, and probably is to treat this mild asymptomatic CTRCD is the right way to prevent a serious event.
So, but I think it's an important message that although it's a class 1, don't bring people in for an additional blood test.
Yeah.
Take the opportunity when they're coming to the chemotherapy unit and getting their baseline bloods. And you don't delay the chemotherapy that day, it's how you interpret it for the following cycles.
And would you recommend that it's the oncologists who lead on this process, and tell the cardiologist if there's a rise or a problem?
Yes, I think for a lot of these guidance, particularly the baseline risk assessment and surveillance, all the patients are in the oncology clinic or hematology service. So we need to work with our hematology and oncology colleagues to educate them about the guidelines so they can implement the advice and the recommendations, but know what to do if a troponin value rises or if the GLS reduces. So they've got to be educated about GLS, a new concept often for them.
That's an interesting question. So we have a question on GLS, so leads nicely onto that. So is it possible to have an abnormal LV strain in oncology patients who have no other cardiovascular risk factors, and what would you do in that context?
That's a great question. I'm going to think about one of two patients. The first is the treatment-naive patient. So if you've got someone who is got no previous cardiovascular history, they're treatment-naive and their GLS is reduced at baseline, it still raises the question why in the context of a normal ejection fraction. And we know some cancers release chemicals that are potentially cardiotoxic, particularly some of the very metabolically active cancers. Acute leukemias, some of the very rapidly progressing lymphomas. So we do see cardiac dysfunction at baseline, and that patient is a higher risk. Then we also see the GLS falling during treatment, and maybe that's a different population where they've now had a delta change, and then the guideline gives advice about what to do with those patients.
Specific question on checkpoint inhibitors. Do you recommend any screening prior to starting checkpoint inhibitors for medium to high risk patients? Maybe, Teresa, if I could start with you for this one.
Yeah, well, in fact, we divide the population who is going to receive immunocheckpoint inhibitors in two groups, low and moderate risk and high risk. And is it true that when we compare with other cancer drugs, the definition of the high risk group is not so precise as in other scenarios? But for sure, patients at high risk are those with previous cardiovascular diseases, who are going to receive more than 2 drugs or 2 immunotherapy combination, who are going to receive at the same time chemotherapy, radiotherapy. So to have a baseline risk assessment of this patient is critical, particularly with biomarkers, because some of these patients have a high level or median increase in NT-proBNP or cardiac troponin because of previous history of ischemic heart disease, or just because they have a high cardiovascular risk. And if not, it's very, very difficult to interpret the results during the treatment.
So the guideline says everybody who's going to receive a checkpoint inhibitor should have an ECG and the troponin measured at baseline, and the high-risk patients get the echocardiogram. I think it's just so we know what's going on, and often these patients can have symptoms and they haven't really had the management, they've got a new progressive malignancy, so there's also the opportunity to help.
So I think one of the key things my take home from the guidelines is that a lot of baseline assessment for all cancer patients to just understand where we are before something happens. So how best to kind of manage this? Should we be doing it as cardiologists, or is the burden then on the oncologist? I mean, practically, how can we implement this?
So I think it depends what the components of the baseline assessment are. So we've got the HFA ICOS risk assessment. It's now actually in the app. So if the oncology colleagues and hematology colleagues download the ESC guideline app, they can have the interactive tool and in their clinic be able to calculate it. I think they can do ECGs, they can do the blood tests. We have to have a relationship so they can order echo rapidly. The first echo for a patient is a comprehensive echo because we don't know what we're going to find, and thereafter can be focused. So as a cardiology service, we've got to work with them to be able to deliver what they need, but some of this is their responsibility because we can't see every patient on these treatments. We need to see the right patients, which is where the guideline says it's a class 1 indication to refer the high-risk patient pre-oncology treatment. Of course, in the context that time allows, it's not an oncology emergency where they must start treatment.
There's an interesting question, maybe slightly outside of the guidelines but related. Should we be doing specialized cardiovascular safety RCTs with oncology drugs similar to those done with anti-diabetic medications? So a bit of a kind of, not a loaded question, but maybe relevant for future guidelines.
Well, I think my approach is if you don't know the cancer drug works, then it's not worth spending a lot of resources to do a safety study. So if the cancer drug works, then we need to think about how we manage that. In classes of drugs where we know there is a cardiotoxic signal and another trial's being done, the checkpoint inhibitors or a VEGF TKI and another treatment, it seems logical to do a cardiovascular safety sub-study and maybe something on everybody, troponin or ECG, and then a sub-study looking at advanced imaging that could then pick up where we have a true concern. But if it's a first-in-class drug, and these are coming down the pipeline a lot, I think we need to know they work on the cancer first.
So, Teresa, there's been a lot of talk about the late effects part of the guidelines, and I think a lot of people welcome this very much. Some of the questions that I've been hearing from general cardiologists is how can we fund such a service, and should it be cardiologists or should it be oncologists? So what are your thoughts on that?
Yeah, this is a really difficult piece to organize because we have a huge number of patients to manage, and of course, again, as during the treatment in the cardiology services, we cannot be the only ones who take care of these patients. So again, risk stratification at the end of cancer therapy gives us the clue which patient really needs a specific cardio-oncology follow-up that with the help of the oncologists, the hematologists, and also GPs, I think is the right way to organize the cardiovascular surveillance of cancer survivors, because we need to perform a yearly cardiovascular risk assessment, a standard cardiovascular risk assessment. And just in a few patients who are treated with a specific drug, we need other specific complementary tests. But what we need is to promote healthy lifestyle in these cancer survivors, because statistics give us high numbers of uncontrolled cardiovascular risk factor in this population. And the first doctor that sees a patient with poor control cardiovascular risk factor needs to go to deal with
And maybe it's that first year, the end of year assessment, they're still under the oncology clinic. So there we're liaising with the oncologist, but then there'll be that natural transition from oncology care, hopefully if they're cured, to the primary care, and the cardiology team has to then coordinate with both.
Okay. So there's a question now on 5FU. Asking any role for algorithms about heart failure and direct toxicity due to 5FU rather than ACS or ischemia.
So we do see this. I think we have not included an algorithm specifically because really there's no data out there as to A, how common is it, B, what should we do? It's very difficult, but we do see it in our day-to-day practice. But compared to the more vascular toxicities of the fluoropyrimidines, which are more common, so I think that is clearly in the area of the gaps in evidence. You know, we need future studies to provide the data so a future guideline can then directly address that. But we have not covered that topic really because there was very little in the literature and we didn't feel that that was a topic that we could include. But we recognise that patients do exist with it.
Great. So I think that that's most of the questions that have come through, and I'm aware that we're kind of coming towards the end of our time. So thank you very much for the presentation. Thank you for answering all the questions that came through. And maybe if I hand over to you, Teresa, to give your last take-home messages.
Wow. So maybe the key messages is that we need to stratify cardiovascular toxicity risk, and we need to work really close to the oncologists and the hematologists for this task, but patients are in oncology and hematology clinic, so we need to educate them, as Alex told you before, to try to organize good referral pathways to the cardio-oncology area. And another really key point that sometimes is forgotten is the re-stratification of the risk at the end of cancer therapy. So, because if not, it's really impossible to organize a comprehensive cardiovascular surveillance for these patients.
Okay. Thank you so much once again to Alex and Teresa for your very great work over the last so many years to get this to fruition, and hope the audience and most importantly our patients will benefit from the new guidelines. Thanks for joining us. Great, that's done.
Okay. Didn't need to do a take two then?
Well, I hope not.
Vansball, Associate Professor of Medicine and Cardiologist from McMaster University in Canada. And I'm absolutely delighted to have with me Professor Karthik from the All India Institute of Medical Sciences. And we are here at ESC 2022 to discuss his late-breaking clinical trial presentation of the Invictus trial. Welcome, Karthik.
Thank you, Harriet. Pleasure meeting you here.
Likewise. I'm going to start by asking you to give us some background so that our viewers can put Invictus in context of current knowledge about atrial fibrillation and rheumatic heart disease and anticoagulation regimens that have been evidence-based to date, and tell us what knowledge gap this trial fills.
So, as you know, rheumatic heart disease is a disease of poverty. It affects people mainly in low and lower middle income countries. And the problem with rheumatic heart disease as such is that these are young people who develop AF much earlier than non-valvular AF. They are at higher risk of stroke much earlier in life. And when they develop strokes, they develop large strokes, and it's pretty debilitating, and the subsequent burden and mortality is known to be high. So the second part of the problem is that the classic trials of anticoagulation in atrial fibrillation explicitly excluded patients with rheumatic heart disease, particularly the ones with mitral stenosis, because they felt at that point in time that these were patients who were at prohibitively high risk of stroke, and it was probably unethical to randomize these people. So as a result, you had the first trials of VKAs versus placebo, from which RHD patients were systematically excluded. And then subsequently, when the DOAC trials were done against VKAs, because these were non-inferiority trials, they again had to exclude patients with rheumatic heart disease. So as a consequence, you have 0 RCTs for patients with rheumatic AF in terms of stroke prevention. So this is a very big knowledge gap. And the third point is that as a result of all this, treatment of patients with rheumatic AF is empirical, and people give VKAs in developing countries. But the biggest challenge with using VKAs, as you all know, is the INR monitoring. And INR monitoring is very challenging in developing countries. And data suggests that about just half the patients who are eligible for anticoagulation go on anticoagulation with VKAs. And even among those who are on anticoagulation, only about a third maintain an INR in the therapeutic range. So it's pretty dismal. And so we felt that, if we used an anticoagulant which does not need monitoring, and if we find that to be effective, this would be of great benefit to these patients.
So tell us about your trial design and how you tackled the question, your research question.
So our research question was pretty simple. The question that we asked was, is rivaroxaban non-inferior to vitamin K antagonist dose adjusted for, as originally planned, reduction of stroke or systemic embolism? We did this trial in about 24 countries, 138 centers around the world, all in the RHD endemic countries. So we have most of the patients coming from Africa, the Middle East, South Asia, some other parts of Asia as well, including China, and then also Latin America. So we have about 24 countries participating, and we recruited about 4,500 patients. The dose that we used was pretty straightforward, 20 milligram per day of rivaroxaban among patients with normal renal function. Anybody who had a calculated creatinine clearance less than 50, we used the 15 mg dose. And we used, for the purposes of VK, any locally approved VK in all these in these participating countries. So most of it was warfarin, and about 15% was acimacimorol. So very standard, straightforward treatment. And we encouraged INR monitoring in patients who were on VK, and we tried to bring it up. This was a non-inferiority trial, so we needed to make sure that the control arm was treated well. Otherwise, it would have affected the integrity of our trial. So we did that with a simple algorithm which suggested a 10% dose increase or decrease every month. So that's how we went about it.
And what were your inclusion and exclusion criteria?
So we included patients who had echocardiographically proven rheumatic heart disease with documented atrial fibrillation or flutter. In addition, we required that, because these patients are very young, we required that they needed to have at least one additional risk factor for stroke. So the two most important ones were the presence of moderate mitral stenosis, which we defined as a mitral valve area less than or equal to 2 centimeters square, or a CHA2DS2-VASc score of 2 or more. So these were the two primary inclusion criteria by which patients qualified to enter the trial. Of course, if they had left atrial thrombi or if they had spontaneous echocontrast, they could also enter the trial because they were considered at higher risk of stroke. So these were the primary inclusion criteria. And so our primary outcome, like I said, was initially stroke or systemic embolism, but then during the course of the study, we noted, blinded to the treatment allocation, that our event rates were very, very low. The stroke event rates were very low. And the deaths were far higher, about 6 to 7-fold higher. So these were sick patients the patients who were at risk of stroke were also dying. So we were unlikely ever to reach our primary endpoint as we had originally planned. So blinded to the treatment allocation, treatment arms, the steering committee decided at somewhere in 2020 to expand the inclusion, the outcomes to a larger composite, which included MI and deaths of vascular or unknown causes. So the final composite that we've analyzed and presented is a composite of stroke, systemic embolism, myocardial infarction, or deaths due to vascular or unknown causes. This is quite similar to a previous trial, an old trial, which was led from PHRI McMaster, which was the Active W trial. They used a similar composite at that point in time. That was also a AF trial. So that's our modified composite outcome.
Right, and important to mention, as you did, that you were blinded to treatment allocation when you had this change in protocol. Tell us about the baseline characteristics.
Yeah, so in summary, there are 4 or 5 important things that we need to remember when we look at the patients who were recruited into Invictus. First of all, they were young patients, average age of about 51. This is about a decade and a half or 2 decades younger than the regular non-valvular AF patients who've been included in these DOAC trials, for example. The second thing is there was a female preponderance. About 70% of patients were female, and this is very much in sync with what the prevalence of RHD is among females. So that is one thing which is very different from non-valvular AF. The third thing is 85% of patients had moderate mitral stenosis. And out of these patients, about 2/3 had severe mitral stenosis as defined by mitral valve area less than 1.5 centimeters square. So these were patients predominantly with mitral stenosis. The fourth important thing was that the conventional risk factors for stroke, atherosclerotic risk factors like hypertension, diabetes, or coronary artery disease, was infrequent in this population. So as a consequence, you have about 45% of patients who have a CHA2DS2-VASc score of either 0 or 1. So in terms of stroke risk, this is not conventional, by conventional metrics, this is not a high stroke risk population.
Right.
So, yeah.
Okay. And what were your event rates in the control group?
So the stroke event rates, so overall the stroke event rates were about 1%. But the overall event rates for the primary composite is about 8.5%.
Okay.
So,
and what was the follow-up duration?
So we had about 4,531 patients followed up for about an average of 3.1 years. Okay. We had excellent completeness of follow-up. We had about 97% full follow-up. Remember that this whole trial was done in very poor countries where it was pretty challenging, and we also had to go through the COVID pandemic. So despite that, we achieved an excellent rate of follow-up in these patients. And so at the end of 3.1 average years of follow-up, we are now, we have a
ready to give the results away. But before you do that, tell me about the INR achieved in the group that was on VKA therapy.
So there are 2 aspects to it, right? So in the study drug, rivaroxaban, the compliance rate for rivaroxaban, rates of complete discontinuation, permanent discontinuation at the end of trial was about 23%, which is in the ballpark for all the other DOAC trials. So there's nothing alarming about that. So this is what is typical. On the other hand, patients on VKA had an excellent compliance. So typically in the DOAC trials, the rate of permanent discontinuation was similar in both arms. So about 20% of patients at 2 years typically go off the trial. But in Invictus, in the VKA arm, just 6% of patients were off drug at the end of study, and at the end of 3.1 years of follow-up. So that is a pretty remarkable achievement for a trial done in developing countries. Patients were on VKA.
And why do you think there were these different rates of adherence to the drugs across groups?
I don't know.
Okay.
I don't know. Frankly,
not any adverse effects or intolerance?
One thing that could have contributed, it did contribute to a little bit of that, is that these were sick patients. They went on to have valve replacement surgeries with mechanical valves during the course of the study. So about a third of patients who discontinued rivaroxaban permanently did so because they had to get mechanical valves.
So that accounts for,
yeah, so that accounts for about a third of these patients, but the remaining patients, most of it was patient decision why they stopped. And before we go on, I just need to also mention that the INR control in the VKA arm at baseline was as expected about 30%, 33%. That is, the proportion of INRs in range at baseline was about 33%.
So TTR.
So we looked at the proportion of INRs in range. So that was about 33%, which was expected. That's usual practice, like I said in the beginning. But over the course of the study, by the end of 2 years, we had reached proportion of INRs in the range of 65%. And that was maintained throughout the study. And so this is in sync with all the DOAC trials which were done in high-income countries. So we did a good job with INR monitoring as well.
Fantastic. And your analytic plan was intention to treat
Yes.
the primary analysis.
Yeah.
And so tell us what the results were.
So at the end of 3.1 years of follow-up, the primary outcome occurred 25% more frequently in the rivaroxaban arm than in the VKA arm. So the hazard ratio was 1.25 with fairly tight confidence intervals and a very low p-value. So this was a very surprising result for us. And for those of you who will read the paper in the New England, so the curves, the Kaplan-Meier curves actually crossed over. So proportional hazards assumption was not met. So as a result, we had to do a restricted mean survival time analysis. Basically, the restricted mean survival time gives us the cumulative time till the primary event occurs. So the difference in the restricted mean survival time is a good way to analyze when the curves cross over, when the proportional hazards assumption is not met. So by all accounts, this was a statistically significant robust result. So there was a 25% increase in the risk of the primary outcome in patients on rivaroxaban when compared to those on VKA. And most of this, I would like to say it the other way. So VKA reduced the rate of the primary outcome among patients with rheumatic AF because the overall event rates were similar to our previous experience with rheumatic heart disease patients in the ballpark of 8% per year. So that's what we got. So and most of the difference in the primary outcome was driven by death.
Yeah.
And in fact, the overwhelming proportion of the primary outcome was death. So we had over 990 deaths in the study. And that also showed a 25%, 23% increase in the rivaroxaban. So VKA is somehow protected against death.
Fascinating and, as you say, unexpected results.
Very unexpected.
Did you do a sensitivity analysis focusing on those patients that remained adherent to
So we did an on-treatment analysis, which looks at patients who received at least one dose and in the next 5 days. So we analyzed outcomes. So there was absolutely no difference. It was pretty much consistent. The results remained the same. It was a very robust result.
Okay.
And in terms of the stroke outcome, we had, as expected, fewer stroke events than we had originally planned. The ischemic stroke rates were lower with VKA when compared to rivaroxaban. But overall, the stroke or systemic embolism composite was not different between the two groups. And there was no signal of safety at all. Both the drugs were extremely safe. There were only about 90-odd major bleeding events in the entire study. So, and there was no statistically significant difference between the two groups.
And I suspect that the rates of valve replacement were the same across groups?
Yeah.
Okay. So a large trial, well executed, primarily in low and middle income countries that bear the brunt of the burden of rheumatic heart disease. Tell us about the challenges of implementing a clinical trial in low resource settings and any particular challenges you had related to the COVID pandemic.
Oh, yeah. So I think here, PHRI is a very experienced group of people who have done these trials in low and middle income countries for a long time now. So they have all the resources and they have the experience, and they've done these trials for maybe more than 20 years now. So that's the biggest advantage that we had in terms of experienced people like Dr. Yusuf and Stuart Connolly and others at the PHRI. So that's number one. And the second thing is we had great national leaders across the world, people who were really interested in rheumatic heart disease and who went out of their way to sometimes recruit patients, follow up patients, because some of these countries had local strife and things like that, and they were able to recruit and follow up patients. And COVID didn't help at all.
I'm really glad that we've had a chance to discuss this trial.
It's been a pleasure.
I hope our paths cross again, and I will come to your presentation this week at ESC.
Absolutely.
Thank you for being here.
Thank you.
I'm Harriet Vansball, Associate Professor of Medicine and Cardiologist Researcher from McMaster University, and I'm absolutely thrilled to have with me Professor Milton Packer, a distinguished scholar in cardiovascular science at Baylor College of Medicine in Texas. He is a clinical trialist who is well known across the world, and his work has transformed the way we provide care to patients with heart failure. It has also shaped the way we think about clinical trial design. We are here to talk about his career, his life, and lessons he has learned across his career journey. Welcome, Professor Packer.
Thank you so much. I'm really delighted and so honored to do this with you, Harriet. This is really special. Thank you.
I'm delighted. I'm going to start by asking you to talk about your early formative years. Would you tell us about your family, your early life experiences, and what shaped your interests and character?
I have a somewhat miraculous family history. My parents were Holocaust survivors. And in 1941, 42, they were in the Vilna ghetto. And most of the Jews in the Vilna ghetto were scheduled for extermination. And in fact, of 100,000 Jews in the Vilna ghetto, there were only 1,200 Jews that survived the war. My parents survived the war because a Nazi major provided them very kindly with false work permits. And that's how they survived the war. They emigrated to the United States in 1947. And I was the only surviving child in the family. My siblings had died in the war. And so you can imagine the enormous expectations that my parents had for me. Their seminal thought was that their emigration to the United States was a special event, that their survival during the war was a miraculous event, and that it was really important for me to do things that were above and beyond what their expectations were. This was a really deeply held family value. The goal was to do special things. And the goal was to somehow make sure that the horrors of the war actually had yielded something, an opportunity that was unique. I grew up with that. I felt it all the time. My parents never, ever spoke about their experiences during the war, but it was really understood in everything that they said and did, that it was important to make sure it never happened again.
I cannot begin to imagine what those years were like for you and for them. But what shines through is the experience of those who have lived through persecution and adversity and injustice, and how that shapes one's character and determination and drive. What lessons did you take from those early years and the experiences of your parents that have shaped you into the person that you are?
When you're a child, you don't spend a lot of time thinking about lessons. When you're a child, you're just a child. When my father was a tailor. He was a tailor because he was a carpenter in Europe, but carpenters were unionized in the United States, and the unions wouldn't allow immigrants into the union. So he had to do something different. He had to become a tailor. I wasn't really convinced he was a very good tailor. I think he was probably a much better carpenter than he was a tailor. But I learned that he was so determined to adapt. It was so important for him to make the most of opportunities that he didn't think were possible. And so I was in sort of imbued with this sense of making the most of opportunities. When life is kind enough to give you an opportunity, you need to do something about it. You can't say, no, I'll wait for the next opportunity or the third one. Well, yeah, you could do that, and maybe there will be a second and third one. But it's really important to capitalize on the gifts that life presents. If you can do that, you won't be sorry.
Right. I could see how the past journey has shaped that hunger and drive to excel and to capitalize on every opportunity. One of the other things that is very striking about you is the way you think. You have this great clarity of thought. And I wonder if you could name a person who you admire or who mentored you, but who also shaped the way you think.
There's so many people who shape the way I think. There are too many to mention. I think that the most important thing, the most important principle is never assume that what you are taught is correct. Never assume that the status quo represents the truth. The status quo represents some truth, some fiction, some storytelling. The worst thing that someone can do is to spend their time reinforcing the status quo. There are enough people who do that. The goal isn't to keep the status quo as it is. Can you imagine how awful society would be, how backwards we would be if we just kept everything the same? So the goal is to change things. And the only way you're going to change things is to say, well, the way things are they're either not good enough or they're not right. So I always, when I was in school, I was always told to question what I was taught, even by the teachers who taught it to me. So that was amazing. So all through my education and my training, my tendency was always to think of things differently. Sometimes you would think of things differently and you would say, okay, well, the status quo is correct. But so many times you would say, God, the status quo is based on assumptions that have no evidence behind them. Just suppose we made some different assumptions. What would the result be? And it's joyous to do that. It's so much fun to do that. But in all honesty, you can typically do that best when you're young. I always tell young physicians and young cardiologists that if they want to succeed, they need to challenge the status quo, not reinforce it. It's often an advice that young physicians get. Well, when you do your first research paper, do something safe. That way, no one will be mad at you. Well, if you do something safe, maybe no one will be mad at you, but no one will notice you. No one will pay attention to anything that you've done because all you've done is reinforce what everyone already knows. So the goal is to think of things differently. The first paper I ever wrote was in 1978. I was still a cardiology fellow. And vasodilator therapy for heart failure was just emerging as a concept. And I wrote a paper that questioned the efficacy of vasodilator therapy in heart failure. I was a second-year cardiology fellow. And because there were assumptions in that field that actually turned out to be wrong. But the goal was to call attention to them and to then do the work that tested whether the assumptions were true or not.
And is that how you ended up leading clinical trials?
I didn't lead clinical trials for a long time. I spent the first 10, 12 years of my career doing mechanistic research. Most of the work that I did in the first 10 to 12 years looked at the mechanisms of heart failure progression, hemodynamic determinants, vascular responses, vascular reflexes. I spent my time taking every patient with heart failure who was referred to me and taking them to the coronary care unit and performing hemodynamic measurements over long periods of time, 3, 4, 5 days, because I wanted to understand heart failure. I wanted to understand what it was. Why were people different? How did people respond to drugs? What determined that? And most of the work at that time, I was entirely supported by the NIH for the first 12 years or so, and I started doing work with various drugs because they turned out to be a tool for understanding mechanisms in heart failure. They didn't really think of drugs as a therapeutic tool as much as it was an experimental tool, a way to understand what heart failure was. I didn't get into clinical trials until about 10 years into my career. And that was largely driven by the fact that in 1986, much to my surprise, the FDA asked me to be a member of the Cardiac and Renal Drugs Advisory Committee. It's a committee that reviews most new cardiovascular drugs. And it was at that time that I learned about clinical trials. I learned about clinical trials from wonderful people at FDA, regulators, physicians, scientists, statisticians, who taught me so much about clinical trials during the course of my appointment at FDA, which, by the way, still persists to this day. I've probably reviewed 1,000 clinical trials, and you learn principles. You learn, gee, what kinds of designs are likely to be unbiased? What kinds of designs are likely to yield results that are replicable? What kinds of designs get you into trouble? And I started writing about that, talking about that. And then industry took notice and said, well, you have some interesting ideas. Would you like to look at our drug? And believe it or not, one of the earliest trials I did was with a drug called milrinone. It was a positive inotropic drug. I had written extensive negative papers on positive inotropic drugs. I had said that I really thought that they were worrisome, that they accelerated the progression of disease. And so when the sponsor called me and said, would you like to lead our trial? I said, you must have the wrong number. You're asking someone who really does not have fond feelings about your drug to lead your clinical trial. And they said, that's why we're asking you. Because if you lead the trial and you say that there's a positive result, that will mean something. And that was one of the earliest trials that I led. Most of the other trials that we moved from Mount Sinai to Columbia University in 1992. I had at Mount Sinai, I had a very small group of people. Myself and 2 wonderful research nurses and a couple other people. Columbia University in 1992 said, we want you to establish the first dedicated heart failure program in the United States. And we did. We established the first multidisciplinary, broad-based heart failure program in the United States. Columbia actually carved heart failure out of cardiology and made us a separate division. We were called the Division of Circulatory Physiology. And over a period of several years, we recruited more than 20 faculty devoted to heart failure. Now, at that time, that was a gigantic program. We would get referrals from 7 states. Admittedly, there were small states in the Northeast, so, but there were a lot of people. And we recruited some wonderful, at that time, young, bright, really innovative investigators, almost all of whom have now moved on and established their own programs. They're now leaders in the field. They've changed heart failure in wonderful ways. I'm so proud of them. There is nothing happier, more joyous than to have academic children. Here's the definition of an academic child: someone who you have spent time with, and it goes beyond mentoring. It is someone you've spent time with, who you've embraced, who you've said, spend time with me, I will share with you what I know and what I value. And you will take from that, put it together with your own talents, your own aspirations, your own view of the world, and you will create something new.
Right.
And then you'll go someplace and make me proud.
You describe the pride and investment of a great mentor very well. And I want to ask you whether you think that the opportunity to be mentored is offered equally to people across demographic groups. Why is it that the face of clinical trial leadership, particularly in our landmark trials, appears rather homogeneous? And what do you think we need to do to diversify the clinical trial enterprise?
So you're 100% right. It's incredibly homogeneous, embarrassingly so. When we established the Division of Circulatory Physiology, I have to tell this, it was the second largest division in internal medicine. And in 1992 at Columbia University, every division, every member of the faculty in internal medicine had, with a few exceptions, every subspecialty had about 85% men. Circulatory physiology, the heart failure division, had about 65% women. People would ask, why is your division different than all the other divisions? And Harriet, I know you're going to think this is funny. I said, I never noticed. I just got the best people. Gee, 2/3 happen to be women. That's nice. But the reason that we are in the state that we are now is because clinical trial leadership is a repetitive process. People who have done clinical trials are invited to do more clinical trials. Well, if we had predominantly men 20 years ago, well, that's carried forward one generation of trials, another generation of trials, another generation of trials, and we end up having this same leadership that we've had before. We need to change that.
Yes, absolutely. And we've done some analysis that demonstrates
Yeah,
that
I know.
mentorship and sponsorship seems to occur across gender lines. And we're trying to change it. But research environments can be inhospitable to diverse ideas. You talked about the importance of disruptive thinking and innovative thinking. And some of those tendencies are rewarded in certain groups and penalized in other groups. So I think part of what we could potentially tackle is, yes, those we recruit, those we retain, how we mentor and sponsor people and choose the people we mentor and sponsor, but also the cultural aspect of academic medicine that in some centers could really penalize differences, different ways of thinking, and any deviation from what's considered normative.
Well, it's so interesting. One of my fellows at Mount Sinai was Roxana Marin, and she was so really innovative, thoughtful, and we spent so much time. She gives me undue credit for helping her, because her success is driven by her talents, her innovation, her thought process. But it's really interesting. There's always been a bias. Can I tell you a story that illustrates probably the best example? In 1992, I was recruited to Columbia University, as I said, and Mike Weisfeld was chairman of medicine. Mike was a wonderful chairman of medicine. And to recruit me to Columbia, they put together a wonderful recruitment package. I was really delighted. A lot of resources, a lot of money. And at the time, I had decided to, Beth and I had decided to get married. Beth was finishing her postdoc and fellowship at Johns Hopkins in Baltimore. And in order for us to start a family, she needed to move to New York. Well, that means she needed a job in New York. I went to Mike Weisfeld. I said, Mike, I'm getting married. It would be nice if you were to find a position for Beth. Mike was so upset. He said, we've been negotiating a package for 10 months, and right before you sign, you tell me that you're getting married? I said, well, I am getting married. Maybe you should meet her. And so Beth and Mike met, and he said, okay, I will give her a faculty appointment, and I'll give her a recruitment package. Beth comes home and she says, I'm going to be a member of the faculty at Columbia. I have a recruitment package of $20,000. I said, what? What can you do with $20,000? I said, please go back to Mike and tell him that that is an embarrassingly low recruitment package. And Beth said, I'm not going to do that. I said, it's an embarrassing, I will call him and tell him that's an embarrassing recruitment package. And she said, nope, you're not going to do that. I'm going to show them what I can do with $20,000. Well, fast forward, over the next several years, she got 5 NIH grants. I don't even think she ever used the $20,000. But I have a feeling that in that time, Beth's entry into medicine would have been easier if she were a man and not a woman. And I think to some very meaningful degrees, those biases, they continue. There is not equal opportunity. There isn't equal mentorship. That is a problem that we need to address. I like to think it is happening slowly, but Harriet, I'm not so sure. I don't know if we're doing enough.
Yes, I would agree with you. I think that the ongoing research networks and even the pipeline of sponsorship and the new era of clinical trialists demonstrates that we have quite a journey to embark on before we work in an equitable environment and build equitable networks that allow the same opportunity for all to succeed. I think what's particularly concerning is that even the younger investigators seem to have the same old networks that they're coming through the pipeline to lead, and it leaves little room for others who might be equally capable. And so,
yeah, Harriet, I'll tell you what the real deficiency is. It's not talent. It's not drive. It's not innovation. The current group of clinical trialists have an experiential body of information that, in all honesty, is not really written in the literature. It can be only transmitted with direct interactions with people on an ongoing basis. We really need to be proactive in transmitting this information. We're not doing a great job. We are not doing a great job. And I and many others are terrified that as we get older, and we do, that many of the lessons of how to really run a clinical trial, I don't mean write a protocol, I don't mean publish papers, but really run a trial and how to interact with sponsors and how to reinforce the concept of academic independence. Those lessons are not being transmitted, and they have to be.
right, and they're not being transmitted, and they're not being transmitted equitably because there are too many closed networks and informal mechanisms to get ahead. And we need to open up those opportunities. I want to switch gears a little bit and tell you that I've admired your academic work for years and your contributions. But I really became a fan when I read your tribute to Beth, who was an accomplished scientist and who you regarded your intellectual equal and perhaps even a source of inspiration. Tell us about her.
So Beth wasn't my intellectual equal, she was my intellectual superior. There's a famous story. When we moved to Dallas, our kids were 9 and 10 years old. And I guess at that point in time, it was fashionable for children to get up in front of the class and tell the class what their parents did for a living. My son, who was 9, got up in front of the class and he said, you know, I really don't know what my parents do for a living. They're both physicians, but they do something called research, and I really don't understand what that is. But he says, all I know is that my daddy is smart, but my mommy is really smart. That's a true story. Beth was she was brilliant. She was the founding. She founded the field of mammalian autophagy. She was a Howard Hughes investigator, member of the National Academy. When we moved to Dallas, University of Texas Southwestern recruited her. I was the trailing spouse. They had to find a job for me. Okay, they made me department chair, but that was not the reason we moved to Dallas. We moved to Dallas because they wanted her. And that was the driving principle. It was a driving principle for our children. Our children grew up in a household where there was no difference in expectations between my son and my daughter as to what they're supposed to do in life and what they're supposed to do. By the way, our primary endpoint to them was be happy. Our secondary endpoint was do good. You can switch the primary and secondary endpoint if you want. It sort of depends on the person. It's the only 2 things that matter. Beth was.
I think they're good composite endpoints. They go.
Yeah, they're good. Yeah, you can put them together and you know, somehow combine the 2. Yeah, sounds like a great idea. We should do that. So she was just she was just amazing. She changed everything in cell biology. But it was so funny. We worked in totally different areas. And we had, before we send a paper out, we had the other person read it. Because, and even though in all honesty, if I would read one of Beth's papers, I really understood about 5% of it. I moved some commas around just to pretend that I had read the manuscript. But that was the kind of interactions that we had. We wanted to make sure that the other person knew that we cared about their success. This is really important. Marriages are really are complicated. Commitment to another person is complicated, but here's the secret. You have to be the president of the fan club for your spouse. You have to be their number one cheerleader. You have to celebrate their successes as being as important, if not important, more important than your successes. Because if you don't do that, that's not a partnership. So that was a driving principle. I was not only Beth's husband, I was the president of her fan club. And that was, gosh, I was an incredibly fortunate person. She had a profound impact on her field. She had a profound impact on my life. And she has given such a wonderful legacy, not only to her mentees, but to our children. So what else can I say?
A testament to your love for each other. How did you manage raising children whilst navigating your excruciatingly busy careers?
We had some basic rules. It was very easy. Rule number one, you have dinner together every night, without exception. No one works late. If you want to work late, you first come home, have dinner, and then you can work afterwards. So no one ever missed dinner. Very, very important principle. Dinner is a time when families bond, when people tell stories about their days, when people, learn about what values they might consider or should have. So never miss dinner. My second rule is make sure that you are deeply involved in what makes your children happy. Here's my personal thing. One of the most fun things that I did was coach Little League baseball. Now, I will tell you, Harriet, I never personally played baseball, but I had this incredible fondness of the sport. And when we moved to Dallas, they were looking for a coach. I volunteered to coach Little League baseball. And in Texas, because of the weather, we play baseball twice a year. We play it in the spring and in the fall. Too hot to play it in the summer. And so I coached baseball. My son was a left-handed pitcher. And but during the time that I coached baseball, I had 13 sons. 13 sons. They all played for the same team. Gosh, that was magical. And Harriet, Beth and I, we never, ever missed a game. We never missed a game. Oh, I'm sorry. One time, I was presenting the primary results of a clinical trial at an American Heart Association meeting, and my son was pitching on the same day, and I couldn't be in two places at the same time. So what happened was that I called in and I asked Beth to tell me about every ball and strike during the entire game. By the way, when you ask someone to do it, you really ruin the game for them. So never ever really ask them to do that. But we were so involved. My daughter played basketball. We went to every single game. We rejoiced in our children's accomplishments and achievements. And because of that, we became an incredibly close-knit family. Remember, career, it's nice. Cardiology, well, it's a wonderful passion. Family is 10 times more important than all of that. It's family, 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 cardiology, maybe? I don't know. I'm not so sure. So you have to get your priorities right. If you don't get your priorities right, you're going to find yourself to be a very accomplished but lonely person.
Mm-hmm.
That's not a life.
Right. You grow what you invest your time in.
And
it's a struggle for people in their early and mid-career stages when trying to build a career without adequate support, institutional support, that makes them overinvest in the career aspect and sacrifice some of the more important priorities in life, thinking that they can catch up.
Remember, Harriet, I grew up in cardiology during a magical time.
Mm-hmm.
I grew up during a time when programs actually did not account for every 15-minute interval of a faculty's time. If we wanted to take an afternoon off and think, we could. If we wanted to explore, spend time in the library and read, we could. If we wanted to pursue something that was really interesting, the institution allowed us to do that. But medical schools now have become businesses. Their business product is not research. Their business product is not career development. Their business product are revenues and their bottom line. And the faculty represents simply we're subcontractors. We're just mechanisms of generating revenue. That's not the way cardiology was when I grew up. So, Harriet, I grew up at a different time.
Mm-hmm.
I grew up at a time when what I decided to do could be done. I don't know whether if I had to do it all over again, starting right now, whether it would be possible.
Yeah, there are unique challenges in each era, but I think your points are timeless and universal. I want to ask you what you learned about illness and loss as a husband that you did not know as a physician.
The loss is incalculable. When you lose a loved one, you haven't lost a person. You've lost a partner, a soulmate, your best friend. you've lost the driving purpose for living. How do you replace that? You don't. The goal is that you don't try to replace it. You celebrate it. You're not happy that you've lost it, but you honor it. You ensure that it lasts, that it's durable. One of the things that we're doing, I've been raising money for the last year, and University of Texas Southwestern is going to establish a prize in Beth's name. Believe it or not, there are very few medical schools that give prizes. We've raised enough money to establish a prize in perpetuity. There will be a awardee of a Beth Levine Prize every year, forever and ever. But that's just a part of it. You remember that the secret to life is not only to live it, but the real secret is there are paths to immortality that we don't appreciate. Immortality is achieved through our work. Immortality is achieved through our families. Immortality is achieved through our mentees. Immortality is achieved through the way we change the world. And that doesn't stop when someone dies. The goal is to keep reinforcing those values, those legacies, those memories. And if you do that, then there's immortality. Then life really has meaning. And then what you've essentially been able to do is partner with someone and realize that together you tried really hard to make the world a little bit better. And maybe you succeeded.
Yeah, those are powerful messages. I can't think of a better way to end this conversation.
You know what's wonderful, Harriet? I want to say just an observation. You've given me a wonderful privilege in asking me to do this. You've allowed me to tell my story. Most people never get a chance to tell their stories. But here's the thing that's really amazing about our conversation. We didn't talk about heart failure at all. We didn't talk about a single drug, a single trial, a single paper. You never asked me about a presentation. You never asked me about anything I have done professionally. And I am so grateful to you about what we have talked about, because what we've talked about has so much more meaning than what we could have talked about. You know, I get to talk about my papers and presentations all the time. You gave me a chance to talk about my story. and my story doesn't have anything to do with my papers and presentations, or my trials, or anything to do with heart failure.
It was my honor to be here, to spend this time with you, and to get to learn who you really are. Thank you for the generosity of your time, for the openness with which you spoke to me, and for giving us wise words to live by. I think that your advice is timeless and important, and I'm just really grateful to you for saying yes to this invitation, Milton. And I hope that we have another chance to talk, because I know there's so much else we could talk about. So just thank you so much for your time today.
Thank you so much. I really appreciate it. I am deeply appreciative of it.
I'll talk to you again, Milton. Bye.
Talk to you soon. Take care. Bye.